Hey, good morning, everyone. I'm Lynn Morski. I'm really excited to be here with you. Sorry, it's virtual. I am probably asleep in California at this time while you're watching this, but really excited to be here, at least virtually with you. And at the end, I'll give you an email that you can contact me if you have any questions. But excited to start off this conference for you all. So let's go ahead and flip over to Keynote and get this going. All right. Today, we are going to talk about what doctors and you future doctors need to know about psychedelic medicine. So as you may be wondering, and especially if you're looking into the possibility of working in psychedelics yourself, who I am and how I got to where I'm speaking with you today. My initial path is a little different. I started off as a multimedia designer, but then shortly after that went to medical school. And then I did residency in family medicine, and I did my fellowship in sports medicine. And after that, I wasn't loving the traditional practice of medicine, so I went to law school. So how old am I? The picture at the top is of me in law school graduation, because there are no digital pictures of me from medical school graduation, if that tells you when that took place. So there I am, 2014, graduating from law school. After that, I taught health law for a bit. And the entire time I was working, the entire time I was in law school, and ever since fellowship, because I decided sports medicine was not for me, I was working at the VA in a department called Compensation and Pension, where veterans come in, we do an exam, they get benefits. I wasn't making them better or treating anything. It was just kind of doing an exam, and then they would go on and get benefits for what injuries or illnesses they had incurred in the military. So I did that for 9 years. Now, in that time, you should know that I was raised in a very conservative family in Southern Illinois. I did not drink till I was like 26. I had not had cannabis until like 35, because by that time I was working for the Department of Defense, and they said they could drug test me at any time. So hadn't had any cannabis before, wasn't going to have any now. And I had absolutely zero experience with psychedelics. I had not been a rave kid. I was literally just kind of like the nerdiest kid you knew. So just no experience with any of these altered types of substances. Then in 2013, that changed. I had my first experience with both cannabis, which is not necessarily my medicine of choice. But then I also had my first experience with psychedelics. And at the time, I did not know psychedelic science was a thing. And so when I had like great therapeutic realizations on LSD, which it was, I thought, wow, that's really interesting. But, oh, it must be an isolated incident, we living in our own heads. Had never talked to anybody else about it. And I did a few other isolated psychedelics over the years. Every time had some great insights. And then in 2017, I heard a podcast, I believe it was Tim Ferriss, where somebody from MAPS was talking about MAPS being the Multidisciplinary Association for Psychedelic Studies. They were talking about psychedelic science. And I thought, oh, this was not an isolated incident. This is an entire field of study. And maybe I should look into it. And so in 2019, at this point, I've worked for the VA for 9 years, seen about 9,000 veterans. And if you can imagine, for the past number of years, I've been hearing about how psychedelics can help veterans with a lot of the things that I'm seeing that they've encountered, right? PTSD, traumatic brain injury, anxiety, depression, suicidality, military sexual trauma, all the above. I'm seeing patients every day that have these, and I can't tell them about them because as a Department of Defense employee, that was not allowed. I couldn't be doing these medicines, much less perhaps recommending that these patients do them themselves. So in 2019, with no backup job in May, I quit the VA and made it my mission to spread the word of psychedelics to other clinicians. Because as you know, we can spread something to patient by patient. Or if you educate one clinician who sees maybe 100 patients a week, then you've really like expedited the education and the help to that patient population. So first thing I did is I started the Psychedelic Medicine podcast, which was called the Plant Medicine Podcast at the time. And then that was the way I was going to educate clinicians. Now, as you probably know, that's not where clinicians get their information, right? Like, especially when you're busy, you're seeing all these patients a day, you're not like, okay, how do I fix depression? Let me listen to a 45-minute episode about it. No, you want what's easy in your inbox. What can I read in 2 minutes? Look at the abstract. Okay, that works. So that's why I founded the Psychedelic Medicine Association, so that we could get clinicians and trainees and medical students to come in, and we would send them information in their inbox in an easy to digest form, so that they could keep abreast of these psychedelic therapies. So Psychedelic Medicine Podcast 2020, Psychedelic Medicine Association 2021, January of 2022, I became the medical director of MAIA, which is a measurement-based care platform for psychedelic practitioners. Now let's get on to the good stuff. What is psychedelic medicine? Any therapy involving a psychedelic substance, and many of these often include psychotherapy as a very important component. Psychedelic medicine is different because it's aimed at resolving the cause and the root of what is leading to illness, not just chasing symptoms. As you know, most of the things, if you come in with depression today, what do most patients get? Therapy and an antidepressant that's aimed, the antidepressant specifically is aimed at treating the symptoms. Nobody's like, here, this Paxil is going to get to the root of what causes your depression. It's just going to try to manage the symptoms of depression. Psychedelic medicine is very different. Most often, at least in the ways, and right now we have the forms that we know about, and there are drug development companies making 4 million other forms. And so whenever I kind of hedge, it's because something may come out that is aimed at treating the symptoms. But most of what we're talking about now is aimed at getting to that root cause so that you don't have to keep chasing those symptoms. Now, some of the most common psychedelic medicines that we talk about today, MDMA is the one that is first going to be likely FDA approved, and by about 2024 is the last prediction that I heard. Psilocybin is about to enter phase 3 trials. MDMA is already in those phase 3 trials, and psilocybin is likely close behind MDMA in the approval process. Now, LSD, DMT, and ayahuasca, and perhaps by this time also 5-MeO-DMT, they're also in other studies, either phase 1 or studies outside of the US. And again, a lot of these, probably the vast majority, are used to address illnesses with trauma at their core, but not exclusively. I saw a paper the other day that was referring to psychedelics that were being tested for glaucoma. So if you are going into ophtho or derm or something that you think is not at all related to mental health, it does not mean that psychedelic medicine will not touch your field. It is being looked at for a number of indications across a range of specialties. So just to look at some of the things that, and this is again from 2020, but by 2020, most of these were either mental health conditions or pain conditions. So in the ketamine trials, we've got depression, post-operative pain, chronic pain, suicidal ideation. MDMA, we've got PTSD, depression, addiction. Now, again, you'll see, that's down here in psilocybin, we've got depression, addiction, and cluster headaches. Cluster headaches, again, is an interesting one. You're starting to see crossovers into neurology and other areas. Anorexia, terminal patients, so end of life, if you're thinking of going to hospice or palliative care, these are going to be very important there too. Now, you may have come across ketamine. As an anesthetic. So when I first came across ketamine, I was total nerd, had missed the whole party scene, did not know this was a club drug. I just thought it was something that you use to anesthetize kids in the ER. And turns out there are significant benefits outside of that setting. It's in use as a treatment for depression and other mental health ailments and chronic pain, mostly via off-label use intramuscularly or intravenously, though they're also now using lozenges and nasal sprays. You can get rectal ketamine. Not sure I know anybody who signed up for that yet. And these are, the IM and IV are often dispensed via ketamine clinics for those indications that I mentioned on that other slide. And there are also a lot from the pandemic. Now we've got a lot of people doing, maybe not a lot, but there are companies doing telemedicine, whole different set of issues comes up there when you're just sending people to ketamine and whether or not they're being supervised. Whole separate talk we could do, but that's another thing that's going on is telemedicine, ketamine telemedicine. And now there's FDA approved ketamine use via something called Spravato, which is a nasal spray approved for treatment-resistant depression. That's an enantiomer, if you want to get really like biochemically nerdy, of the ketamine that's way off, generic at this point. And they've found, via some of these trials, like I indicate there, that ketamine has this ability to rapidly resolve suicidal ideation, which is something, if you leave with almost nothing else with this talk, this is one of the things I really want you to take away. Because think about suicidal ideation. Somebody comes to you now, acutely suicidal, aside from hospitalization, which we know mental hospitals are not that prevalent, hard to find, aside from that, what are our options? We put them on an antidepressant. Well, how long did that take to work? Ketamine takes 45 minutes, and they're showing these rapid from acutely suicidal into not so acutely suicidal. This could be very life-saving. So this is something I really want you to come away with, that ketamine itself has been shown to rapidly resolve suicidal ideation. It also has rapid antidepressant effects. So like you saw, most of the things that were being investigated were with major depression. Ketamine, huge indication here. Now, for the more in the weeds psychonauts in the group, correct, ketamine is not a classical psychedelic. It's more of a dissociative. But at this point, we're, when we talk about psychedelic medicine, we encompass kind of a number of things. And since it has psychedelic-like effects, and it's also kind of a good gateway. It's 45 minutes. You can control the dose. And if people are maybe more leery to go into those deeper psychedelic states, psilocybin, ayahuasca, ketamine might be a great way to let them dip their toes into a little bit in a, nice clinical setting that might feel comfortable. And then, if that's their first experience with an altered state of consciousness, it's maybe a great way to get them more comfortable with other experiences. All right, let's talk about the FDA has something called a breakthrough designation. Now, this is a process that helps expedite the development and review of drugs that are for serious conditions and where the clinical evidence early on is indicating that the drug may demonstrate improvements that are significant over what's currently available. So for our industry, unbelievably, we have, both things that are about to be FDA approved or likely FDA approved have been given breakthrough designation. And for those of us who are well aware of like we were talking about how these get to the root, this is really not a surprise, because what's more effective, to go to the root of something and then not have to chase the symptoms for life? That's why these are, like it says in there, this is a substantial improvement over available therapies on clinically significant endpoints. As we'll talk about later, most of the endpoints for using an antidepressant is just like, can I function? It's rarely like, has the depression resolved? Which through psychedelics is something that has actually been achieved. So first in the pipeline, MDMA, which you may have heard of called ecstasy or E or Molly. And this is currently in phase 3 trials. Here is the article in Nature Medicine published last year. With the primary endpoint, 67 participants, and this is again on patients with severe PTSD. So 67%, 2/3 of the patients who had used the MDMA with therapy, so it's called MDMA-assisted psychotherapy, they no longer met the diagnostic criteria for PTSD after 3 sessions. If you're not sure what that means, that essentially means they no longer have PTSD. This is essentially, they came in with severe PTSD, did the psychotherapy sessions and the MDMA-assisted psychotherapy sessions, there are both, and they no longer qualify for having PTSD. That's incredible. Like I said before, these are not endpoints we've had before. We were just trying to manage PTSD. Can you have fewer nightmares? Can you go to work and not feel whatever kind of triggers you felt before? Now they no longer qualify for having PTSD. After MDMA, like we talked about, psilocybin is likely next. If you are unfamiliar with the word psilocybin, this is the active ingredient in what is very often referred to as magic mushrooms or shrooms. That picture there is Anderson Cooper at Johns Hopkins. He is showing you a great little look into what psychedelic-assisted psychotherapy can look like. So if you see, he's got his eye shades on. He's got a soundtrack piped into his closed earphones. That's maybe a classical, I think Johns Hopkins uses a classical soundtrack. Sometimes it's an overtone soundtrack. And then you lay down there in a comfortable sitting, and then you can kind of see there's a hand of, well, that might be Anderson Cooper's hand, but there are in these trials 1 or 2 therapists sitting there for the entirety of that period of time. Yes, like 8 hours. There is a therapist there or 2 therapists, co-therapists. And here, I think the first thing that they were talking about at Johns Hopkins was how psilocybin was shown to produce these decreases in depression and anxiety in patients with life-threatening cancer. So a little quote from that study was that this high-dose psilocybin showed these giant decreases in depressed mood and anxiety, along with increases in quality of life, life meaning, and optimism. And this decrease in death anxiety, which is really important. If you know anybody who's been facing a terminal illness or end of life, there can be a lot of death anxiety. And very often these experiences bring you to this place where you might see your birth, you might see your death, you might have conversations with people who've passed, and somehow many of them come away with a lot less of this death anxiety and an increase in their well-being and life satisfaction for the rest of the life that they do have. Now, again, as I showed before, a lot of the psilocybin investigations have been on depression. So a little quote from this study that was published in JAMA Psychiatry, 71% of patients had a clinically significant response to the psilocybin-assisted psychotherapy, and 58% of them at week 1, and then 54% at week 4. So again, this is over half at 1 month were in remission. They no longer had depression. Again, this is not, we're chasing the symptoms. This is, we've gotten to the core and the disease is no longer there. The condition is no longer something the patient is suffering from. These are incredible new endpoints. This is my favorite study. I don't know, I'm just a big fan of how obvious this is to most people who've tried to, I was a family medicine doctor when I still practiced, and trying to treat smoking cessation or trying to achieve smoking cessation with somebody who has suffered from tobacco addiction is very, very challenging. And in this study, Johns Hopkins did 2 or 3 sessions of psilocybin with cognitive behavioral therapy, and 60%, almost 2/3 of the participants were still not smoking at 16 months. So over a year of smoking abstinence with 2 to 3 sessions of psilocybin and cognitive behavioral therapy. They're not using Wellbutrin. They're not using the patch. This is all that they did with this study, and they're still abstinent over a year. And then a nice little byproduct of that is that 86.7% rated these psilocybin experiences among the five most personally meaningful and spiritually significant experiences of their lives. So we were talking about FDA approval, but something that's coming even sooner is that there is a legalized medical model of psilocybin coming to Oregon in January of 2023. Yes, that is like 9 months away. As you see here, this was voted on in November of 2020. So the state voted to legalize this therapeutic use of psilocybin. So in addition to Oregon, and by the way, I would give you more details on Oregon, but they are still being worked out. But that is also an entirely separate talk. But if you are tuning in remotely and you're not in one of our New Jersey medical student friends, this is something that may be coming very soon to your area. So this is an area to definitely keep your eyes peeled on Oregon. Especially, we're going to learn a lot about how these, potentially large-scale rollouts of these psychedelics go. So in addition to Oregon, we've got the spreading of something called decriminalization. So this is different from legalization. As you may be aware, like I live in California, we have legalized cannabis. You can go to a dispensary, you can buy it. That is not what decriminalization is. Decriminalization, by the way, it varies depending on how statutes are written. It may just mean that there are $0 that the law enforcement are allowed to spend on enforcing the drug laws that are specific to a certain drug. That may be another thing that they have in Oregon. So Oregon has decriminalized the vast majority of drugs for the entire state. And if you are seen with those or caught with those drugs, you are offered either, do you want a ticket, like a traffic ticket, very low level offense, or do you want to go to one appointment to see if you have a problem? Like there are, different, decriminalization looks different in different areas. So the following cities or states have decriminalized psilocybin at the least, at the most, like I said, for the state of Oregon, most drugs. And we're not talking just psychedelics, like other non-psychedelic drugs as well. State of Oregon is a huge one. Washington, D.C. has decriminalized natural psychedelics. Seattle is the largest city to have these decriminalization. Denver, Oakland, Santa Cruz. We've got some places in Michigan and Massachusetts as well. This is growing, I'd say, by the month. So now for those of us here in medicine, we see that there's this psychedelic science world, but how are we going to incorporate this into our practices? And there are a few basic challenges that exist at this point. The first is provider knowledge and acceptance of these medicines. The second is having our patients become aware of these medicines and accept that these are things that they would be willing to take and that these are viable therapies. The availability is a big issue right now. Like I explained, most of these are still illegal, and so we're working on getting them legal. But then once they're legal, we have to have enough accessible providers and retreats and clinic settings for them to be accessed. And then affordability, which is a challenge to basically providing any medicine in the US, unfortunately. So that still applies here to psychedelics. So let's focus for a moment on provider knowledge, because this is where most of you come in, right? You're going to be providers. This is something that is, luckily you're right on the cutting edge, right? You're in school, for those of you in medical school, at a time where people are having these conversations. I went to medical school again in days before there were iPhones. So it was, that's how long ago it was. And we didn't even talk about the benefits of cannabis. There wasn't an FDA approved treatment for seizures that involves CBD, So be very grateful that you are coming in at the time that you are. But that being said, you have the ability to start shaping the knowledge of your classmates and your training mates there's a helicopter, that you will soon be in residency and fellowship with. So where clinicians learn about new therapies, school, but generally let's talk about, curriculum are not necessarily up to date to the last minute, right? So we start to learn about therapies, but maybe school's not where we learn about the newest therapies. But residency may be, we start to learn about more new things there because you're actually using the medicines and interacting with people that are reading journals and drug reps are visiting them, etc. Once you're out, you're going to take continuing medical education, and CE is what therapists take, but for doctors, it's CME, and that's another place you can learn about new therapies. Journals is another place. If you're doing journal club or if you're just really up to date on your specialty, by the way, kudos. That's another place to keep up with the latest. And then, like I mentioned before, think about, I'm not sure where you all are rotating, but if you're practicing and you've got somebody who's diabetic, we all know metformin, right? It's generic, but how do we know when the newest thing comes out? Well, you might see it on TV like everybody else, or maybe you see an ad in a journal, or maybe you see an article about it in a journal, but very likely a drug rep shows up with some sandwiches and like a bunch of flyers about it or something. That's very honestly, that's how a lot of people find out about new therapies. And also why it's really hard to get doctors educated on generic ketamine, because it's generic and nobody has a vested interest besides the people who made the new version, Johnson & Johnson. And nobody has this vested interest in paying drug reps to go tell you about generic ketamine. So there's a reason here that I've got asterisks next to two of these, because these are the places where you can basically already learn about these new therapies. So journals, here we go. Like I showed you earlier, there was JAMA Psychiatry, there was Nature Medicine. Here was the first article that appeared in the New England Journal of Medicine that was showing psilocybin versus escitalopram, a very interesting article. And then continuing medical education is already available. Now, it's not super easily findable, I will tell you that. Like if you go to most of the places where you are looking, by the way, I guess you all probably are not doing CME, in case there are any faculty in there listening. And when you go out in the world and you eventually have to get CME, most of us go to these places where like, when can we find our online, cheap or free CME outside of the conferences we'd attended, etc. And psychedelic therapy isn't necessarily in those databases yet. If you want to find psychedelic related CME, it's out there. You just have to look. Spoiler alert, if you go to psychedelicmedicineassociation.org, we have a list of courses on our page that many of which have CME. Okay, now provider knowledge. Where are we at now? Well, H&P Global put this out to their mental health practitioners. So they put this out to a number of practitioners, I think this was in 2020, asking, have your patients already started asking about psychedelics for these mental health issues? And almost half said yes. So patients are going to come asking, and they already are asking, especially if you're suffering from a mental health condition and whatever you're taking isn't working, or you're taking it and it's kind of working, but it's got a lot of side effects. You're probably going to go investigate. If you type in new therapies for depression, psychedelics are likely to come up, and they're going to come asking, hey, this isn't working for me, but I hear psilocybin's available. So, luckily, a lot of patients are already starting to come, and hopefully that starts to perk up doctors' ears about this. Now, those same doctors did not consider themselves very knowledgeable about psychedelic therapies. At least almost half thought they were somewhat knowledgeable, but 50% thought definitely not knowledgeable. And no shame to those doctors, because like we just discussed, we're not taught about this in medical school. Most doctors my age, we didn't hear about it in residency or fellowship either. And it's kind of hard to advertise some of these things because of the illegal nature, just trying to even advertise on Facebook or something else, lots of flags pop up sometimes. So it's just kind of hard to get this information out in certain ways. And then, are you interested in learning more about psychedelic therapies? Thank goodness 87% of these doctors said yes. I do not recommend going to the 13% who said no. Unfortunate. And that's why I'm really excited about you all that are here, because this next wave of doctors is going to have to know about these. Doesn't matter if you want to learn about this. Like, these are here, and these are the way that you're going to be able to be more effective providers for your patients. Because if you know that there are these, essentially disease eliminating therapies out there and you continue to give antidepressants or whatever, isn't working for the patient already, that's really doing a disservice. So I'm excited that you're here. Let's outweigh the 13% that don't want to hear more, because these are going to do better for your patients than a lot of what we have now. Now, again, with providers, not only do we need to know about it, but providers need to accept them more. And of course, these come with so much stigma. We've had 40 plus years of prohibition. You all may know what the DARE logo is just from like nostalgia or something, but I grew up with DARE in our schools. It was just say no to everything. There was that commercial where they fry the egg and this is your brain on drugs, right? We had the just say no Nancy Reagan stuff. And thanks to most of these substances being made Schedule 1 in 1970, the research was taken off the table for decades. So for people to say, well, why haven't these been studied? Well, because they weren't allowed to be studied. It's very, very difficult to research things that are Schedule 1. Dr. Rick Strassman, who I think is speaking to people after me, is almost single-handedly the reason that this has been changed. So thank you, Dr. Strassman, for your work in making the rest of us have more options to give to our patients. So here's some possible solutions. This is where a lot of you come in. For medical students and faculty, do you have access to the curriculum committee? Can you ask them, hey, how about we do, just a one-day seminar on some emerging therapies, and we could have a discussion on psychedelics? There are lots of experts probably in your vicinity that would come over and give a talk or have somebody do a virtual talk, and just get this in the medical students' minds. You don't have to tell them everything about it, but it's better that you start to introduce these ideas so that when a patient comes and asks you about them, they're not completely foreign, right? You don't want to be caught deer in the headlights when a patient comes in and asks about a therapy and you have no idea about it. Even worse if you just poo-poo it, oh, those are drugs, just say no. And the clinical evidence is absolutely that these are effective. Like this is not a position that anybody wants to be in. So let's start educating people just so that they don't have that knee-jerk reaction of like, oh, you're coming to me with an addiction, because we didn't mention this, but there are a lot of things that are being shown, like with the tobacco addiction. You want me to prescribe an illegal drug for an addiction? Like that might at first sound crazy. And without the education, that stigma and that erroneous train of thought may be stuck in the provider's heads. So let's start at least bringing forward the idea, like, look, you may have heard that these are illegal, but look, let's start talking about the research and let's start talking about the evidence. And hopefully that gets minds to start opening and then looking further into it for themselves and their own patients. So another way that you all can get involved is student groups. Would you like to start, your school's psychedelic medicine association chapter or branch, or, maybe once a month you get together and you do a little journal club on a psychedelic journal article or something like that. Great way to start spreading information there. And then, oh, by the way, students can join the Psychedelic Medicine Association for free. It's cheap for trainees, but completely free for students. So we would love to have you. And what we do, which I'll tell you a little bit later, but our entire thing is to get you educated on these enough to feel comfortable having those conversations with patients. Now, as you are going into your training, some of you may be, what are we in here? Okay, some of you may be graduating from training in the next few months. I had to figure out what month we were, March. So as you're going into your training, take a look. Is ketamine-assisted therapy discussed? Or even if you're in psychiatry and you're just going into your third or fourth year clinical rotations, is ketamine-assisted therapy discussed? Or is other psychedelic research discussed? This is the time where you can start having, if you're starting to narrow down on what your residency may be, or if you're already in residency, then especially if it's psychiatry, look around and see ketamine-assisted therapy is out there. We've got probably 1,000 clinics in the US. This is something psychiatrists need to be educated on, at least the existence of it. If not the provision of it. And again, you might want to start a journal club that focuses on some psychedelic research articles. Now, here's some questions. If you're going into a training program, I think your match day is probably coming up, so maybe it's a little late in the game for this, but questions to ask for those of you maybe in the future is, do the residents or the fellows get to rotate with psychedelic assisted therapists? If you are going into, say, a mental health, psychiatry program, and you are curious about psychedelic assisted therapy, maybe being one of those co-therapists in the room, then ask if you can rotate with those who are doing psychedelic assisted therapy. Like I said, especially by the time you all are in training, some of these will be legal, But even if not, there are clinical trials going on across the country. So it is not too difficult to find somewhere to hopefully kind of shadow and rotate with these practitioners. And that's something that I think a lot of residency programs should start adding is credit for participation in a psychedelic therapist training programs. There are a number of psychedelic therapy training programs, and there are a number of hours. And so I think residencies should start looking into, okay, how much education comes with these, and can we give them, a month of credit or an away rotation type credit or whatever for doing these? Because imagine the extra skill in your toolbox if you graduate from a psychiatry residency and you have psychedelic assisted psychotherapy training in that tool belt. I think that's just going to extra prepare you for this new world and better serve your patients. So the Psychedelic Medicine Association, like I told you in slide number 2, we wanted to educate clinicians in a way that was accessible for them and not in 45-minute podcast form. So our mission is to educate frontline healthcare providers and clinicians on these psychedelic therapeutics. And we're talking doctors, nurses, PAs, therapists, anybody that a patient might come to and say, I'm feeling sad, anxious, have experienced some trauma. But again, like I said, it's to the point where now they're trying DMT for stroke victims. They're trying other medicines for headaches or for glaucoma. So it's not just mental health practitioners that we want to educate. We want to educate across the spectrum, but also, just in case you're not familiar with this statistic, 80% of antidepressant prescriptions are written by primary care providers. So if you're not in mental health, but you're looking to do family medicine or internal medicine, this is something that's still going to really touch you and your patients. So why is it so important to educate the providers, all of us, right? Well, those patients that come to us, they may be asking about psychedelics, right? But they may not have the first clue about psychedelics. I'm looking at my parents, right? They're in Southern Illinois. They're 72 and 75. Shockingly, thanks to me, they do know what it is and are actually on board. Very conservative people, but on board. And now they send me articles. But, prior to me, they had never heard of psychedelic therapy. What if they started to have depression or end of life issues? My mom was diagnosed with cancer last year. Thank goodness she's better, but she was having some, end of life anxiety. And if she goes to her, Southern Illinois provider, and that, in a future where the psilocybin is legal, I want that provider to know that, and I want that provider to present that as a viable option. Because especially think about our parents' generation and our grandparents' generation, they very often look to us as this font of information. If the doctor says so, then we believe it's true. And so we, especially when the therapy is kind of cutting edge and strange and maybe had a stigma in the past, especially those, my parents' generation grew up with the hippie and the hippie generation, and these were taken to kind of drop out. Well, now we're trying to tell them the same medicines will help you drop out, now can help you be okay with your end of life anxiety, right? That might be kind of a mental switch for them. But if it's coming from their trusted physician, maybe not so much. Like, especially, the generation that isn't Googling everything is much more likely to come to Dr. You than WebMD. So that's why we need the providers to be versed enough to start the conversation, right? At some point, you may not feel like, okay, this is a little over my head, let me pass off to a psychedelic therapist. Great, at least psychedelic therapists are there to pass off to, right? Like, we want at least the providers to know that when it's appropriate, this is when we should at least offer that option and suggest that this is a viable option for a certain patient. And again, so then in number 2, when those 47% of patients that were asking 2 years ago, you want to be prepared to have that conversation. I remember when I was actively practicing, like, the worst fear was when somebody came in and they're like, can I take such and such for my diabetes? And there's like a deer in the headlights because it was a medicine I'd never heard of. And then I literally had to say, like, let me go ask my attending, or I would Google it, or so, best to have at least a baseline knowledge. And then you can comfortably say, like, I understand this much about it. This is not exactly my realm, but I do know that psychedelics are good for these things. Let me refer you to somebody. We want you just to feel comfortable enough to have the first kind of inklings of that conversation and then feel comfortable referring. And then also, you want to protect your patients and yourselves. Right now, a question that doctors so often ask me is it malpractice to talk about illegal substances with my patients? That's what they think when we're talking about psychedelics. And it's not. It is more on the gray area side if you start to do something that looks like you are aiding them to get what is currently an illegal substance, but something like educating them on the substance is not illegal. But we also want you to know those kind of boundaries, and we want you to protect yourselves and your patients. You know, like if your patients come to you and say like, I've heard Ibogaine is great for, we didn't mention Ibogaine, but Ibogaine is a pretty like hardcore psychedelic from Gabon, Africa. Very, very effective in addressing opioid addiction. So somebody comes and I'm suffering from opioid addiction. I want to do Ibogaine. And you're like, okay, sounds good to me. Well, you have to do a cardiac clearance for Ibogaine, right? So there's like a baseline amount of information that you need to know, or at least say, okay, I'm not 100% sure. Ibogaine sounds like, yes, I've heard the research is good, but let's get you to a qualified practitioner so they can do the clearance, et cetera. Like, we want to protect you and your patients. And the more knowledge we have, the more that's likely to end up in better outcomes. So now here's where it gets really interesting, is that we're not quite sure where the physician is going to come into this. Like, say a primary care physician, you know, somebody comes to, if I were still a family med doc, somebody comes to me, they say, I have PTSD. Do I do the clearance to make sure that MDMA is okay for them? Because with some heart conditions or blood pressure conditions, it's not. And then in the future, if they come, like, say, with depression, and we know that psilocybin is good for depression and ketamine is good for depression, who does the medicine selection? Is it the primary care doc who's referring to one or the other? Or is there some other kind of psychedelic medicine specialist that is able to make that decision? And then who does preparation and follow-up? The follow-up after a psychedelic experience is called integration. But so preparation before the experience, integration after the experience are shown to be very important parts of a psychedelic journey. It's not like you walk in, you've had no preparation, you take the thing, you have the journey, you come out, no PTSD, right? Like there's preparation that has to be done beforehand to set the patient up for success. And then afterward, you might have seen some very interesting things in your journey, and you need somebody to help you talk through those and then integrate the lessons you've learned into your daily life so it sticks, right? So that, you know, whatever therapeutic benefits you got, hang on. Well, who does that, right? Is it the psychedelic therapist, or do they go back to their psychiatrist? And then referrals are tricky at this point. Like, you know, legally, can you refer to an ayahuasca facility in Peru? Probably not, because it's not legal here, but it's legal there. So like that's a, you know, kind of a gray area. And then referrals are tricky because also, number 3 here, we have a lack of certification and governing boards. Those boards are developing. You know, by the day we're getting new people who are trying to make certifications, but, you know, as it stands right now, if somebody wants to refer to a ketamine clinic, there isn't a certification that says this is a quality ketamine clinic. You know, ketamine clinics can be started by anybody. They don't have to be giving proper therapy. They don't have to be giving the proper dose. Like, so you could be sending your patient to something that could be even harmful for them. And so referrals are tricky because how do you know if it's a qualified ketamine center? If you're referring to a board certified cardiologist, you know they're board certified. They've done a fellowship and they've done their boards and they've passed. There isn't something similar for ketamine. So that's something that we're working on for, you know, ketamine clinics and psychedelic psychotherapy providers, so we feel comfortable making those referrals. Okay, we're wrapping up here. What can you, my medical student friends, do? Know that these therapy options are coming and very likely will be available by the time you are out and practicing. So, you know, think about what options you may want to take part in your journey. Do you want to be the provider for these therapies? That's a possibility. Do you want to refer to these therapies? Also a possibility. Or do you want to be in integration, you know, with some of the, you know, dealing with some of the after effects? Or do you want to be in perhaps, you know, think about things way outside of medicine. Do you want to work in policy or something? You know, we need medical minds on all of these angles. Do you want to work in research? There are lots of other kind of outside effects that have roles. You know, I'm the medical director of a psychedelic tech company. You know, I'm not seeing patients at all anymore. So there are a lot of ways that you can fit into this industry. So if you are thinking of providing these therapies, like I said, see if you can get residency rotations in them. See if you can shadow. Let me tell you, the difference between seeing a patient an hour or seeing a patient for 8 hours, vast. I would say before you do psychedelic assisted therapy, see if you can shadow somebody. See if sitting for 8 hours with a patient in that kind of state is something that you would be interested in doing. Try to find a training program that incorporates psychedelic medicines. And then here I've got a question mark, because my ideal is that at some point there's a psychedelic medicine fellowship, and that psychedelic medicine specialist, they know how to do all the clearances. They may know how to do a lot of the medicines, but they at least know how to refer to the medicines. They may know how to do that medicine selection. So keep an eye out for a fellowship at some point. if you just want to be prepared, you don't want to provide the medicines, well, join us at the Psychedelic Medicine Association for free at psychedelicmedicineassociation.org. We will send you a newsletter every month with like the latest 5 or 6 articles in psychedelic science. And we have a webinar every month with experts that are focusing on one specific topic. So we'd love to have you join us. All right, my friends, thank you very much for your time. I hope you enjoy the rest of the conference. And if you have any questions, you can send an email to info@psychedelicmedicineassociation.org. Bye, guys. Hey, good morning, everyone.
Wow, thank you so much, Dr. Morski, for recording that for us. That was such a great presentation. I got a lot out of it. I myself am really passionate about women's health, and so I like her point of doctors just need to be aware of what's out there and what are options, just so that we're knowledgeable, even if it's just a little bit, and can refer out to people who know in much greater depth than us. So it's about 9:45 right now, so we're going to take a quick little 15-minute break, and then we will introduce Dr. Andrea Iannuzzelli and medical marijuana. Thank you so much, everyone. We will see you at 10. All right, everyone, welcome back. It's 10 a.m., so we're going to start with our next presenter. Dr. Andrea Iannuzzelli graduated from Rowan School of Osteopathic Medicine in 1995 and went on to complete a residency in internal medicine and even a fellowship in nephrology. While in private practice as a nephrologist, her son Nicholas was diagnosed with Lennox-Gastaut syndrome, a rare refractory form of epilepsy. After years of working with neurology and neurosurgery teams, trialing combinations of treatments to manage her son's seizures, his seizures were still not successfully controlled. This led Dr. Iannuzzelli to ask Nick's team to consider alternative treatments, culminating in a trial of medical marijuana in 2014. The experience to use medical marijuana with her son prompted her to entertain its use with her own patients. Today, Dr. Andy's life is dedicated to advocating for the intellectually and developmentally disabled population, and she accomplishes this through caring for patients at the Rowan Integrated Special Needs Center in Sewell, New Jersey, as well as serving on boards and committees at the state and local levels. Dr. Andy also treasures time spent serving students and the community of RowanSOM as president of the alumni board. So, Dr. Iannuzzelli, I turn it over to you to share your slides and give us some wisdom today.
Thanks so much, Magdalene. All right, thanks everyone. Let me share my slides with you first. There we go. All right, everyone can see that well? Perfect. So as Magdalene mentioned, I RowanSOM is near and dear to my heart. I went to RowanSOM as a medical student, although it was called UMDNJ-SOM at that time. I did my internship residency in internal medicine here. I did my fellowship in nephrology here, and I graduated in 1995. So my son likes to tell me I graduated in the 1900s, and that's like, oh, it makes me feel so old. I guess well, relative to you guys, I kind of am. But and now, as Magdalene mentioned, I am president of the Alumni Association, and I work for Rowan Integrated Special Needs Center, or RISN Center, down in Sewell on the new campus. And so how did I end up here with you all today talking about medical marijuana? Let me just advance to the next slide and talk to you about my experience. So as Magdalene mentioned, my son Nicholas started having seizures when he was in kindergarten. Was a typical little boy up until then, hitting all his milestones, and you know, we thought he was the smartest kid in the whole world, like a lot of parents do. He's playing violin when he was 3, and he was on the swim team, and he was just absolutely brilliant because he takes after my side of the family, but don't tell my husband's side that. And then all of a sudden he started having seizures right around the time he was going to go into kindergarten. And after you know, doing this extensive workup, it was found that he has something called Lennox-Gastaut syndrome. And Lennox-Gastaut is fortunately a rare form of epilepsy, but it's really refractory. And as the brain matures and develops, the seizures get worse. And so he had tried all different types of medication management. We met with neurosurgical teams at Cleveland Clinic. We've been seen down at Hopkins and DuPont and CHOP. So we were really hooked in with all of these amazing centers across the country. And he still was having literally dozens, sometimes up to 100 seizures each day. And so it was like, you know what, something's got to give. So in 2014, we were frankly ready to move out to Colorado, or at least rent an apartment out there for a 3-month trial so we could try him on marijuana, which was obviously legal out in Colorado at the time, but not legal in New Jersey. And we met with our neurologist in March and talked to her about it. And she said, hold that thought for just a moment. CHOP is going to be approved to be part of the first medical marijuana study in the country. And, you know, it's crazy. The FDA, and we'll talk about all the legalities of this stuff, the FDA approved only 4 centers across the country to enroll 100 kids. CHOP was one of those centers, fortunately for us, since it's in our backyard, and could enroll 25 kids. And so each neurologist at CHOP, like 50 neurologists, had to submit 5 of their most refractory patients. And so the bad thing is my son was one of the most refractory patients at CHOP. The good thing is he was the second kid chosen for the study. And the next good thing is that medical marijuana worked for him. So I was a believer. And kind of like the last speaker, you know, I was a little on the nerdy side, wasn't a partier, have never been stoned, but had heard anecdotal reports of these success stories, and my son became one of them. So it was like, okay, if it's good enough for my own family, then it's good enough for my patients. And at that time, I had kind of switched gears in my career and was working in a geriatric population, and a lot of these patients have pain. You know, a lot of my patients were octogenarians, nonagenarians. We didn't want them on opiates. They couldn't do NSAIDs or COX-2 inhibitors for some reason. And so it was like, you know what? Why don't we try CBD, not necessarily THC formulations. Let's try CBD formulations initially. And then some of them, we moved on to medical marijuana when New Jersey laws changed, and we had success there. So it was like, okay, now I'm at Risen Center, and we've got huge behavioral health issues with many of our special needs adults. And we're seeing that medical marijuana is helping in that population. In fact, I'm going to read you just a text I got from a mom a couple of days ago who was really, really nervous about starting her 18-year-old son on medical marijuana, but didn't know what else to do because they were having such horrible problems with him. He was injuring his family, he was injuring himself. And so here's the text from her on Tuesday. Just wanted to let you know that he's had a wonderful few days. He's been calmer, not as much screaming and agitation, and he is sleeping. I gave the CBD THC tincture. It's been about a week, and we're in a nice groove. So I'm getting success stories like this with my special needs population. And so it's just even more convincing for me. And I'm hoping I'll convince you all, if there are any skeptics out there, that there really is huge amounts of value, therapeutic value, to entertaining these therapies and thinking outside the box. So that being said, let's talk about the experience that the medical community has with specifically medical marijuana. So Boston Medical Center has a primary care journal, and this article was just published not even 2 weeks ago on March 3rd. And what the authors did is they surveyed internal medicine residents at Boston Medical Center just to see what their knowledge was about medical marijuana, what their attitudes were. And the conclusion is that, in the bottom bullet point here, there's a critical lack of medical marijuana related knowledge. And I don't think this comes as a surprise for anyone. And I think that we can extrapolate this study done with internal medicine residents to the medical community as a whole. So in a population, they say, with growing cannabis consumption, physician training on the indication, toxicity, and drug interaction of cannabinoids is warranted. So, you know, and this is looking at physicians who are in training, so they're younger. I mean, and I know I'm generalizing here, but I think a younger population tends to be maybe more embracing of these therapies. I think if we were to survey physicians who were more seasoned, who were in their 50s like me, or their 60s, there might even be a more intense critical lack of knowledge. So I think this is a best case scenario is what I'm talking about. And the best case scenario is there's a critical lack. So let's work on that. Let's first start with a little bit of history. I'm going to breeze through this a little bit, but I didn't want to leave it out. So, documentation of success with marijuana goes all the way back to the 19th century. Dr. William Brooke O'Shaughnessy, he used medical marijuana with patients who had cholera, tetanus, epilepsy, rheumatologic issues, and he actually published his data, which is really cool. And he found that medical marijuana has analgesic, muscle relaxant, anticonvulsant properties, and he was witnessing it. And think about it, back then, there really wasn't a lot in the way of pharmacologic agents that he could use. They had to use more natural types of therapeutics, and he saw the success with it, and he published his findings. So then jump forward to 1964 is when the THC molecule was actually discovered. And then in the 1990s, endocannabinoids, anandamide and 2-arachidonylglyceride were discovered. We'll talk about the Cb1 and Cb2 receptors in a minute. But so we knew in the 1960s that the THC, that the phytocannabinoid molecule was discovered, and then endocannabinoids were discovered in the 1990s. We'll talk a little bit more about the distinctions between those as well. So let's talk about the science. Endocannabinoids, so those are cannabinoids which are made by our own bodies. The Cb1, there are two receptors, Cb1 receptor identified in 1988, and then the Cb2 receptor in 1995. As I mentioned, in the 1990s, anandamide was discovered, and that works primarily at the Cb1 receptor. And interestingly, anandamide was named because it is Sanskrit, the Sanskrit for bliss, which I thought was kind of appropriately named. And then arachidonylglycerol works on the Cb1 and Cb2 receptors. So those are endocannabinoids that our body just endogenously creates and makes, which is a really cool concept. But then there are also phytocannabinoids, which is what we're really here to learn about today. And those are the plant-based cannabinoids, most commonly known THC and CBD, although there are about 100 different phytocannabinoids that have been identified. So this is the receptor. No medical lecture is complete without a little bit of molecular biology. So this is what the CB receptor, endocannabinoid receptor looks like. And if you look, there is signaling CAMP, a bunch of kinases, transcriptional control, all different types of internal reactions are going on here. And so as you can imagine, with cannabinoids affecting all of these different pathways, there probably is a huge amount of therapeutic benefits that we haven't even discovered yet. We're, I think, just at the tip of the iceberg when it comes to, from a medical standpoint, discovering all of the beneficial effects that we can see with cannabinoids. Let's talk a little bit about the Cb1 receptor. So this is the receptor that primarily responds to THC. And it's really, if you look at the distribution of these receptors, primarily located in the central and peripheral nervous systems, but also can affect the endocrine systems through the pituitary and thyroid, affects the GI tract, reproductive systems. I know we've got an OB-GYN who's going to be speaking later in the day, and hopefully he'll touch on that more, the myocardium. So all different types of locations for these receptors. It's not just, in the brain. And interestingly, the Cb1 receptor actually, when it's activated, it activates the GABA receptors, and that's how we end up down the line getting some of the neuropsychiatric effects that we see. But also, phytocannabinoids are primarily, we know those about those as giving us a high, but there are all these other amazing effects that they have. Regulation of sleep, fear, appetite. A lot of us know about appetite because we feel like, weed makes us hungry. It's kind of known for that. Memory, motor responses. So much more far-reaching than just neuropsychiatric effects. And then with the CB2 receptor, so the CB2 receptor, similar to CB1, they share 44% of their amino acid sequences, but different enough that there are distinct binding properties. And what's interesting about this group of receptors is, if you remember, the CB1 receptors primarily central nervous system, peripheral nervous system. Well, CB2 receptors also are present in the peripheral nervous system, but also immune cells, vascular endothelium, smooth muscle, again, myocardium, and the GI system like CB1. But, again, interesting to just kind of start to imagine all of the future possibilities for therapeutics in this realm. And then, so our guest of honor is marijuana, cannabis. This is the molecular structure, and it's a C21H30O2. So if there's ever like a trivia question or extra credit question on an exam, and you're like, C21H30O2, that's marijuana. So, it's just, I think everyone thinks of marijuana, in its illegal sense, which we're trying to destigmatize here and demystify. But really, when you look at the chemistry of it, a pretty simple molecule if you think about it. So let's talk about the science of phytocannabinoids, marijuana. As I mentioned, they're plant-based molecules, and there are over 100 different molecules that have been identified so far. THC and CBD are the best known, of course. And, concentrations of the different cannabinoids vary depending on the chemovar. And chemovar is the preferred verbiage for the different strains of marijuana. And just like when parents are raising children, that how you raise them really can affect how they behave later on. Well, the same thing for marijuana. Horticultural techniques and how the plants are raised really can have a significant influence on the effects that they have within the human body. THC, as we all know, is the psychoactive component of marijuana, not just medical marijuana, but of cannabis. And it is active at both the CB1 and CB2 receptors. As you saw in the drawing of the molecular chemistry drawing, it works at cyclic AMP. And acutely, it can affect memory, spatial orientation, learning, and attention. However, also can have longer lasting analgesic and anti-inflammatory properties. So really, this is kind of the segue into how medical marijuana is being approved for these medical indications because of analgesic anti-inflammatory properties. Now, of course, with any pharmaceutical, you can see some side effects: tachycardia, hypotension, dry mouth, dry eyes, orthostasis. The beauty of THC and of cannabis is that there is no respiratory depression. So how with certain pain medications, opioids, you can see actually death is one of the risk factors because of respiratory depression. You don't see that with THC and with cannabis. So that's one of the nice things about it, is you're not going to have people who are overdosing on it and who are dying because of it. Now, CBD, another of the phytocannabinoids, also works on both the CB1 and CB2 receptors. It binds these receptors more weakly than THC does, but there's a theory that when you've got a formulation that has a little more CBD in it, you're not seeing as much in the way of psychoactive effects. And CBD in and of itself has been identified to have anticonvulsant, anxiolytic, anti-inflammatory, and neuroprotective properties. And the anticonvulsant is what really led me on this journey with the success we had with my son. So we'll talk briefly about the pharmacodynamics, but this is an important part, right? Because the pharmacodynamics really influence which mode of entry we're going to choose when we're administering this or making recommendations for our patients. So if you smoke cannabis, the peak action is going to occur within 30 minutes. It's not going to last that long, though. The effect is going to wear off typically within a couple of hours, sometimes as long as 3.5 hours. However, when you ingest it, you're going to have a slower longer time, I'm sorry, till the peak, but it's going to last longer. And so advantages and disadvantages are, if you're ingesting it, you know, you might have some people who are new to this realm, and they might ingest some cannabis, and after an hour they're like, well, I don't feel anything, so they're going to take another dose. 30 minutes go by, they don't feel anything, they're going to take another dose, and that's what's called dose stacking, because all of a sudden, once it you know, gets to your phase 2 metabolism, then your levels are going to come up. So you can get side effects because of dose stacking, because people just aren't experienced enough to know you've got to wait a little bit longer before you're going to see the effects. Whereas with smoking, you're going to get effects much quicker. You're not going to have that potential for dose stacking. But then there are also other ways of using cannabis and getting it into our patients' bodies. So there are topicals. Now, the onset of action is not quick. It's less than 2 hours. The problem with topicals is it's really unpredictable with regard to pharmacokinetics. It's absorbed at varying rates depending upon the patient. And so although you have a pretty, you know, relatively rapid onset, it's just very unpredictable. Oils and tinctures, the nice thing about them is, although they can taste kind of unpalatable, they can be administered sublingually, and they act within just a few minutes. So within less than 10 minutes, you're going to start seeing effects of this. And they can last up to 10 hours. So it's kind of nice. You get a quick onset of action, and you get a pretty long action. Good bioavailability. And with vaping, again, you'll get a pretty quick onset of action, doesn't last as long. You know, downside to vaping is lung injury, chronic bronchitis. We'll talk about side effects a little bit later on, and long-term sequelae. So legal information, you know, 37 states, actually, it might be 38 now, have legalized medical marijuana as we know it. There are 11 states that have legalized low dose, which is more like a marijuana-based CBD. And then there are 2 states that still in no way, shape, or form have legalized marijuana. And I believe those states are Idaho and Nebraska, last time I checked. I don't think that's changed at all. You know, part of the problem with medical marijuana is that it's not legal from a federal standpoint, but each state can make their own laws, and the approved conditions vary by state. So for example, what is legal to use medical marijuana, you know, medical marijuana indications in New Jersey are different than those in California, or different than those in Florida. And so there really is no standard with regard to conditions, and there's no standard formulation. So it's a little bit of a free-for-all right now, which I think is where medical marijuana loses a lot of credibility with its skeptics. Hopefully, we're going to see, as research improves, we're going to see that it becomes more accepted in the medical profession. You know, however, the FDA did in 2018 approve the first medical marijuana formulation. It's called Epidiolex. Actually came from a British company, and it's approved for very narrow therapeutic indication, and it's just 2 rare and really refractory forms of epilepsy. One is Lennox-Gastaut syndrome, which is what my son has, and the other is Tourette syndrome. So beyond those 2 diagnoses, not FDA approved. What's interesting is in physicians who really want to provide these medications for their epilepsy patients, all of a sudden we're seeing the number of people diagnosed with Lennox-Gastaut syndrome it's starting to take off. So whereas Lennox-Gastaut was considered pretty rare before, now physicians are kind of making the diagnosis fit their patient, and they're kind of like justifying use in patients who otherwise in the past didn't have Lennox-Gastaut syndrome. Now they're kind of like back-ending their patients into that diagnosis. So that's been interesting to see. more on legal information, this is really interesting. So cannabis is considered a Schedule 1 drug. And what that means is the government feels that it has no medical benefit whatsoever. And this is in the same class as heroin, LSD, and ecstasy. So that makes it difficult to study, right? I remember when our son entered into the study back in 2014, we had to get fingerprinted. We travel a lot. And so we had to have letters from our the study team and from the FDA and the DEA to carry with us all the time across state lines, showing that we have this product, and ours was a liquid that we had. We're allowed to have it. But it was just this really, it was difficult to study because of all the regulations. Whereas if you look at a Schedule 2 drug, Schedule 2 drugs include fentanyl, methamphetamine, morphine, oxycodone. So it's just interesting to me that medical marijuana, which, I feel and most of the medical community, I think, would agree, much more benign than methamphetamine and fentanyl, yet it's considered a Schedule 1 drug. So just kind of interesting to compare and contrast Schedule 1 and Schedule 2. So hopefully this will change in the very near future. So let's talk about efficacy. There was the National Academy of Science, Engineering, and Medicine in 2017 did a comprehensive literature review. And what they found was there was either conclusive or substantial evidence that cannabis was helpful in a few different arenas. One was chronic pain in adults. One was they agreed that in doing this lit review that there was an indication for antiemetic use in people who had chemotherapy-induced nausea and vomiting. And then they also concluded that when people who had MS, there was an improvement in muscle spasticity. So this was kind of a groundbreaking publication because it was done at the national level. It was, it reviewed, it was very comprehensive in reviewing the literature to date. And it was the first time that there was kind of on a large scale, this published position on that, okay, this really could be helpful, and there was conclusive evidence. And I think that opened up a lot of minds at the governmental level. And then 2018 comes along, the Epidiolex study drew its conclusions after 4 years, showing that there was evidence that it also, cannabis also helps in epilepsy. And I think after that time, we started seeing more and more states start embracing the use of medical marijuana. So, let's talk about some specific instances, some specific diagnoses with regard to success. So, as I mentioned in the last slide, the NASEM published in 2017 saying chronic pain, there was substantial evidence that it was helpful. And chronic pain, frankly, is the most common symptom, the most common problem for which medical marijuana is prescribed. And there was an article that just came out a couple months ago in Pain Physician showing that medical cannabis use is associated with significantly lower rates of death due to opioid overuse. So what this is showing is that if we can use medical cannabis for pain in a Schedule 1 medication, a Schedule 1 drug, versus a Schedule 2 drug, opioids, we're not going to see as much overdose. We're not going to see as much morbidity and mortality. So I think, this study is new, but I think it's going to really spearhead, again, people opening their minds, governmental agencies, regulatory agencies to opening their minds and saying, maybe we need to make this more accessible to the population at large, especially the chronic pain population. With regard to the spasticity in MS, which was one of the NASEM's conclusions, is that medical cannabis can help with spasticity as it relates to MS. There's another review article done in 2019 that had 8 randomized controlled trials. And what it found is that if you have a combination THC plus CBD, that was much more effective with spasticity than THC alone. And so a lot of people after that study started extrapolating these findings to other diagnoses that have spasticity, cerebral palsy, all different, people who've had strokes and now have some spasticity, traumatic brain injury. And, the limitation with some of these studies is that a lot of them were not done in the United States. So different countries use different chemovars. And so it's hard to extrapolate the data from those chemovars and say that, yes, we can use it in the same fashion. We're going to have the same types of effects with chemovars that are primarily used in the United States. However, the seed has been planted. And in the United Kingdom, there's a medication called nabiximols, and it's actually, they use it, it's legal. It's made by pharmaceutical companies. It's embraced by the medical community. And it's actually an oral spray, or an oral mucosal spray for spasticity and pain. So, hopefully we always find that in other countries, their regulations seem to be a little less rigid than ours. So hopefully nabiximols will find its way to our country in the not too distant future. And then we also know with based on the Epidiolex study that there is definitely an efficacy with regard to seizures. So the study that was done with Epidiolex was a double-blinded, randomized control trial. And so with my son, we didn't know if we were getting a placebo or the study drug until about day 3. And we're like, he has a study drug. This is not placebo, because at that time he was having about 80 seizures a month. And within 3 days, he was down to like less than 1 per day. So what we saw with him just in the first few days was astounding. And ultimately the study concluded that Epidiolex, which has a really, really high concentration of CBD, showed a 40 to 50% decrease in seizures in kids specifically with Dravet and Lennox-Gastaut. But it was funny, we go to Children's Hospital for our checkup. We had to go every couple of months. And you'd be sitting, you weren't supposed to talk to other parents about, because there'd be other study drug families there as well, other study families. And, excuse me. So you knew you weren't supposed to talk to the parents, but you saw them every time you went back. And you could see a change in their kids, even though you didn't really know them. You could see that their kid was now more alert. Their kid, their whole countenance had changed. They weren't as encephalopathic because they weren't having as many seizures. And so you'd start to kind of like try to talk to the other parents, like kind of cryptically, like how many seizures did they used to have? Are they having less seizures now? And so you kind of knew who was on the study drug and who was on the placebo. There was another open label study that was done using formulation with adults. So that initial study was just in kids. They did a study with adults, and there was even a more impressive improvement in seizures, a 70 to 80% decrease in seizures. And the seizures that they did have were less severe. So again, the limitation with that particular study is that the dose of CBD is much smaller than which was available in state-run cannabis programs. So it's hard to draw parallels, but at least these seeds and this growing evidence is being planted and embraced. And let's talk about efficacy with regard to psychiatric impairments. So the Journal of Psychiatry Research, again, this year, 2022, just last month, did a review on the use of cannabidiol in psychiatric disorders. And what they found, preliminary findings, were that psychotic symptoms and anxiety were significantly improved. However, as with most of these other studies, there's a need for more high quality evidence. And then the Clinical Drug Investigation Journal in 2014 did an open label. So again, that's one of the criticisms, is that a lot of these studies have used different formulations, different chemovars, and some of them, they haven't been double-blinded, randomized, randomized controlled. That's been one of the criticisms. They're not well-done medical studies. However, what that study showed is that with PTSD, there was improved sleep And we know now, after using it for significantly more years than, this came out in 2014, that PTSD is one of the wonderful success stories with medical marijuana. So let's talk a little about specifically, because I know a lot of the viewers today are in New Jersey. So let's talk a little bit about prescribing specifically in our state. So, and not just across New Jersey, but across the country, we're in a unique position as the medical community, because this is the only prescription where practitioners, I shouldn't just say physicians, because nurse practitioners and PAs are allowed to prescribe in New Jersey as well. So it's the only prescription where practitioners make recommendations about the dose and the route and the frequency, just like we would make recommendations about, if someone were going to take a blood pressure medicine, we'd say, okay, we want you to take Norvasc 2.5 milligrams once a day, and the patient would do that. That's typically how prescription medications work, with the exception of medical cannabis. We can make recommendations, but in practice, the patients have the ability to titrate their own dosing, so they can choose their dose, choose their frequency, choose their route, and they get advice from the dispensary. And this is not to downplay or poo-poo the importance of the dispensary. They are a wealth of knowledge, the employees there, but it's just kind of interesting how with other medications we prescribe, everything's so rigid. And with this, it's still a little bit nebulous. It's still, this just goes to show that this is still a burgeoning area where we're still gaining information. So in New Jersey, again, I'm not speaking about any other states. This is specifically in the state of New Jersey. These are the approved diagnoses. And it's interesting because when New Jersey first approved medical marijuana, I guess it was like, it's 2022 now, so 7 years ago, six years ago, there were only a handful of indications. One was refractory epilepsy, multiple sclerosis, a terminal illness like end-stage AIDS, terminal cancer, glaucoma. What else? Cancer. There were and ALS. Those were the 6 initial approved indications. And so look, over the past several years, the number of approved indications has just started skyrocketing, which is great, which is wonderful. The caveat is, in order to prescribe, the disorders that they have the conditions must be debilitating. So for example, if we look at the second diagnosis in the left-hand column on the list, anxiety. So not just anyone with anxiety can be approved for medical cannabis. It's got to be debilitating anxiety. For someone, the fourth one down, chronic pain. It can't be someone who, has a little bit of arthritis in their shoulder and they want to get approved for medical marijuana. It's got to be debilitating chronic pain. So that's the caveat in this. Now, debilitating, is a very individual type of definition. So there still is, again, this still is very nebulous, which I think right now, until we have really substantial laws and standardization, I think nebulous is okay because it gives us more flexibility. But yeah, look at all these. Migraine is something that's relatively new in New Jersey, a relatively new indication, which is great. And you might see in the right column, the fourth one down, opioid use disorder. Wait a minute. So I'm supposed to start using medical cannabis to treat opioid use disorder? Yeah, and here's why. Remember a couple of slides ago when I gave you, as I cited a study showing that for people who are prescribed medical cannabis for pain, they weren't using as much in the way of opioids. And so the incidence and prevalence of opioid use disorder was much lower. The death due to opioid overdose was much lower. So absolutely, medical cannabis can be used for opioid use disorder in the hopes of helping people taper down their use of opioids. So Tourette Syndrome is a relatively, the very bottom one on the right-hand column is relatively new diagnosis that's been approved in New Jersey. Dysmenorrhea, interesting. So I think this is very provocative, all of these approved indications, and I think we're just going to continue to see it expand more and more. Contraindications, and this is one area, another gray area, is that there are very few states that actually will delineate specific contraindications. So that can be a challenge, but it also can allow us as a medical community more opportunities to work with this new, relatively newly used pharmacologic agent. We know that in pregnancy, there is intrauterine growth retardation. Babies come out and they're smaller. There's more preterm labor. So, you might want to think twice in pregnancy, but I'm interested to see what the rest of the speakers have to say later today. For people who have cardiac problems, tachycardia, we know that there are Cb1 and Cb2 receptors in the myocardium. So tachycardia is a real possibility when using medical cannabis. So we do want to make sure we take caution in cardiac patients. In some instances, people who already have some psychotic symptoms, those can worsen, although we know that if you've got a higher dose of CBD, a lot of times those symptoms will be less. But be careful in patients who have a history of hallucinations, psychosis, because their symptoms can worsen. Now, with regard to, we're going to switch gears with regard to initiating medical marijuana or medical cannabis. I, as a physician, have looked at the data, and we know that with vaped formulations and inhaled formulations, there is a risk with chronic use of chronic bronchitis, lung injury, kind of no COPD, and there really hasn't been good evidence to show that there's a higher risk of lung cancer like with tobacco. But I think as a whole, we as a medical community who advocate for medical marijuana use, we do want to discourage inhaled forms. I think we need to educate patients on the duration of onset, on the time to onset, the peak of onset, and the duration of effects, kind of like what I talked about a while ago about dose stacking. We don't want that to happen. So we need to make sure that we inform our patients. I always like to ask my patients to start low and go slow. So, I read you a text early on in this conversation about a mom who was having seeing some wonderful benefits with her son who has severe autism. Well, the very first time she gave him a dose, I got this really anxious text, and she was like, "Oh my gosh, I think I gave him too much. Oh my gosh!" And it was like, "You gave him an eighth of a gummy. It's okay. It's okay. Don't worry. We're." So that's literally I'm using this to illustrate how low I will go when it comes to initiating, especially in patients who are treatment naive, who've never had any form of cannabis, medical or non-medical, because we don't know how they're going to react. So I'll have parents of my special needs parents, like literally cutting gummies into eighths or quarters, and you can always increase. You can't always go back if you've given them a lot. And then we increase every 1 to 2 days. I will increase it more frequently than every 2 to 3 days, depending on the effects that we're trying to achieve. I ask my patients to take their very first dose, especially again if they're cannabis naive, take their first dose at bedtime, so they can see how they're going to do with it. To take the first dose on a day when you have to go to work, probably not a good idea, because you don't know how you're going to react. And so if you take your first dose at bedtime and it really chills you out and makes you tired, well, that's great. You want to go to sleep anyway. So those are kind of like my rules of thumb when it comes to initiating medical cannabis. And a lot of times I have people, especially people where finances may be a barrier, because if you buy cannabis from a dispensary, it's going to be more expensive than if you get it off the street. So if I have a lot of patients who've said in the past that, well, they're using weed, I smoke weed to help me sleep already, why should I go to a dispensary and get it when I can get it cheaper, off the street? And it's, well, medical marijuana or any dispensary derived cannabis is safer. We know what the ingredients are. It's legal this way when you're getting it from a dispensary and you've got your card. because we know the ingredients, we know the ratios of THC to CBD, it allows us to titrate the dose more effectively. So there are a lot of reasons to ask people not to use street marijuana, even though they may be seeing benefits from it. And in someone who agrees to transition from non-medical marijuana use to medical marijuana, I ask them to abstain from non-medical marijuana for a couple of days. We want to kind of have a washout period. So once we start the medical marijuana, we'll be able to know the benefits they're seeing is that from the medical marijuana, and there won't be any confounding factors that we're seeing. Hopefully that makes sense. And then I'm going to try to wrap up in a couple of minutes so we've got time for question and answer. But types of cannabis. A lot of times I'll have patients ask me, well, should I get a formulation that's from the sativa, chemovar, or indica? And so let's talk about, and those are the two, most well-known and most broadly used chemovars. So with sativa, that traditionally has been the plant that causes the high that people get when they're using cannabis more recreationally. It can be stimulating, it can be energizing. A lot of people feel like it helps with their creativity and helps with their focus. And people who have anxiety feel like this is the chemovar that works best for them. People who have depression feel like they like sativa better. And because it can be stimulating and energizing, we advocate for, if you're going to be using sativa, traditionally, we've said use this one in the daytime, because we certainly don't want you to become stimulated and energized when you're ready to go to bed. And typically in sativa, again, this is typically in the past, sativa has been associated with higher THC doses and not so much CBD. Just to clarify, I don't think I mentioned this, but there is THC and CBD in every chemovar. Some chemovars have higher CBD relative to THC. So, but they all have both CBD and THC. And then if we look on the right side of the slide, let's talk about indica a little bit. So indica has not been so much responsible for a head high, but it's been felt to really relax and calm the entire body. So that's why this is a good one if you're going to want something at nighttime. You don't want something that's going to maybe induce deep relaxation again before you go to work or before you have to go to class or listen to some type of like an echo online. Now with indica, they also have high levels of THC, these chemovars, but there's also typically a high CBD dose in these as well. And again, I've been saying, typically and in the past, because in 2022, all bets are off when it comes to, saying, oh, I want sativa or I want indica. Because what's happening is there's now a new nomenclature. And because there are so many chemovars that are being bred to be hybrids, we're now, you can't say, oh, this is all, this chemovar is 100% sativa, this chemovar is 100% indica. So now they're starting to break them down into a new nomenclature, type 1, which is high THC as the primary effect. Type 2 is a combined THC and CBD, and type 3 is a higher CBD. So for example, my autistic gentleman, who the mom is having that success story, we chose for her a type 3 chemovar because we wanted him. He was ramped up. He was manic. He would go for sometimes up to 72 hours without sleeping, had self-injurious behavior. And if you're, for parents out there, if your kid's not sleeping, then the parent's not sleeping, and the entire family is really, and that's what was happening with my family as well. The entire family just becomes upended. So with her, we chose a type 3 chemovar, but there might be other people like with anxiety, where you're going to want a type 1 or a type 2. So what I advise patients to do now, rather than looking just for a sativa or an indica chemovar, each dispensary has descriptions of their different products, and they're going to be able to really counsel the patients on finding a chemovar that might be best for them. It's important, like we do with any other pharmacologic agent, to talk about potential complications, because let's face it, even though this is a natural substance, there are potential complications. So, this is metabolized through the cytochrome P450 system. And what that means is there may be interference with other meds. I'm going to, again, cite an experience I had with my son. Unfortunately for him, he was, my first experience with cannabis, and he was the guinea pig upon which I base all the rest of my experiences. And with him, he was on 3 other anti-seizure meds already. And because there wasn't a whole lot, it was a phase 3 trial, there wasn't a whole lot in the way of knowing how Epidiolex was going to interact with other meds. We just simply didn't know. Well, what ended up happening is all of a sudden he started having urinary retention, and I was having to straight cath him at least 4 times a day. He'd have like 1,300 cc's in his bladder, and I'd look at him and be like, Nick, you look like you're 6 months pregnant. And I'd palpate his bladder. I'm like, oh my gosh, he feels like he's 6 months pregnant. And, unlike most parents, I have a bladder scanner in my office. So I could like take him to the office, do a bladder scanner. But imagine, parents who don't have a medical background and don't know to look for this stuff. And lo and behold, he had like 1,500 cc's of bladder. So we straight cathed him right away. But what was happening is that one of his other meds was vying for some of the same receptors and some of the same metabolism, actually a couple of his meds. So he went to liver failure because all of his med levels were super therapeutic. One of his meds, he was on Onfi. One of the metabolites, you don't want to see a level above 3,000. His was 13,000. And we know now that that's what was responsible for his urinary retention. So we had to kind of regroup. But all this to say, this is a pharmacologic agent, and it can interfere with other meds that our patients are on. So always have an index of suspicion when someone, comes to you and they say, I started medical cannabis, and I'm kind of like noticing, ask them to be very, very open with things they may be noticing. And also, if they are on meds where you can measure the levels, make sure that you do that to make sure they're not developing super therapeutic levels or subtherapeutic levels, and make sure you're always keeping an eye on their renal function and their hepatic function. Other potential complications I alluded to a little bit ago about pulmonary symptoms. People who are using chronically inhaled formulations, whether it's through vaping or smoking, they can develop a cough, they can develop a wheeze, sputum production, almost like a smoker's cough. This is real stuff. And then new psychiatric symptoms. So although medical cannabis can be used to help with anxiety, some people with depression feel that it helps their depression. Some people also feel like it can cause depression and anxiety. So just always be on the lookout and have a very transparent association or relationship with your patient. GI symptoms, I have not seen this yet, but it is something that is very real and is reported. Cannabis hyperemesis syndrome, and I mention only because when you do see it, it's impressive. So for people who are heavy users, meaning they're using it on a daily basis, and this is whether it doesn't have to be medical cannabis, it can be, cannabis for recreational purposes as well. And this is where people will have refractory nausea, vomiting, abdominal pain. It's cyclical. My nephew actually had this. He was using it non-medically, but he went from 185 pounds to 145 pounds. I mean, it was really profound, the amount of weight loss he had. He didn't tell his doctor he was using cannabis. And so the doctor did like this huge GI workup. He was ready to go for endoscopies and everything. And it was like, let's just stop the weed and see what happens. So, so this is definitely a very real syndrome. Fortunately, I've not had it in any of my patients. And also cannabis use disorder, so people who use cannabis on a chronic basis, whether it's for recreational or medical use, about 8 to 12% of them can develop cannabis use disorder. And, the reality is that patients who are admitted to substance abuse programs, about 15% of them have cannabis use disorder on top of perhaps other illicit drugs. So this is something that can become very real, and for us to be on the lookout for. Now, these other complications or side effects, if you will, are typically associated with THC, not really associated with high CBD formulations, dry mouth, dry eyes, tachycardia that we talked about before, hypotension. And so when I was using this in my geriatric population, a lot of geriatric patients develop orthostatic hypotension just because their vessels aren't as compliant as they used to be. So we would do sitting and standing blood pressures baseline, and then every time they came in for a visit, we would do sitting and standing just to make sure they weren't developing orthostatic hypotension. Dizziness can certainly be a side effect, lethargy, paranoia, anxiety. I'm sure you all have heard of these, but I wanted to just not be remiss, and I wanted to mention them for those of you who weren't aware of these potential side effects. Something else to know is that the ingested form, not the smoked form or the inhaled form, but the ingested form converts to 11 hydroxy THC, and that form is more psychoactive. So that's just, again, something to be aware of in patients who are on ingested formulations, and the psychoactive effects can last for days. So that can be a good thing if it's working well for them. It can be a bad thing if the psychoactive effects are intrusive. So always be on the lookout for that as well. The good thing is neither THC nor CBD is fatal. And so it's kind of like this too will pass. The side effects are going to wear off. You're not going to die. And you can come back with a lower dose potentially. So in summary, I hope I've convinced you all. If you didn't already know, I'm assuming that you're here today because you already knew this, but I might be, so I'm probably restating the obvious, but cannabis is growing not only in medical acceptance, but also in social acceptance. As in New Jersey last year, it became approved for recreational use. But as medical practitioners, we need to be aware of the potential complications and interactions that it can have with our other medications that we prescribe. I demonstrated to you that there's an increasing number of approved medical indications, as we've seen just in the state of New Jersey, and evidence, the body of evidence is growing. I've cited for you some articles just from the past couple of months, just in 2022, and one as recently as March 3rd. So this is something that I agree with the first speaker, we really need to be aware of, because more and more patients are going to be coming to us asking for our opinions, and we need to educate ourselves. So if you want to know more, I would encourage you to go to a local dispensary. Local dispensaries love when people from the medical community are curious about cannabis. They love answering questions. They love giving you a little tour of the dispensary, and it's kind of fun to see. Fun. Well, no, it is fun. But it's informative as well, academic as well, but fun too. To see, Jesse agrees. To see, their process, and it's a pretty rigid process. It's really interesting. Curaleaf is, and I'm not putting Curaleaf out there because I'm not a paid speaker for Curaleaf, but I do love how they embrace the education of medical practitioners, and they've got dispensaries in South Jersey. So just call ahead, let them know you'd like to come for a tour, and they would be over the moon about it. Also, I'm seeing more and more medical conferences are having dispensaries at booths. And so again, that's a great place to stop by. I mean, I find that, next thing I know, I'll stop by just to say hi. And I'm like, oh my gosh, I've been here for an hour learning more from you guys. And also follow research. As I've shown, new studies are coming out every week, literally every week. There's also something you may be interested in. So Florida has this very active organization called the Consortium for Medical Marijuana Clinical Outcomes Research. And there are about 40 participating research centers from big universities in Florida that they meet every year. And so in May, they're having their annual conference, and it's called the Cannabis Clinical Outcomes Research Conference. And I'm not sure if they're going to have a virtual component this year. I should have checked to see, but there's an in-person component. I'm pretty sure they're going to have a virtual component this year as well. But that would be perhaps interesting for you all who want to learn more to see what the new research is that's coming out on cannabis. So that being said, I'm going to conclude my slides. Let me stop sharing. And do we have a couple of minutes for, maybe just a couple of minutes for question and answer?
We can go a little longer. It's just a lunch break.
Okay, I didn't know if there was
fine.
another speaker like right after me.
I just wanted to first thank you so much for that very comprehensive presentation. I personally loved seeing how your medical career track has totally shifted, just with your personal life experience, which I think is encouraging to a lot of medical students, that we don't have to initially right out the gate jump into something, that things can shift and change.
I have definitely evolved. Yeah.
All right. So one question I got from Olivia is there any official website where you can cross-check maybe different types of cannabis or different concentrations of cannabis with specific drugs to find out the interactions? Or is that kind of...
Not that I am aware of. And I think that's simply because there's not great data out there looking at pharmacodynamics, pharmacokinetics, and interactions. So there may be something new that's present that I'm not aware of. If anyone knows of something, let me know, because you would educate me. But yeah, it's not as simple as going to Hippocrates and putting in the meds that they're on and seeing if there's an interaction. Unfortunately, we're not there yet, that I'm aware of anyway.
Thank you. Looks like we have another question. Let me just see. Is there any literature on the difference in dosing for RRMS versus PPMS? Do progressive patients hit a wall where there's no marijuana doesn't relieve symptoms anymore?
Yeah, that's a great question. So I don't take care of MS patients. If I've got someone who's got significant MS, actually any of my MS patients, not just significant, I always have them see a neurologist. And so the neurologist is typically the one who's treating them and referring them to medical marijuana program. In my experience, I haven't seen a difference in the two different types. But I have seen people who feel that, they're not having as much benefit as they did initially.
Thank you. We have another question from Sasha. In what ways can physicians who prescribe medical cannabis help to support decriminalizing marijuana, especially that numerous people of color are still in jail where this drug is being legally prescribed?
Yep. And so I think, and you guys probably hear this all the time. Well, maybe you don't, I don't know. But I found that it's really helpful to create relationships with your legislators. As medical students, you don't really have a lot of time to do that because you're too worried about boards and, doing all these other things. But once you're out and you're in practice, I think legislators love speaking with physicians, and they love hearing how we think, because we think a lot differently than many legislators. And I think if you can go to them, like once I started seeing success with my son, I could would take pictures of him before he was on medical cannabis, and then I would say, and now here he is now, and here's how much more functional he is, and for them to actually see transformation, helps them recognize that there are benefits. And once they recognize that there are benefits, and once they recognize that many people are self-treating, which is where a lot of people who get arrested or who have marijuana on their persons, and they get become part of the legal system because of it, a lot of them are self-medicating, and they may not recognize, they might not be able to verbalize, I'm self-medicating. But I think once more studies are done, I think it would be a wonderful study to do, to talk to people who've been incarcerated or indicted for possession of marijuana. It'd be great to do a retrospective study and say, why were you taking it? Was it, were you treating and to find out, were you treating your anxiety? You know how to verbalize that. Maybe that's what you were doing. I think once we have more data, we're going to be able to make more of a case from a legal standpoint. But I do think educating, just like we're educating the medical community now, I think the legal community needs to be educated as well. And it does become really dicey in states where it's approved for recreational use. It's okay. So I got it for recreational use from a dispensary, and that's okay. But if I did get it from a dispensary, that's not okay. It's that's a really it's a tightrope that we're walking as a society. And I don't have any answers right now other than just continuing to educate.
Yeah, and to that question, I know the bill that passed in New Jersey that legalized social use of marijuana didn't retroactively pull people out of jail.
Yeah.
And that's a huge issue, in my opinion.
Yeah.
We have another question. How would you compare the psychological and cognitive effects of cannabis-based epilepsy treatment to typical anti-epileptics and GABAergic medications?
So how would I compare it to other anti-epileptics? So we saw the greatest improvement in our son's seizure count, because that's kind of, so with him, we looked at not only seizure count, because I keep a daily, he was having so many that unfortunately I had to keep a daily seizure log of what times he was having seizures. But we saw the greatest benefit when he started cannabidiols, phytocannabinoids for treatment of his epilepsy. So he had been on Keppra, Lamictal, Depakote, clonazepam, Vimpat. I mean, he'd been on so many other, there was really only one prescription anti-epileptic that he had not yet been on. We had tried so many different combinations over the years. And so we added on Epidiolex. And like I said, within 3 days, he had a significant improvement. But not only did we see an improvement in his seizures, but he is on the ketogenic diet. That was another treatment. I didn't count that as a medication, but that's another treatment for epilepsy that he had been on since he was 5 years old. And what we did in essence, and it wasn't just the ketogenic diet like to lose weight, it was really intense, where he could have like 20 grams of carbs all day long. We measured his food out on a gram scale. But what we did in effect was give him an eating disorder, because he couldn't have all this stuff that he wanted that was healthy, like carrots and blueberries. Like, no, you can only have 5 blueberries, because more than 5 blueberries is too many carbs. You can only, and so we gave him an eating disorder. Well, when we put him on Epidiolex, we saw that he wasn't raiding the fridge as much, trying to sneak food. He wasn't raiding the pantry as much. It actually suppresses appetite a little bit. So that was helpful as well. And also, we would swear that even though it was,
Looks like we lost Dr. Iannuzzelli for a minute. We will see if she pops back on for any more questions. We're so grateful that you're here. If she pops back on, she'll finish off her questions, but we'll also be heading into our lunch break anyway. And so we will have Dr. Strassman starting at 12. So we'll hang on for a few minutes to see if she comes on. But thank you for attending this talk on medical marijuana.
Yeah, and I just want to add that Dr. Strassman is an absolute legend in the field. So this is such an honor and a privilege to hear him speak. So please set your alarm for 11:55. I want to see you all back here at noon. Okay, thank you so much.
My computer just overheated. Sorry.
Oh, Dr. Inezeli is back. Wonderful.
Sorry, my computer overheated. And now I don't have my nice background. So sorry about that. But sorry about that. What I was saying is, we think that he was getting different batches because sometimes he was just happier than others. And we're like, I think this batch has more THC than the last batch. But it wasn't a bad thing because he was happy and he was calm. And so compared to other, to answer the question more pointedly, compared to other treatments for his epilepsy, we definitely were more excited about this one than others, lower side effect profile, etc. So unfortunately, it's only indicated for the two refractory indication, the refractory types of epilepsy. So hopefully
Were you able to take him off those other medications, or is he on a combination of medical marijuana and those?
Yeah, that's great. So we were able to taper down some of his other meds. So he was on 3 meds plus the ketogenic diet, plus he has a brain pacemaker, a vagus nerve stimulator. We were able to get him on a lower dose of his benzo, like a half dose. We were able to taper off one of his other meds, his Depakote, completely, and his Vimpat was on a minimal dose. So we were able to drop his other meds by at least 50%.
Wow, that's really incredible. I think we have time for just one more question. Let me see. Are there any apps, worksheets, or programs that help patients track their responses to doses or strains of different kinds of cannabis?
You know what? Not that I'm aware of. That would be a great idea, though, is for an app to be developed. And I'm gonna have to talk to my friends at Curaleaf and see if they would be willing to take that on, because I think that's a really great idea. But no, not that I'm aware of. So like we tracked ours on an Excel spreadsheet. And with our son's seizure diary, you know, we're tracking all of his carbs and everything. So we just kind of added that in as so we were doing our own thing, but not that I'm aware of. That's a great idea.
Well, I think that's the bulk of the questions that we have for right now. Thank you so much for coming today, Dr. Andy, and just hearing from you, and especially your vulnerability and talking from personal experience, not just from an academic standpoint.
And thank you all. I mean, it's so encouraging for me as a physician to see med students spending part of their Saturday to come learn and to have open hearts and open minds. I think that's just brilliant, and so I commend all of you for your pursuit of improving medicine.
Awesome. Well, everyone, we are going to put on our welcome slide. We'll be back right at 11:55 to introduce Dr. Strassman. Go grab some lunch, do a quick meditation, go for a run. Just get excited for what the rest of our day has to offer. Thank you so much.
Thanks, everyone.
Hello, good morning, everyone, or good afternoon, should I say. I hope you all had a nice lunch, had a moment to chew over what our first 2 speakers brought us. Our next speaker is Dr. Rick Strassman. He is a native of Los Angeles. Rick Strassman obtained his undergraduate degree in biological sciences from Stanford University and his medical degree from Albert Einstein College of Medicine of Yeshiva University. He trained in general psychiatry at UC Davis in Sacramento and took a clinical psychopharmacology research fellowship at UC San Diego. Joining the faculty at the University of New Mexico School of Medicine in 1984, his clinical research with melatonin discovered its first known function in humans. Between 1990 and 1995, he performed the first new U.S. clinical research with psychedelic drugs in a generation. His studies involved DMT and, to a lesser extent, psilocybin, and received federal and private funding. From 1995 to 2008, he practiced general psychiatry in the community, mental health, and private sectors. He has authored or co-authored nearly 50 peer-reviewed papers, has served as a guest editor and reviewer for numerous scientific journals, and consulted to various government, nonprofit, and for-profit entities. His book, DMT, The Spirit Molecule, has sold 250,000 copies, has been translated into 14 languages, and is the basis of a successful independent documentary that he co-produced. In 2008, he co-authored Inner Paths to Outer Space. He also has written DMT and the Soul of Prophecy in 2014, and his first novel, Joseph Levy Escapes Death, appearing in 2019. Dr. Strassman is currently Adjunct Associate Professor of Psychiatry at the University of New Mexico School of Medicine and lives in Gallup, New Mexico. It is my absolute honor and pleasure to introduce this legend of science and medicine, Dr. Rick Strassman. You have the floor. And we cannot hear you just yet. Not quite yet. So you are unmuted on our side, and make sure your microphone is on your side. And if we need to take a few minutes to fix any issues, that's fine.
So is
You're starting to come through.
yeah, I had to change the microphone. Can you hear me all
Perfect.
right?
Sounds crystal. Glad to have you with us, Doctor.
Okay, good. Yeah, I've got two microphones I switch between. Well, so share screen. Now, how do I? There's share. Well, before I start, I'd like to thank the organizers of the Psychedelic Medicine Conference, including Jesse, Magdalene, Jason, and Ayesha. It's a pleasure to be here. I like teaching students. Students are the future, so more power to you all. So let me see about sharing screen. There you go. Oh, one thing before I start, I'd like you all to know that I have a new book coming out, which I'd like to show you the image of, if I can find it. Yeah, so can you see that?
Unfortunately, not yet.
Okay, here, let me get back there. Yeah, sorry about the,
That's fine. We've scheduled in time for technological hiccups. So,
yeah.
All right. I think it's starting to come through here.
Okay, yeah. So that book's coming out in June. I just sent in the major revision a couple weeks ago. It's called the Psychedelic Handbook. It's intended for the psychedelically naive but curious. And the cover is a bit, what's the word? Misleading. It's a pretty serious book. It's got the day glow and the swirly stuff, but it's pretty rigorous. Today I'll just be talking about the classical compounds. I won't be talking about ketamine or MDMA or salvia, which I do discuss in this handbook. So it's coming out in June. It's available on Amazon. So just wanted to let you all know that. Okay, so let me get off of here. Can you see that?
Not the presentation yet.
Okay, so how's that?
Perfect. Full screen, looks crisp.
Okay, good. Okay, yeah. So we had talked about me just kind of reviewing the field, and I'll be sticking with the classical compounds. For today's talk. Let's see. There you go. Okay, so the history. These compounds have a long history of human use. For example, peyote. The peyote cactus and the San Pedro cactus contain mescaline. and people have been using ayahuasca in South America for perhaps thousands of years. There's snuffs too, DMT containing snuffs, which have been in use for a long, long time. There's a compound called ibogaine, which exists in a shrub that's found in Africa, and that's been in use for a long, long time. And psilocybin mushrooms are cosmopolitan. They pretty much are all around the world and contain psilocybin. The modern era began in the 1890s when German chemist isolated mescaline from peyote. So these were the wonder drugs of psychiatry in the 50s and the 60s. The pharmacological similarity between LSD and serotonin, and the structural similarity between LSD and serotonin led to the discovery of serotonin as the first neurotransmitter. And so LSD was the most popular compound studied back then. It was used as a psychotherapeutic aid. It was used for depression, a host of conditions, substance abuse disorders, end-of-life care, pain, autism, psychosis even. There were a number of biochemical theories of psychosis which devolved from the study of psychedelics as well. For example, did the body make an LSD-like substance, and if so, if you block the effects of LSD, would that be an antipsychotic? And a smaller number of studies gave psychedelics to see if they could improve empathy in therapists working with psychotic patients. In other words, if you entered into a brief model psychosis, would that increase your understanding of the productions of your patients? Confusion, disorganized thinking, hearing things, seeing things that other people don't. So almost as quickly as they became the wonder drugs, they became the horror drugs. There were increasing reports of adverse effects, both psychological and medical, even though the medical ones were disproven later, chromosome damage and birth defects, those never really panned out. But there were, lots of emergency room, visits, lots of inpatient hospitalizations, flashbacks, suicides. The Summer of Love also coincided with Charles Manson and his killers, and LSD was implicated in some of his work with his followers. Clandestine use started leaking out as well. There was an army project, a CIA project, to give people psychedelics unwittingly, and also attempts to brainwash people, turn them into assassins, those kinds of things. And it was a public health emergency, pretty much. And the Controlled Substance Act of 1970 was passed. And it created impossible to get through firewalls, and clinical research stopped. At the same time, though, basic psychopharmacology continued and was responsible in a lot of ways, for the development of SSRIs and the second generation antipsychotics, through the study of LSD and other compounds in the basic science lab. So studies began again, clinical research began again. There was a German study studying mescaline, and I think it came out in 1989 in Biological Psychiatry. And around that time, I was working on getting my permits together for the DMT study, which began in November of 1990. We also did some psilocybin work, which we didn't publish, but mostly DMT work. Plus I had LSD on hand. I imported it from the Swiss, but we never got around to studying it by the time my projects wrapped up. So after I established a means by which you could do Schedule 1 human studies. Other groups, called and, they said, we want to do this, how do you do it? So I described how to do it. There was a so there was a psilocybin study at the University of Arizona using it, for OCD. There's an MDMA study at both UCLA and Wayne State, and some preliminary work in Miami giving ibogaine to normal volunteers in anticipation of some anti-addiction work. And the psilocybin studies started coming out of Hopkins at around 2005. And because of the conflation with spirituality and psychopharmacology, their studies got quite a bit of press. So the last couple of years, there's been a huge upswell or groundswell or tsunami of interest in psychedelics. From the media, there's money pouring into startups. There's retreat centers, mostly in Latin America. There's new academic divisions. There's movements to increase access to psychedelics through the decriminalization and legalization movements. So the types of psychedelics are the classical compounds. You will see the term classical or classic, and for whatever reason I like classical, even though I don't think it's quite as popular as classic. But that's like classical music. You don't call it classic music. You call it classical music. But in any event, the classical compounds include the tryptamines, which contain psilocybin, LSD, DMT, 5-methoxy-DMT, which is in the toad venom, and ibogaine. The structures of ibogaine and of LSD are a bit more complex than what you would call the simple tryptamines, but they both have got a tryptamine nucleus. And if you're a lumper or a splitter, you can lump them, together in the tryptamine family. The only well-known classical compound among the phenethylamines is mescaline. Even though MDMA is a phenethylamine, it isn't quite psychedelic. Well, there are classical or close to classical compounds which belong to the phenethylamines. Some of Shulgin's compounds, like DOB, DOI, DOM, but those are at this point pretty obscure. So ketamine is called a psychedelic, and if you give sub-anesthetic doses, it is a psychedelic, and it's an aryl cyclohexylamine. It's been increasingly popular as an antidepressant. It's also being used in emergency rooms and in clinics as well as an acute treatment for suicidality, and it's been used for pain for a long, long time. So there's MDMA. It's a phenethylamine. It's been studied quite intensively for post-traumatic stress disorder, and it's helpful. Within a specific context, like 3 sessions, manualized therapy. The main problem with MDMA is that the window, the therapeutic window, to avoid neurotoxicity is fairly narrow. So you have to limit exposure, you have to limit dose, and that's not the case with the other compounds. And salvinorin A, which is a compound extracted from a plant called Salvia divinorum, is a terpene. It isn't an amine like the rest of these compounds. It contains no nitrogen, and that's a very weird and potent substance. It's almost as potent as LSD, actually, if it's smoked or inhaled. Most people don't like it, but still, it's being studied somewhat, and in the future may see some use within psychiatry. So the classical compounds. Well, so the physical effects are fairly similar across the board. There's some pathomimetic, they increase, blood pressure, heart rate, core temperature, pupil diameter. And, that's especially the case with parenteral administration, like smoking, injecting IV or IM. Back in the day, the main way of assessing receptor activity of compounds was the neuroendocrine approach. There were animal data about what receptors were mediating the release of what compounds in animals. And so we use that approach to either confirm or refute the animal data, vis-a-vis which serotonin receptors were being activated by DMT. So they increase a number of neuroendocrine variables, prolactin, cortisol, ACTH, beta endorphin, and growth hormone. So psychological effects. So that's the reason that people trip isn't for their neuroendocrine effects or even the functional connectivity changes in the brain. It's for the subjective experience. The unique thing about psychedelics is that they modify every element of consciousness, as opposed to the stimulants which only elevate energy and attention, or the sedatives which calm you down, make you sleepy. So these modify every element of consciousness. They modify your mood. You can experience abject terror to indescribable ecstasy. Your thinking speeds up, slows down, is more novel. One of the striking aspects of the psychedelic experience is the feeling that what you're witnessing or experiencing or apprehending is more real than real. And that's been called a number of things. One of my old mentors, Daniel Friedman, you referred to it in the 1960s as portentousness. This feeling of portent, like this is the most important, intense, meaningful thing that's ever happened. And Ido Hartogsen from Israel has coined the phrase meaning enhancement. Well, perceptual effects are quite common, especially visual. You'll see things that aren't there with your eyes closed, especially. The room starts to melt and shift and pulsate. Colors are much brighter or duller. With DMT, it's a completely visual world. They're spinning, morphing, rapidly shifting color, things in your visual field with eyes closed. Your sense of self is affected. You'll lose your sense of self or self-control. You will feel your sense of self even more. You'll understand your role in existence. You might feel, fused with all being, with all existence, or you might feel abjectly alone. If it's been a good trip, you'll have an afterglow, which can continue for a few days, even a few weeks afterwards. And that actually corresponds to the neuroplastic properties of these compounds, which continue for a few weeks after exposure. At least in lower animals. So the reason I got interested in these compounds in the first place was because of the similarity between descriptions of the psychedelic state and descriptions of states which occurred as a result of meditation. This was the 1970s, California. I was at Stanford, everything was going crazy. There were other than the war, there were psychedelics and transcendental meditation, and all these Eastern teachers were coming in teaching meditation practices. And I thought, well, there must be some common biological denominator mediating the meditative experience and the psychedelic experience, and that got me into looking at those questions more scientifically. So there are a number of non-drug technologies which can induce an altered state that shares features, with the psychedelic state: prayer, meditation, fasting, sleep deprivation, and so on. The near-death experience does. The alien contact experience does. Dreams, share features, with the psychedelic state. Psychosis as well. So these compounds have a lot of names. You won't, find this many names for any other class of compounds. Back in the day, the most, popular medical legal term was hallucinogen, but that's kind of clunky because perceptual effects, even though they occur frequently, they don't occur all the time, and it kind of begs the question about what is a hallucination. And it's kind of disparaging as well. Like it implies that what you're experiencing isn't real. And that's completely in contradiction to the conviction that what you are witnessing is more real than real. Psychotomimetic was a popular term, especially in Europe. People were struck by the overlap between psychotic symptoms and LSD's symptoms, and it was also called a schizotoxin. And psychotomimetic is still in use in Europe in a few groups. Obscure term is oneirogen, or dream generating, and that specifically refers to ibogaine. And I'm not sure if that's because the subjective experience is unique compared to other psychedelics, or if it's just a term that got attached to it, coincidentally. Like after you've experienced the most intense part of an ibogaine trip, you're in a dreamy state for another 10 to 12 hours, but it isn't really like a dream. The intense part is as much like a dream as any other psychedelic. So I'm not sure why exactly that people call ibogaine and oneirogen. The MDMA-like compounds are called empathogens or entactogens. That's kind of a niche term, and it refers to the emotional quality of those drugs. There's a couple of related terms which I kind of have a bone to pick with, either entheogen or mysticomimetic, and it assumes a lot. Number one, that there is a spiritual level of existence, and especially God, because entheogen, generating the God within. It also assumes, that divinity is within us as opposed to outside of us, which not everybody believes. It also assumes that you can, generate divinity or a real religious experience from taking a drug, which I think, lots of, theologians and, more, traditional people would object to. So you're turning off a lot of people who might otherwise benefit, from taking a psychedelic. And I don't like the term. You might be able to tell. The best term is psychedelic. Mind manifesting, mind disclosing. It casts the widest net. It reveals what was previously invisible, but still was existent. So it's material that you were more or less conscious of before. And these compounds manifest what's in your mind, in your unconscious, your subconscious, your conscious mind. Stan Grof, who probably gave more LSD than anyone, has called these compounds non-specific amplifiers of the unconscious. But I think they're non-specific amplifiers of the conscious mind as well, and the subconscious mind. They shed light on things or make more true things that you're already more or less aware of. So for example, if you're an atheist and you experience God on LSD, that does not mean that LSD is entheogenic. It means that you were in the back of your mind wondering if there were a God, and on LSD you're convinced that there is. So it isn't as if these drugs inherently possess spiritual properties. That's one of the questions I brought to bear on my DMT work. Is DMT pharmacologically spiritual. If I don't coach people, if I don't, tell them what to experience, if I don't go blah, blah, blah about entheogens, what's the experience like? And they just had their own trips. Software designers saw, zeros and ones. Somebody, with an interest in the near-death experience had one. Somebody, that was interested in a mystical experience had one. An urban shaman was, dismembered and then put back together. Somebody else, worked through some, personal trauma. So everybody had their own trip. It was not like uniformly spiritual. I was expecting everybody to have a Buddhist enlightenment experience, and most of my volunteers were expecting that as well. But surprise, they just got the mind manifesting or the mind disclosing effects. Well, so key to giving psychedelics and taking psychedelics is the notion that started coming out in the 60s, especially from Tim Leary, is the issue of set and setting. You have to optimize your set and setting. If your set and setting are bad, chances are you'll have a bad experience. If your set and setting are good, then chances are you'll have a good experience. So the set is one's state and your traits, and this basically is who you are at the time you trip. So your mental state, your physical, spiritual state, your intention, your preparation, your previous experiences, were they good or bad? If they were bad, you'll expect a bad trip. If they were good, you'll be looking forward to it. Your hopes and fears, your expectations. States and traits also include suggestibility. Like if you're told you'll have X, Y, and Z kind of trip, and you're suggestible, the chances are that you'll have that kind of trip, more so than if you weren't suggestible. Selection bias as well. If you volunteer for a study with psychedelics, that means you're interested in psychedelics. And if it's a depression study, let's say, you'll volunteer because you believe that psychedelics might be helpful. And people like that, may respond to psychedelics completely differently than a depressed person who's not interested in psychedelics and thinks they're bad. So I think with the microdosing data out there, you really need to think about selection bias. Is the people that answer those questionnaires are, well, they're self-selected. They're microdosing because they have, because they hope microdosing will help them. Well, so setting is physical, indoors, outdoors. Is it therapy? Is it research? Is it religious use? Is it fun? Is it just to appreciate aesthetics more? And quite importantly, the setting includes the set of those people that you're tripping with. Are they friends? Are they enemies? Are they neutral? Are they researchers? In which case, ultimately, they want something from you. Either blood, responses to interview questionnaires, for you to improve, those kinds of things. So potential benefits, it's kind of a joke, but it's not quite, because it's true. There are either laboratory-derived data or strong field data, survey data, either from this current wave of studies or from the 60s. That psychedelics can improve depression, alcoholism, substance use disorders, PTSD, eating disorders, OCD, pain, existential distress with either terminal illness or chronic AIDS, autism, sociopathy, prisoner recidivism. The list goes on. There's also indications for improved wellness, like meditation, nature appreciation, your domestic relationship, it makes it increases openness in your personality, makes you more compassionate. It alters your metaphysical beliefs. makes you more progressive, increases therapist empathy, increases your appreciation of music. So, what does that sound like? Like a panacea. And I think we need to get back to that in a few slides. Because they do what you want them to do, either as a researcher or as somebody that takes them. And there's no other drugs like that. So it's an interesting phenomenon, and I think it underlies their benefits is their ability to act like panaceas. Okay, so potential risks. Well, in this new book, the Psychedelic Handbook, I apologize a few times for being a doggy downer, saying, oh, they're not all glorified drugs. You'll have problems with them, and people do. You have to optimize the benefit, and you have to minimize the adverse effects. So in the field of both research and in the larger community, there's a move to relabel adverse effects as challenging experiences, and they've even come up with a challenging experience questionnaire. But that kind of flies in the face of medicine. Like you don't call a skin rash from penicillin a challenging experience. You don't call a cardiac arrhythmia from an anti-arrhythmic drug or an asthmatic inhaler a challenging experience. It's an adverse effect. And I think to call adverse effects from psychedelics challenging experiences takes them out of the field of medicine. And that's not a good idea, in my opinion. It's like calling them entheogens. It takes them out of the field of medicine. So I think we need to be careful about that. Otherwise, it'll be a cult. It'll be a clique. So I don't think we want to isolate ourselves from the larger psychological and medical traditions. So you can call it adverse effect, acute, medium term, long term, and mild, moderate, and severe. So the classical compounds are physically safe. Speaking of adverse effects, they're non-addictive. You don't withdraw when you stop. Your tolerance develops rather quickly to repeated use. If you take LSD every day for the same at the same dose for 3 or 4 days, you really don't have much of an experience. And if you're abstinent for a comparable number of days, your sensitivity returns. That's not the case with DMT. You can give all the DMT you want, and people don't become tolerant. And that also, could be the case, for 5-methoxy DMT. There's also, the possibility of sensitization in the case of 5-methoxy DMT. In cats anyway. Not quite kindling, but sensitization. The one compound that stands out as perhaps more physically toxic is ibogaine. It will prolong the the QTC interval, and you may have some adverse effects on the cerebellum. So these compounds, especially the more dangerous ones, you always have to think about the risk versus benefit. For example, if you're a hopeless cocaine addict or opiate addict, ibogaine could be your ticket. But if you're just interested in tripping on ibogaine with some friends, it might not be so much. So potential risks continued. Okay, I guess I repeated that first part. Yeah, so there are clearly acute psychological adverse effects. Everybody experiences some anxiety at some point in their psychedelic experience. A very small number of people have major problems afterwards. After they come down, like anxiety, depression, suicidality, those kinds of things. So usually they just, get better on their own or with a little bit of, peer support. And, peer support, groups are increasingly visible. I think there's a project out there called the Fireside Project. You can call them if you're having a bad experience or you haven't quite come down after the drug has washed out. You're still feeling unsteady. If you screen people carefully, you supervise them carefully, you follow up carefully, the chances are quite small of any adverse effects which extend beyond some transient rough spots in your experience. In studies where they give small doses of psychedelics, there was a Hopkins study a number of years ago, giving psilocybin to the terminally ill, and it involved a big dose and a microscopic small dose. And one of the subjects got a microscopically small dose and was disappointed, like they had built up the mystical experience, like the mystical experience is going to make you feel way better. And he just got a microdose. It didn't have any effect, and he killed himself 11 days later. So you really want to be open-minded about what you tell people to expect when you're giving psychedelics. You don't, hold out the orgasmatron and you say you're going to have a complete mystical experience or an incomplete one, and if you have a mystical one, then certain things are going to happen. I think we need to keep ourselves kind of level-headed. Yeah, so I've got, 3 slides of potential risk. Oh, actually, 4 slides. So I might be kind of depressing, but still, I think if you don't pay attention to the potential risks and they come up, people are going to say, oh, I thought you said these were entheogens. Why is my son psychotic and in the hospital? So in a small number of people, especially those who overdo it or take psychedelics in traumatic situations, they may precipitate psychosis. But they're vulnerable. I mean, that's my impression. I published a review of adverse effects of psychedelics in 1984. I figured the first objection people would raise when I said I want to study DMT is you cannot give these compounds to people safely. Look at the literature, and I did. I reviewed every paper I could get my hands on, and if you screen, supervise, and follow up people, the frequency of these kinds of problems are extremely rare, like 0.1% or 0.01%. But still, if you've been psychotic, if there's a family history of psychosis, you shouldn't be tripping. And ultimately, it's probably a case of experiencing the psychedelic as being traumatic, and it's like any other trauma, which will precipitate psychosis, like marriage, divorce, birth of a child, death of a child, being fired, being promoted. The consensus is the kinds of symptoms or the kinds of syndromes were more closely related to mania than to schizophrenia. But in either case, or in any event, you treat the disorder or the condition as if it were not drug precipitated. So if it's a manic-like episode, you just treat as if it were homegrown mania. Clearly you want to stop using psychedelics. So flashbacks, those are now called post-hallucinogen perceptual disorder in the DSM, and the cultish academic newspeak out there is calling them reactivations. It isn't as bad as challenging experiences or more entheogens, but still it's unnecessary. You can call them flashbacks, and I think if you do call them flashbacks, it will give you a foothold in understanding their etiology and their treatment because of their resemblance to flashbacks in post-traumatic stress disorder. The problem with post-hallucinogen perceptual disorder is that they occur within all they occur within all categories, perceptual or emotional or somatic or cognitive. So to limit them as perceptual, I think, is unnecessary. They're pretty frequent. There was a 5-methoxy DMT study came out a year or so ago. 70% of people that smoke the toad have flashbacks, and I get calls from smokers of the toad every so often saying, I have panic attacks. I wake up in the middle of the evening or in the middle of my sleep with a pounding heart. I can't breathe. But usually, they're mild and they resolve with abstinence. And some people, they could be troublesome. They interfere with your life, and they are probably more common with heavier use. But that's not always the case. You can have one LSD trip and develop flashbacks, but that's quite rare. Compulsive use. Maybe, let's see, my DMT book came out 21 years ago now. And I think I've probably gotten 10, 15 emails, with a subject line, your book and my son. And it's about some kid who just has gone over the deep end, taking psychedelics, especially DMT. And, they're in the hospital, they're in prison. They're grandiose with really bad insight. And they won't take meds. They think they've got the answer to the world's problems, that they're the Messiah. So that does happen. But like I said, I've gotten 10,000 emails probably in 21 years, and I probably got less than a dozen cases like that. But still, it can't happen, and you do wonder about their vulnerability. So potential risk continued. There are adverse effects of the setting. There are clearly unscrupulous practitioners out there, both in Latin America, Northern America. People who sexually abuse you when you're under the influence, financially abuse you, kind of turn you into some kind of disciple. Create a cult among people that are dependent and vulnerable and increasingly suggestible. Also, the mismatch between one's experiences and the model. I was discussing that suicide and the terminally ill psilocybin study, and that could be the case as well. If you're in a shamanic group and nobody believes in God and they kind of poo-poo God and Jesus and the Bible, you may feel those are very important in your life. And if you hear people kind of dissing your closely held beliefs, that can be traumatic. Okay, so enough adverse effects. I need some coffee after that. Hooray. So the biology, we understand pretty well that these compounds stimulate the 2A site, the postsynaptic 2A site, in the parts of the brain that you'd expect, the cortex, the limbic system, the visual cortex, the hippocampus. And there's a lesser role, but an important one, for the 1A and the serotonin 2C sites. There's a lot of functional MR data now. As compared to when I was doing my studies, it was neuroendocrine data, which was one step removed from even fMRI data. Now we could look at connectivity among various brain centers. So a lot of emphasis is being placed on the default mode network, which is a series of nodes in the brain, which connect in a circuit, to give you this sense of self, your sense of I, what might be called the ego, mediating, between the outside world and your inner world. So there's, decreased, connectivity within the DMN, and there's enhanced, connectivity between the DMN and other circuits, and other sites. So there's less control of the self on, the unconscious material, so to speak. And, that unconscious material could be, memories, perceptual things, feelings, ideas. So that is what is referred to as, decreased, top down. I'm sorry. So that should read, decreased, top down. So the ego is less influential on unconscious or subconscious material. And there's increased, bottom up communication. And so the unconscious or subconscious things bubble up. And this basically confirms one's subjective experience, which is nice. If it didn't, then you kind of wonder, but still it confirms one's experience objectively. Carhart Harris has coined the term rebus, which is relaxed beliefs under psychedelics, to kind of describe his theory of connectivity impact of the psychedelics. One interesting or a hot topic nowadays is mostly coming out of a lab at UC Davis, David Olson, and UNC, Brian Roth, is the ability of the classical compounds and ketamine to stimulate the growth of new neurons from stem cells. Also, they stimulate neuroplasticity, which is the interconnection among neurons, synapses, functional synapses, dendrite, length, and complexity of the growth cone spikes. It seems to be mediated by the 2A site, but at least in lower animals, that 2A activation can be separated from the psychedelic effects in lower animals. The screening tool for psychedelic effects in lower animals is a thing which is called the head twitch response. If you give LSD in a big enough dose, it'll cause a head twitch in a mouse. And if you give a non psychedelic compounded, it will not cause a head twitch. So these are you can give small doses of psychedelics, which do not induce a head twitch, but still are psychoplastogenic. And you could develop compounds which are not psychedelic at all at any dose, which are also psychoplastogenic. There's a congener of ibogaine, there's a congener of DMT, which at least in lower animals are not psychedelic, but are still psychoplastogenic. And those compounds seem to be efficacious in animal models of depression, anxiety, drug administration. These compounds also have anti-inflammatory effects, especially DOI, which is a phenethylamine classical compound. It's like the most potent anti-inflammatory agent out there, or something. So I think we're going to be seeing increasing uses of non-psychedelic compounds or small doses of psychedelics for non-psychedelic effects. But still, people, at least nowadays, take psychedelics for their experiences. Well, so how do psychedelics work? Psychologically, if you're doing psychedelic assisted psychotherapy, I think that they enhance the components of normal everyday psychotherapy. They stimulate the transference. They'll help you retrieve memories. They'll provide emotional catharsis. You'll be able to visualize and somaticize unconscious mental material. So it's the subjective correlate of the relaxed beliefs under psychedelics. Well, so I spent a number of years studying and practicing Zen Buddhism, and I have an affinity to Buddhist psychology, which is called Abhidharma. And Abhidharma teaches, that ongoing mental experience is a seamless, weaving together of a hand full of mental components. But if you trip or if you meditate, you would be able, to deconstruct what seems, like a coherent sense of self into its component parts, which ultimately would lead you, to an enlightenment experience or ego dissolution, what is called, nowadays. And it automatically, by some, by hook or by crook, will liberate you, from suffering. Suffering is contingent on a sense of self, which reacts to certain situations through, not having what you want or having what you don't want. If you can if you can dispense with the concept or the construct of you, then suffering resolves. So there are groups using CBT, for example, and I think it would be consistent with psychedelics enhancing CBT, through the mechanisms of CBT. You could you could connect to your feelings more. You can come up with new ideas, which you believe are more true now than they were before, more applicable. As a result of the meaning enhancement effects of psychedelics. Oh, so there's Aristotle. That's a kind of a pet project of mine. I wrote that book in 2014 on the prophetic state and the DMT experience, and I studied the medieval philosophers, especially the Jewish ones, who rely on Aristotle's metaphysics. So Aristotle divides the contents of the mind into the imaginative realm and the rational realm. Those are two compartments in the mind. The imaginative realm is called the imagination. But it isn't imaginary. It isn't like made up or make believe. It means anything which is perceptible. So that could be emotions. It could be sensations. Visions. Voices. It's your body. Those kinds of things. So the rational faculty is everything else. It's non-corporeal. It's the expression. It's ideas, concepts, mathematics, abstractions, those kinds of things. So when I was giving dose after dose after dose of DMT, it became clear that the effect was primarily, in retrospect, on the imagination. It catapulted people into a unique kind of world. But it was imaginative. It was emotional. It was visual. It was somatic in as much as you lost awareness of your body. So the rational contents, the information other than the existence of that world and people's painstakingly careful description of that world, other than the description of the nature of that world, the rational content that people came back with, was nowhere as articulated, sophisticated, novel as the imaginative contents. The intellectual information that they extracted was personal. You could link it directly, to that person. The software designer, the nurse interested in NDEs, the shaman. So that after a point, or as I started to look into other models, for the mind and how they could help explain the psychedelic effect, is that psychedelics mostly stimulate the imagination. So if you have a stimulated imagination, the specific content of the imaginative contents, the visions, for example, contain information, and it's up to the intellect to extract the information from the contents of the imagination. So if you see like a car, for example, that's the most far out car you've ever seen. you could go home and say, well, that was the most, far out car I've ever seen. But if you've been, working on your intellect and, preparing yourself, through the set, you could think about, what is a car? What does it represent? How might it, fit into my life? Like am I moving ahead? Am I, not moving forward? Am I moving backward? So you can extract information, depending on your intellectual ability to extract, meaning from the state itself. Well, so there are these things called beings. It occurs frequently after DMT. You'll close your eyes, there'll be this world that appears in front of you, and all of a sudden, there are these things that are looking at you and you're looking at them. And, they could, take any form. They could be plants, cactus, they could be humans or humanoids, they can be insects, they could be furniture, they could be spinning balls, they could be anything. But they can be pretty startling. It's hard to communicate with them, especially at your first encounter with them. They're quite powerful, they're sentient, they have strength, they have will, they interact with you. They may even be expecting you. They'll do stuff to you. You might be able to do stuff to them, but isn't as common. It occurs it occurs frequently after a high dose of DMT, and it also occurs, frequently after Salvinorin A. And I think, rather than, knock yourself out and think, well, is this just my brain on drugs, or am I, seeing into, parallel universes or dark matter? I kind of went down that, road when I wrote the DMT book, but I think that's just impossible to say. I think the most generic explanation is that they represent previously invisible information, and to make the most of your experience, you need to be able to make contact, to communicate, to get information, ask them questions, and you see, and well, to see what happens. Subjective experience and outcome. Well, that's a controversial point. First of all, with the development of the notion of psychoplastogens, non-psychedelic psychoplastogens, there's beginning to be debate, like, do you need any subjective experience at all, or is it simply you're growing new brain cells and the connections are stronger or more complex? If you do believe a particular subjective experience is required for cure or for healing, like for example, of depression, it depends on your model. If you believe a mystical experience is correlated with improvement, you'll develop a mystical experience questionnaire. People score high on it, and that score corresponds to improvement. But back in the day, in Saskatoon, Saskatchewan, Canada, there was a group that believed that that LSD caused a time-limited case of the DTs, which occurs in bottoming out alcoholics, and it is frequently the case that when you have the DTs and you come through them, if you don't die, you'll stop drinking. You just will have been scared stiff or scared straight. So they gave their alcoholics big doses of LSD, and they said this is going to induce a temporary state of the DTs, and get ready. And I don't think they developed a questionnaire, for the DTs, but if they had, it would have contained items like, that's the worst experience I've ever had. I was poked by the devil with his pitchfork. I, was afraid I was going to die. I've never been so sick. God help me. And I can bet you that scores on that scale would have been quite high and would have corresponded with improvement. So you really need to step back and look at the rating scale, and you look at the model from which the rating scale devolves. And I think what may be the case is that it isn't the specific experience which is correlated with outcome, but the overall intensity of the experience, rather than the specific quality of the experience. There was a number of years ago, there was a study out of UNM, giving psilocybin to alcoholics, and it was quite helpful. And we gave a number of questionnaires. The mystical experience scale, my questionnaire, which is based on Abhidharma psychology, and what seemed to be the case was that the overall intensity was more important than the specific nature of the effect. So that leads to one of my pet theories nowadays is psychedelics, panaceas, and placebos. If you look at the list of conditions, both pathological and wellness oriented, that seem to improve the psychedelics, they seem to be panaceas. So they seem to do whatever you want or whatever the people that you give them to would like. So you can have your mystical experiences, or you can confirm your crazy ideas. The Hells Angels were the biggest purveyors of LSD in the Bay Area back in the 60s, and there's plenty of neo-Nazi groups which have retreats. They take LSD and they're more confirmed in their ideology. Charles Manson did the same thing with LSD. So I think what occurs is that psychedelics increase, so psychedelics, there were some studies from the 60s and some confirmatory studies just a few years ago, which indicated that that LSD increases suggestibility. And suggestibility corresponds to hypnotizability. So if you're more suggestible, you're more prone to being hypnotizable, as it were, and those correlate or interact with the placebo response. If you expect certain responses to a drug, chances are you will have that response. And so those responses are real biological responses. Pain control with placebo is reversible, giving naloxone, and there's all kinds of fMRI changes which occur in placebo responses. So the placebo response is a biological thing. It's what I like to consider the innate healing mechanisms, which are inherent in the mind-brain complex. So if you can steer the placebo response, if you can enhance it with psychedelics, which may be reflected in an intense enough subjective effects, you will be steering your outcome in the desired direction. So the psychoplastogenic effects may correspond to the biology of placebo, which hasn't really been looked at yet, but I think is a very promising area for future research. So if you give LSD, you're more suggestible. If you're more suggestible, the effects of LSD are stronger. That was confirmed in the 60s. And so those will both combine to increase the placebo response. And you might be experiencing the activation of the placebo response if you attain to an intense enough experience. Although the placebo response occurs completely out of awareness. It's just kind of chugging along. But there can be correlates, subjective correlates of its activation. So let me briefly go through the individual drugs. You can find those in any textbook. So LSD is a laboratory creation. It was discovered in the 1930s in Switzerland, and was discovered to be psychedelic a few years later. And it was the most popular compound. It's quite potent, 100 to 250 micrograms. It's a long day, 10 to 12 hours. There's mescaline. So mescaline was extracted from the peyote cactus back in the 1890s, early 1900s. But it's got more GI side effects. It's a long day, and it really never attained or gained much in the way of interest within psychiatry. And I don't think it was only because of its side effects or its pharmacological profile. I think it was in the wrong place at the wrong time. Back then, Freudian psychoanalysis was king, and to give a drug that was associated, with the Indians and cause spiritual effects, it just really wasn't an especially easy sell. It's in peyote. It's the sacrament for the Native American Church, which is the largest spiritual organization among American Indians. It's in San Pedro as well. It's got GI side effects. So psilocybin is the most popular drug now, but people are interested in LSD. I mean, it's kind of the grandfather of them all, and it acquired a lot of cultural baggage back in the day. But I think with the increasing acceptability of psychedelics, there's going to be more research with LSD. But currently, psilocybin is the most popular. It's natural. You can grow it at home. The pure drug is active at about 20 to 30 milligrams, about 6 to 8 hours. The number of mushrooms depends on the potency. So DMT is endogenous. It's made in the rodent brain. We know that for sure now from a 2019 study. It's ubiquitous in nature. Levels in the rodent brain increase strikingly, when the animal is killed, especially in the visual cortex. So that supports the notion of endogenous DMT playing some role in some of the aspects of the near-death state. It's smoked or injected if it's the pure drug, 30 to 60 milligrams. It's quite short. Starts within a few heartbeats with the smoked or IV route, and it's over in about a half hour. There's a lot of popularity with ayahuasca, or for ayahuasca, it's an Amazonian brew, which is mostly a combination of two plants. One contains DMT. If you swallow DMT, it'll just break down in the gut because of MAO. But if you combine it with with another plant, that contains an MAO inhibitor, it will stay active in the stomach long enough to be absorbed, and it becomes orally active. Starts working within 45, 60 minutes, peaks at about 2 to 3 hours, is over at around 6. So 5-methoxy-DMT is either synthetic or from the toad, the Sonoran Desert or the Colorado River toad. It's called Bufo alvarius. It's quite potent, 3 to 5 or 3 to 10 milligrams smoked. It seems to cause more frequent flashbacks. And I think that may be because it's easier to overdose on, because how can you measure 3 milligrams? And it's more prone to the white light ego death, completely like in the center of a nuclear bomb. And if you're not prepared for that kind of experience, and you might think you're prepared for that kind of experience, but you probably aren't, it can be traumatic. So there's ibogaine, which has got a complex pharmacology. It also has got some kappa activity, and it seems to have some unique anti-addictive properties. The ibogaine route is inconsistent as far as concentration. So in the studies and the retreat centers out there, it's usually given as pure synthetic drug, 5 to 12 milligrams per kilogram. It's a long day too. It's up to 24 hours. So indications, a slew of psychiatric disorders. The list grows every month. I think one of the things we learned from the 60s is you need to operationalize your psychotherapy protocols, and that's been going on with the MDMA studies for PTSD, psilocybin, for alcoholism, tobacco addiction, end of life, despair, those kinds of things. I think if you just give a psychedelic, you might see improvement, but I think the combination of psychotherapy and the drug will turn out to be much more efficacious than just giving the drug alone. You're seeing some of that with these ketamine clinics. You call up, you say, I'm depressed, can you send me some ketamine? And they do. And you've got a virtual therapist or an online therapist, so they say, here's your ketamine, lozenge, good luck. And people improve, but I think, without support, they could improve, or, without support and a skilled, psychotherapist, their improvement, may not be as great as it could be, and adverse effects, I think, will be greater. So you need to prepare, supervise, and follow up. The psychoplastigenic effects with either low doses of classical compounds or non-psychedelic psychoplastogens are going to be used for neurological disorders. They're anti-ischemic as well. Brain injury, ischemia. So stroke rehab, dementia, multiple sclerosis, ALS. I'm consulting for a couple of startups which are looking at DMT for stroke and stroke rehab. Oh, spiritual experiences. Well, this may be a bit getting deep into the weeds, but when people talk about the spiritual properties of the psychedelic state, they are usually defaulting to what I call the mystical, to the mystical unitive state. It's an experience of unity. There's no time or space. There's no sense of self. There's a feeling that is more real than real. Positive mood, ineffability, which means you can't describe it with words. Oftentimes that's a case of just not having the vocabulary or being lazy, the resolution of paradoxes, good and evil, black and white, light and dark. So that's the mystical unitive state, and you can score it with the mystical experience questionnaire. And that's kind of the default in research, and as a result, it's kind of the default in the within the subculture as well. That's what everybody is looking for: ego dissolution, unity, those kinds of things. One of the strengths that advocates of that state bring up is it's universal. Like everybody can have it. You'll hear people lecturing about the fundamental, essential, underlying spiritual experience of all the world's traditions is this state. But false. That's not true. You look at the Hebrew Bible, the Jewish, biblical tradition. The the optimal or the greatest spiritual attainment is prophecy, the prophetic experience. There's no questionnaire quite yet available. I've got a grad student who's hoping to develop an interactive relational scale. It's more comparable to the DMT state. It's full of content. One's sense of self is maintained or even strengthened. You can interact with the contents. Time and space continue in some form or another. It's more real than real. Your mood effects are mixed, and it's full of information, often verbal. That wasn't the case with the DMT experience, but the phenomenology of the prophetic state, which is any spiritual experience recounted in the Bible, in the Hebrew Bible, is phenomenologically a dead ringer for the DMT state. The difference between the prophetic experience in the text and the DMT state is the information content. So it's what is the information content? Well, it's that you need to do better. You need to repent, the role of Israel, all those kinds of things. Extremely, extremely particularistic, which really rankles the universalistic, progressive movement, which is incorporating psychedelics into their mindset. So be that so be that as it may, I think it helps explain kind of a latent current of anti-Semitism within the psychedelic movement, and also the anti-Jewish sentiment. Like if you read Bill Richards' book, what's it called? Sacred Knowledge. Bill Richards is the chief therapist at Hopkins. He disparages prophetic experience. He calls it the foothills, and his mystical experience is the peak. And he, in the space of a couple of pages, demeans Moses, demeans the prophets, demeans the text. It's really quite striking. And the two patients who do poorly in his studies are Jewish. So like I asked Bill, what's the deal? Are you an anti-Semite? And he said, no, I'm married, to an Israeli, and she's Jewish. And I just couldn't help but laugh. Like, some of my best friends are Jewish. But I think, when you're looking at, what is the spirituality inherent in the psychedelic experience, it is not only mystical unitive. It can also be full of content and verbal. So I think you don't want to disparage one versus the other. Okay, so that's my Zionistic sidebar. Okay, microdosing. That's very popular. The thing about microdosing is it's very popular and there are no data. So take microdosing with a so-called grain of salt. The standard regimen is 1/10 or so of an active dose, and the most common compounds are psilocybin, LSD, and ayahuasca. It's variable regimen every day to every 3 to 4 days. When you're speaking about microdosing, it isn't all the same thing. You can think about tiny microdoses with absolutely no acute effects. And if you take a microdose every day, I would guess that the effects would be similar to an SSRI. You'd be down regulating postsynaptic serotonin receptors, and after a few weeks, you would feel a lightening of your mood. Maybe you're thinking more clearly, you aren't as anxious. There's small doses, small microdoses, which are like stimulants. I think. I mean, that's kind of the data that's coming out of the labs, is that they're stimulating. They may increase your cognition, but they may not. So they're you have acute effects. And if you took them daily, it would be the same kind of downregulation of postsynaptic serotonin receptors, and you would experience an antidepressant effect. But they do have acute effects as well. And there's medium microdoses, which would be kind of bringing on mild psychedelic effects, and would hint at what would be in store if you took higher doses yet. There are very few data. Most of them come from survey studies, which we discussed earlier, selection bias and placebo effects. There's probably 12 laboratory studies with microdosing, and all but one of those gave only a single dose. So what seems to be the case is that you have increased energy, but there isn't any increase, but there isn't any increase in your mood or your cognitive abilities. There are some brain imaging studies, fMRI, and I think EEG, indicating some functional connectivity changes, which are comparable to those which take place with full doses. So the belief is beginning to develop, that you don't need to take psychedelic doses for antidepressant effects. And So that's consistent with the psychoplastigenic effects, mediating the benefit, without necessarily a full full psychedelic experience. But I think the combination of psychological work with the drug, either non psychedelic doses of classical compounds, psychedelic doses of classical compounds, or even non psychedelic compounds. I think if you're going to be stimulating psychoplastigenic effects, those neurons are not growing or connecting randomly. They're connecting based on the set and the setting. So if you're in a particular state and trait, if you're getting therapy, those psychoplastigenic effects will be directed in a specific direction as opposed to just randomly growing. So the prospects for the psychedelic future, well, there's new compounds, including non-psychedelic ones. There's lots of money going into psychedelic startups, psychedelic divisions within academic centers. There's a increasingly hot patent war going on out there. Use patents, new salts, new delivery systems. There's going to be increased access, if we like it or not, legalization and decriminalization. And I think the important thing is to how to maintain public health. So they're struggling in Oregon to work out their, legalization certification. It turned out, that the chairman of the board, working on the structure for certifying therapists was sleeping with, somebody who's the CEO of a psychedelic startup. So that that's not cool. So it also is, what are the qualifications of somebody who's going to be giving psychedelics to to an increasing number of people. And the question of scheduling, the Hopkins group recommended a few years ago scheduling these compounds down to schedule number 4, which is like the benzos. I think that's a little bit cavalier, but I think schedule 1 is a little too restrictive. So I think federally anyway, putting them in schedule 2, perhaps schedule 3, or some new schedule would be more reasonable than dropping them all the way down to 4. And get ready for backlash. You want to avoid psychedelic newspeak. You don't want to use the term entheogen, challenging experiences, or reactivations. You want to say they're psychedelics with potential adverse effects, including flashbacks. So you don't want to glorify the benefits. You don't want to dismiss the risks. There are going to be adverse effects. There are going to be some association with controversial social causes. I mean, I wouldn't be surprised if kids in Russia start dropping acid, and hundreds of thousands of them congregate because of the war. Pied Pipers, like another Charles Manson terrorist, crazy people are going to use psychedelics to reinforce their crazy ideas. Okay, good. So that's a lot of material. If you want a copy of my presentation, I'm happy to send one to whomever is interested. And let me stop sharing.
Wow, Dr. Strassman, that was absolutely phenomenal. I learned so much, and you have a certain way of cutting through assumptions that is so profound. Personally, I always looked at the mystical experience questionnaire. I was like, wow, this is evidence that psychedelics definitely produce spiritual experiences. But it's not that simple. And it's kind of just one lens to understand that experience. So thank you for your lessons on that. We have several questions. So I'm hoping we can do a little rapid fire question and answer if you're up for that.
Sure, sure. Let me, rub my eyes and my forehead.
Yeah, that was that was a lot. That was a serious download.
Well, it's like a real, distillation of my book. I just, finished that book 10 days ago, right? So it's all in my head.
So we got the
I
advanced copy
just went
here.
through the book and said, okay, there's this chapter and I covered this. So it's a big book that I just, crammed into an hour and a half. So
We're all looking forward to getting our copies soon.
So pre-order. It'll go up on Amazon Rank and everybody will be happy, my publisher, all that stuff. So.
Okay, question 1 from our guest, Victor Demetrio asks, hi, Dr. Strassman, thank you for this talk. I was wondering if you could briefly talk about the findings of the 2019 paper you co-authored on the biosynthesis and extracellular concentrations of DMT in the mammalian brain and discuss what you think some of the roles endogenous DMT may be in the human brain.
Yeah, well, so that group is in University of Michigan in Ann Arbor, and it was stimulated by some of the ideas I put forth in the original DMT book about the pineal gland producing DMT, and all kinds of theological speculations about the role of DMT in spiritual experience, and there's a neuroscientist in Ann Arbor, Chimo Borjigan, Mongolian actually, who studied melatonin in the pineal gland. And she called me one day and said, what's DMT? What are you talking about? And I, described, my thinking, and she said, oh, that makes sense. So in 2013, the same group published an article, demonstrating, measurable concentrations of DMT in the living rodent pineal gland. And so that was exciting. It confirmed an idea that I had been toying with since I was in college, actually. But there were some technical questions, some pharmacological questions, some concentration receptor binding questions about the pineal, the pineal issue. So they went back to the drawing board, the same group, and they looked more carefully, and they were able to establish the co-localization of the two requisite enzymes for DMT synthesis in brain, in pineal as well, but in brain too. When people first discovered DMT in mammalian tissues, it was believed it was produced in the lung because of the enzymes there. But the lung tissue does not have the enzymes co-localized in the same cells. But in the brain, the enzymes are co-localized. And concentrations of so concentrations of DMT in the rodent brain are comparable to the concentrations of canonical neurotransmitters like serotonin and like dopamine. So there's beginning to be some speculation about, well, if concentrations of DMT are that high, maybe there's a DMT neurotransmitter system in the mammalian brain. So the search is on for the vesicle reuptake and transport and those kinds of things, which are like additional criteria to establish a compound as a neurotransmitter. I mentioned in my talk that concentrations increase in the dying rodent brain up to 5 times at least in the visual cortex. So that lends some credence to the importance of DMT in mediating some of the properties of the near-death experience. Interestingly enough, there was no DMT in pineal when they went back to look, for it, and they concluded, well, even though the enzymes are co-localized in the pineal cells, there wasn't any DMT there. So they concluded that they snagged brain tissue in that original 2013 study, and picked up brain DMT. they weren't looking, for brain, DMT back then, only pineal DMT. So it was, it was an artifact of, the probe going in and out. Some people who, for whatever reason, like go crazy when you mention the pineal gland and DMT in, the same breath. They kind of, clap their hands, gleefully, and they said, "Oh, there's no DMT in the pineal." It's like, I don't care. There's DMT in the brain, and it's really quite, the concentrations are quite high. The pineal. I mean, it was an interesting theory. It'd be frosting on the cake. But
Yes.
I think the more important thing is there is DMT in the brain. Concentrations are high. They increase in the dying brain. The biological effects of DMT are conducive to that kind of phenomenon. If DMT is a psychoplastogen, it would help your brain repair from damage. And that seems to be the case in animals. It'll reduce stroke size and speed up functional recovery in stroke. And DMT is anti-ischemic. So if you put neurons in a test tube and you starve them for oxygen, they start to die. If you pre-treat them with DMT, they don't. So you could construct a tidy scenario, that when the brain is dying, it releases DMT in order to reduce ischemic injury and to reduce infarct size and to speed recovery. Why a compound like that is so crazily psychedelic, though, is a question. Why isn't it just sedating? It could be a psychoplastogen and just be sedating. So it's quite psychedelic. So it makes you wonder, why does the body produce like this incredibly psychedelic compound as you're dying? Like in everyday, like in everyday life, what's the role of DMT? Well, the hallmark of a DMT experience is the feeling that it's more real than real. And so it is, tempting to speculate that if, there is a DMT neurotransmitter system, it's, regulating our ongoing sense of reality, kind of like an endomatrix, but that gets to be pretty weird. And I'll stop there.
That's fascinating. We are about out of time for this portion of our conference, but I'd love to just ask one more question. If you could just give us a few sentences on this. Are there ways to mitigate adverse effects during psychedelic use, perhaps like benzodiazepines to control anxiety? If the most important feature of a psychedelic experience is intensity, would blunting adverse/unpleasant experiences decrease the total healing potential?
Well, there's a stepwise progression for dealing with bad trips. You reduce sensory stimulation. If you're in a crowd, you separate from the crowd. Like a calm, quiet, dimly lit place. Talking down is the first step. Just have somebody question you empathically, or just smile benignly, or hold your hand, or put a cold compress on your forehead, or put on some relaxing music. And you can lay on people. You could do holotropic breathing. You could do some more intense physical stuff to to ground them. There are some urban myths about vitamin C or milk or niacin. There's really no data to support that. They wouldn't hurt. But if one glass of milk doesn't do it, I wouldn't drink a gallon. Benzos are first line for drugs, and if benzos don't help, then you go to the big guns, like the antipsychotics. One of my mentors, back in Berkeley, used to say, if somebody's having a bad trip, you take the Valium, in order to be calm and to not inflame the situation. The question about if you minimize adverse effects. Well, I mean, if you can work through adverse effects and they have attained to a certain certain level of intensity, they could be beneficial. Like that Canadian study giving people LSD and telling them they're going to be going through the DTs. DTs are horrible. It's like the nightmare, and they got better. So I think it's skillful handling of the experience, either on your own or with the people around you, which would then allow the intensity of the experience, be it good or bad, to be metabolized, as it were, and then effect whatever changes that you're looking for.
Wonderful. That's a beautiful sentiment. And I think everyone here aspires to be that skilled practitioner. So I appreciate your time so much, your attention to detail and your service to, the fields of science and medicine. Thank you very much.
Well, you're welcome. Thanks for the invitation.
Okay. So allow me to introduce our next speaker. Okay, so that was Dr. Strassman, truly enlightening. That was such a pleasure. I hope you all enjoyed that as much as I did. Our next speaker will be Jason Leonardo. He is a first-year medical student right here at Rowan School of Osteopathic Medicine, and a member of this planning committee for this conference. So we're very happy to welcome him here. He grew up in Gloucester Township, New Jersey, just 5 minutes from RowanSOM Stratford campus. Jason received his Bachelor's of Science in Biology and Pre-Medical Science with a minor in Biochemistry at the Kutztown University of Pennsylvania. He was an active member of the cross-country and track and field programs at Kutztown University. Go Golden Bears! Jason Leonardo, student doctor extraordinaire, you have the floor. Thank you so much for coming and being with us today.
Oh, can you hear me now, Jesse?
I can hear.
All right. Hear me now?
I can hear you, and I can see your presentation, and momentarily should be full screen. It is full screen. Looks great.
All right. Great. Hello, everyone. Thank you guys for having me today. It's great for everyone to be here and to be able to talk to you guys. Even more so, it's so great to have had Dr. Rick Strassman here to present just prior to me. He truly is a legend in the field, and a lot of his work has not gone unnoticed, and he really paved the way for much of the research after him, especially in the United States. So thank you again to Rick Strassman. Today, I'll be talking about lysergic acid diethylamide, or commonly known as LSD, and I'll be talking a little bit about the applications for this relatively new drug in medicine, as well as alongside psychotherapy. So it's no secret that there is a large area within medicine and psychiatry specifically, which needs some reform. We need to find ways in which we can improve how we approach mental illness and how we treat these diseases. Hopefully this movement of psychedelic compounds will continue to gain momentum in research, and we'll continue to discover novel ways in which we can use psychedelic drugs effectively. All right, so first up, let me start just by going into the history of LSD. LSD was first synthesized by Swiss synthetic chemist Albert Hofmann in 1938, and this was done at Sandoz Laboratories in Switzerland. Hofmann had been looking for a lysergic acid derivative from the ergot fungus, which commonly grows on rye, which he could use to serve as a circulatory and respiratory stimulant. LSD-25 was the 25th compound Hofmann synthesized from ergot fungus, but he found this drug to cause restlessness in mice and contractile effects of the uterus. And since these weren't the effects he had been looking for, he ended up setting it aside in his lab for multiple years. Hofmann did not end up picking this compound back up until April 19th of 1943, which has since been known as Bicycle Day. Hoffman this day accidentally dosed himself with the LSD, and he discovered the effects this substance can have and potentially change the world. 3 days later, after accidentally dosing himself, Hoffman intentionally had dosed himself and further investigated the effects of this novel compound. He shared this compound with other colleagues around Sandoz Pharmaceuticals in order to investigate it further. Ultimately, this led to Sandoz Pharmaceuticals patenting this compound and distributing it to research programs globally, and it first arrived in the US in 1949. At first, LSD was initially studied for its believed effects in mirroring the psychosis state of schizophrenia, and other studies globally had found potential for treatment of alcohol dependence as well as other illnesses. However, the potential uses of LSD in medicine and the research that was being conducted had been vastly overshadowed by the wide recreational use of the substance in the mid-1960s. Prohibition of LSD began in 1965 with the Drug Abuse Control Amendments restricting possession to clinical research programs. The negative view of LSD grew with the prohibition and the negative reputation it was acquiring, and research programs globally began losing interest because of this. Sandoz Pharmaceuticals eventually discontinued sponsorship of the compound between 1963 and 1966. And all of this only really served as fuel in creating further regulations of the compound. Possession of LSD was restricted completely in 1968, and then it fell under complete prohibition in 1970 when LSD was classified as a Schedule I substance under the Controlled Substances Act of the UN Convention of Drugs. Research after that was very limited for the next 30 to 40 years, especially in the United States. But over the last 25 years or so, interest in LSD began to resurface amongst other psychedelic compounds. And like I mentioned earlier, we have Rick Strassman to thank for helping pave the way for that. Like I said, this new interest had been sparked from the promising studies on the applications of marijuana in medicine, as well as the research of the potential medical applications of other psychedelic compounds, particularly psilocybin, and the DMT studies which Dr. Strassman had been partaking in. So I know Dr. Strassman touched on this quite a bit, but the typical effects you commonly see with a dose of LSD are predominantly limited to psychosensory and perception changes, and these are seen with doses as low as 50 micrograms. Users will get changes in vision, most particularly distortions in color, shape, size, and movement. And they'll also have distortions in sense of time, identity, ego, as well as changes in the sense of touch and hearing. Synesthesia is actually a phenomenon that's been commonly reported with LSD use. And this is when one sense is perceived as another. For example, if someone were to claim to see music. Distortions of cognitive processes and accelerated thought are also often very common. And partially due to this, LSD has also been seen to hinder sleep capabilities and ultimately decrease frequency of REM sleep. So in this way, it does act as a stimulant, causing insomnia. The mechanism of action of LSD is much due to its tryptamine derivation and the fact that its structure is so similar to serotonin, just alongside many other psychedelics. LSD is absorbed into the bloodstream and transported to the brain to alter activation of the 5-HT receptors, and predominantly the 5-HT2A receptor in the frontal and temporal lobes. This binding pattern likely is the causative factor that creates the distortion in cognitive processes. It is then metabolized by the liver into inactive metabolites, and LSD is found to have a half-life of about 3.6 hours, and the psychosomatic effects have been found to be directly correlated to the concentration within plasma. So with all that in mind, I can finally get a little bit deeper into the potential applications we've been studying and researching for these drugs. First up, I'll go into depression studies. So depression is a very prominent illness in society today. I don't know of anybody who will likely know a single person that doesn't have depression. Everybody knows at least one person with it, but despite this, treatment is often very long-term and not always effective. The effectiveness of LSD on depression has only been briefly investigated, however. The first study of the efficacy of LSD on treating depression was performed in 1952. And while no real effectiveness of LSD at improving symptoms of depression were found, users and the subjects in the study did report that the hallucinations that it had produced had been found to produce therapeutic effects. So this is a possible benefit and could help in turn improve their depression symptoms. Then later in 2014, they studied rats with olfactory bulbectomies as models for depression. And post-treatment with LSD, these rats were found to have a reduction in active avoidance learning, and this suggested that LSD may have a potential use to combat depression. And just alongside depression, anxiety, the current treatment standards also involve daily administration of medications with only about a 60% reported effectiveness. And this is another illness that's huge, that's largely predominant throughout society today. So a double-blind randomized placebo study in 2014 had compared anxiety levels in two groups of individuals suffering from anxiety related to their terminal illness. Both of these groups, with 2 LSD-assisted psychotherapy sessions each, were dosed with LSD 2 to 3 weeks apart. One of these groups received 200 micrograms of LSD, and the other had received 20 micrograms of LSD in order to serve as a control with no long-lasting effects. 2 months post-treatment, there was a significant reduction in state and trait anxiety levels of the treatment group compared to the baseline. And then 12 months post-treatment, we still had 77.8% of the treatment group reporting reductions in anxiety, 78% of this group reporting less fear of death, and almost 67% reporting improved quality of life. So I think that 12 months out from those 2 treatments is truly a remarkable number. In addition to this, none of the treated patients reported any lasting negative effects of the LSD, which really can attribute and account for its safety and lack of toxicity. In addition to this, we have preliminary results from a study in Switzerland which involved LSD-assisted psychotherapy treatment for both healthy and terminally ill patients with anxiety. The treatment group in this study had been receiving 200 micrograms of LSD just once, and the placebo group had received no doses of LSD. This study found that significant reductions of anxiety levels, depression, and general psychopathological symptoms were found at 2, 8, and 16 weeks post-treatment in this treatment group. Next up, addiction, just the same as anxiety and depression, where it's another one of those illnesses which are truly far too prominent within the society, and we need to find new novel ways in which we can better combat this. Alcohol addiction and dependence have great prevalence globally, while products that help with this addiction are not as readily available as they are for, say, nicotine addiction. And among the available treatments are therapies through rehabilitation centers, which can often prove very costly and are often cut short by the patient against medical advice. In addition to this, Alcoholics Anonymous, which is not a true therapy or treatment, rather a support group with individuals with similar addiction struggles, while it's effective and helpful for the patients, it's not always everything they need, and it doesn't really control their disease. A study in 1969 had compared the effectiveness of LSD to dextroamphetamine in treating alcohol dependence. So dextroamphetamine is now used in treatment of ADHD, but at the time, this CNS stimulant had been used to treat alcohol dependence. This study had found that LSD had significantly greater efficacy in the treatment of alcohol addiction and dependence, and a more recent meta-analysis of 6 randomized control studies testing LSD in treatment of alcohol addiction had found that a single LSD-assisted psychotherapy session was effective for patients through the 3 and 6th month follow-up visits. 59% of the patients in the treatment group reported cutbacks on alcohol misuse, while only 38% of the control group had reported less alcohol misuse. The efficacy of this LSD-assisted psychotherapy session no longer proved effective at the 12-month follow-up, but just as Dr. Strassman had touched on, the researchers in this study had noted that the effects have possibly been more prominent and more long-lasting if the treatment was coupled with other alcohol addiction treatment programs like AA through the first year post-treatment. In addition to this, we had an online study involving the effects of psychedelic use on smoking cessation, and this study reported that 59% of the participants who had reported reduction in smoking cessation, and 36% reported quitting smoking following use of LSD. Now, again, this isn't a cure-all. It really is just another tool in the tool belt of the psychiatrist. However, it's another tool that we very well may need and may continue to use in the future. For obsessive compulsive disorder, we haven't had very thorough studies on this. It's mostly just anecdotal evidence we have currently. For example, a 30-year-old patient with treatment-resistant OCD received weekly increasing doses of LSD for 15 months. Over the course of the treatment, he began to experience relief of his symptoms, and by the very end of the treatment, he reported a complete relief of symptoms, which was maintained for 3 years post-treatment, which is truly phenomenal. But again, we would need more controlled studies to truly test the efficacy. In addition to this, there was a man with severe depression and obsessive violent sexual thoughts, and he had been injected with 2 doses of LSD over a few weeks, and after that, he had reported full relief of symptoms. Now, again, just like I had been saying, it really will take more testing and more controlled studies to truly test the efficacy. As far as the safety and toxicity of LSD, there's several controversial concerns of LSD which had led to the classification as a Schedule I substance. While effective doses of LSD are just 25 to 200 micrograms and considered physiologically safe, the LD50 is 100 milligrams, which is at least 500 times the standard effective dose, so toxicity is highly unlikely. Concerns have been focused on negative psychological effects of the drug, but any long-term consequences had been reported to be incredibly unlikely to occur, especially when used under careful supervision, especially in clinical settings. As Strassman said, LSD abuse and addiction is highly unlikely as LSD is not reinforcing in action, and it imposes virtually no symptoms of withdrawal on users. There's been very few deaths reported with LSD toxicity in recent years. One of these, a man was detained in the hospital after being administered haloperidol and lorazepam, and just after this, he was found unresponsive and later pronounced dead. His death was ruled as an LSD toxicity. However, toxicology results showed that he only ingested about 100 micrograms of LSD, which is a very safe dose. So this was more likely to due to the haloperidol and lorazepam, which was administered, which cause CNS and respiratory depression. Then we have a very sad case of a young woman at a music festival a few years ago who arrived at the hospital with symptoms of hyperthermia. She ended up having fluid removed from her lungs just before being pronounced dead. Toxicology showed LSD in her system, and her death was ruled as a result of LSD toxicity. However, hyperthermia is not actually a symptom of LSD toxicity, rather is more commonly associated with drugs such as 2,5-I-N-bomb, paramethoxyamphetamine, and PMMA, all of which are often cut and even sold as LSD at the street level. And lastly, we have HPPD, which is probably the largest concern surrounding LSD treatment. And it's a very rare disorder in which an individual who has previously used LSD or another psychedelic has flashbacks, which may last weeks, months, or even years. Typically, these are limited to reoccurrences of visual distortions of movement and color, just like this image on the left, which they call snow. And it's perceived as trails or tracers from moving objects, as well as geometric hallucinations. And while this is extremely rare, it can occur after just a single use of psychedelics, which is why it's of concern. But in addition to this, it's reported to be worsened by additional use of psychedelics or use of SSRIs post-onset of this disorder. But it's much less likely to be reported in controlled settings. And as I previously stated, while it's in its infancy, research has already suggested that LSD does have the potential to be used in medicine and alongside psychotherapies. Further research is obviously still needed to investigate these potential applications and other potential uses of this compound. Data has been shown that when used under medical supervision and at the recommended dose range, LSD is not toxic and it is physiologically safe. But despite this, LSD, as well as most other psychedelic compounds, still carry a negative reputation and will likely continue to face limitations in research and alongside psychotherapy until these barriers are broken down. So these are just my citations. And does anybody else have some questions for me? I'll stop sharing.
Last call for questions. We are a little bit behind, so we'll move along shortly. Jason, that was a wonderful presentation. Thank you so much for your effort on that.
Thank you guys for having me.
And we'll be moving on to our next student presenter. So, hold on one moment. Jason, and we have. Oh, student doctors Parisa Tepmankorn and Keshav Holani, revisiting peyote, a qualitative analysis of the subjective experience of peyote use as documented in online drug forums.
Hello. Thank you for having
And
us.
I'm sorry if I'm not introducing one of you. Please feel free to introduce yourself. I apologize for any confusion on that front.
Oh, no worries. My name's Ashish. I'm also a med student working on this.
We're so happy to have you with us, and we're all looking forward to your presentation. You have the floor.
Thank you.
Okay. Hi, my name is Parisa, and we're here to talk a little bit about peyote and some of the research we've been doing regarding it. So I guess first off, what is peyote? So it's a cactus found in Mexico and southwestern United States. Some evidence has suggested that it's among the oldest psychoactive substances in the New World, and for thousands of years, it's been used by various Native American and indigenous tribes to address a wide variety of conditions. So it's been used for various pains, including like teeth pain, childbirth, skin related concerns, fevers, snake bites, burns, and even as an antibiotic. So in essence, it was used a little bit as kind of their version of aspirin, just something for, you know, any ailment or any illness that came up. And a little bit about mescaline. It's the main psychoactive substance found in peyote. It's a phenylethylamine alkaloid that acts similar to psilocybin and LSD. So it acts on serotonergic receptors, specifically the 5-HT2A through C receptors, but it has the strongest affinity for the 2C receptor. And as an agonist of serotonergic receptors, it has a lot of effects on people's moods, anxiety, feeding, and reproductive behavior. And it also mediates dopamine release in various areas of the brain. Peyote also contains dozens of other alkaloids, some of which are thought to enhance the effects of mescaline, but most of those are concentrated in different parts of the plant. And mescaline is considered to be the main psychoactive substance that people think about whenever they think about peyote's effects. Oral mescaline ingestion has a longer half-life compared to other classic psychedelics, which can be around 6 hours. Mescaline lasts for 8 to 12 hours in total, with kind of the peak effects occurring around 2 hours after ingestion. So here's just some of the main alkaloids found in peyote. And up here, kind of on the top left corner, you can see that that's the structure of mescaline, which is the main psychoactive compound. And here we have a kind of a picture depicting the effects of mescaline at the 5-HT receptors. So those receptors are G proteins, specifically GQ, G protein coupled receptors. And as serotonin or mescaline acts on these receptors, it's increasing IP3 and calcium concentrations in the postsynaptic neuron, and that ultimately results in neuronal excitation. And that's how we see the effects of mescaline and peyote consumption. So the history of peyote use in America. So as I talked a little bit about before, archaeological evidence suggests that for thousands of years, since 1000 BC, different indigenous cultures across the US, in Mexico, and Peru have been using peyote in various ceremonies, as well as to kind of treat different illnesses and conditions. But it wasn't until the late 19th century that the first Western medical report of peyote consumption kind of surfaced. And 2 decades after that, then we saw kind of an isolated administration of mescaline for medical purposes.
So next, we're going to talk about peyote use today. And as the previous presenter pointed out, a lot of the research in psychedelics have decreased because of this switch to a Schedule I controlled substance across all of these different psychedelic substances, peyote, psilocybin, LSD. But despite that, and despite its continued illegality, a surprising number of people have used it. In 2016, SAMHSA, the Substance Abuse and Mental Health Services Administration, the federal government, their general, I think the Surgeon General's report on it said that 8 million people have used mescaline in their lifetime, and 5.5 million have used peyote specifically in their lifetime, aged 12 and up. And at least based off of the reports that we looked at, because our general research was looking at people's trip reports online, most of the time in controlled settings, even in the Native American church, use wasn't administered to children. It was every adult. Sometimes children would be there, but so it seems like a pretty good estimate, and it's definitely a much higher number than I was expecting myself. And so yeah, since 1967, it's been a Schedule I controlled substance and generally legal. The exception is, as we've talked about earlier, the Native American Church, which I believe has over 100,000 members across the country. They're allowed to use it for religious and therapeutic rituals. So in the 1950s, mescaline was first used psychotherapeutically to help patients. As Parisa mentioned, the Native Americans and other indigenous groups did use it like back going thousands of years for various illnesses, but for mental illness specifically in the modern context, the 1950s and maybe a little before that is when it was used with psychotherapy. We found some research by Wallace in 1959 looking at Native American use in the past century. And so it was used to reduce chronic anxiety, improve community satisfaction, because you've seen gatherings of people doing this as a group experience and increased senses of personal wealth. And that, notably, the important thing there is that it was always a guided experience in those encounters. And it's also been used to treat chronic alcoholism. That was the research that we were looking at back in the 50s, 60s, 70s. So mescaline, we've seen that it may also help treat OCD and personality disorders. That was some of the suggestions that people were extrapolating towards. And so I want to talk about the effects of peyote, both just overall, and then also talk about the adverse effects. So we looked at a few hundred reports and then isolated it down to just a small subset, 50 or 60. But we grouped the reported effects into visual, positive, cognitive, and emotional, and then challenging psychological. So some of the visual effects are things that were mentioned for LSD as well, since they're both serotonergic agonists. So you'd see spatial distortion, distortion of color, synesthesia, like I believe Jason mentioned. A common example is hearing music, or just any connection between the sensory processing centers for different senses. You can see all sorts of things, including looking at different numbers. Each number could have a different color, and also closed eye visual hallucinations, which were extremely common. And a lot of the time they would, at least in the reports that we were reading through, a lot of these hallucinations involved someone speaking to them. There was a lot of animal imagery and similar guided experiences. And then there were also positive cognitive emotional effects. A lot of the reports we examined, patients reported euphoria, they reported pleasant feelings and like unity, transcendence with nature and the world around them. Tied in with the euphoria, there were some cases we saw where patients might initially have some negative experiences, and then those negative feelings transitioned into an overall positive experience by the end of the trip, and they had net positive reactions with peyote. And then there were, of course, challenging psychological experiences, which are part of the reason for the stigma, just part, as we know. So there's sensory alterations, there's paranoia, delusions, and depersonalization. And like our main presenter just before spoke about, it's important to have someone guiding the experience and someone to talk you down and talk you through the anxiety and paranoia that comes up. And as I said, it can be resolved and be an overall positive experience. And the adverse effects, essentially what I just mentioned, some of the adverse psychological effects, the anxiety that can come up, the panic, the disorganized behavior, as well as some GI effects. And since not everyone, a lot of people, especially in recent years and also in the past, have used it as a recreational experience for some people. Well, if it's not a guided experience, the anxiety and the panic, or especially your first time psychedelic experience, it can be very disorienting to a lot of people. And it really has helped, at least the patients we were examining, them look more internally, have more self-examination of their thoughts, their experiences, their actions. And so that can be that can be, like I said, disoriented and cause all of these effects. The nausea and vomiting was, so generally peyote we saw is either ingested, you eat the tops of the cactus, the peyote buttons like they're called, or it's converted into a tea and it's consumed that way. But we did find, looking at peyote versus mescaline and some other psychedelics, that the nausea and vomiting was more common with the peyote ingestion versus using mescaline in other ways. And the general consensus from the research we were looking at seems to be that both like the bitter taste, but then also all those alkaloids that Parisa mentioned that are found in these different cacti and other, in these different cacti, they are thought to contribute to the nausea and vomiting. And that's one of the main concerns going forward with the use of this, and why there hasn't been as much research as, say, psilocybin for it, because it's a little more difficult to isolate when you're consuming it.
So in terms of the research that we were conducting, we looked at, I guess this would have been a year or two ago, but at the time, the last 20 years of user self-reports of peyote consumption as reported on online drug forums. And our goal was to just get a better understanding of what people's subjective interpretation of the effects of peyote on them. What was their experience like using peyote as compared to some of the things that were written in literature already? So the way we did this was we searched public discussion forums such as Reddit, which I'm sure generally it's just a discussion forum, but then more specific drug forums such as Arrowhead or DMT Nexus as well. The keywords we used were trip report plus peyote, peyote experience, as well as experience peyote, because we found that sometimes just flipping the order of the words would generate different trip reports on those forums. In terms of our exclusion criteria, we had originally generated about 498 posts, but we knew that we weren't, not all of them were usable in terms of our research. So we had 3 exclusion criteria. One was if it wasn't a trip report. People would just post random things about peyote sometimes, but not specifically their experience using peyote. So that was one exclusion criteria. Second exclusion criteria was if it contained non-written media, such as photos and a lot of the times videos. People would post, video reviews of peyote. So if there was a written portion, we would use that, but we excluded the photos and the video portion. And then the third was if they described simultaneous use of other psychoactive substances, such as marijuana or other like LSD, things like that. The exception was tobacco, which isn't really as psychoactive. And there were just so many reports that had co-tobacco usage that we couldn't exclude those. So of the original 498 posts, we ended up with 41 of the written posts that qualified for analysis and that we looked at for the subjective reports. So our findings, we found that peyote would give most users a slow onset, long-lasting high with visual hallucinations. About 73% reported that. They also reported free-flowing thought processes guided by peyote and a feeling of connection to the world. About 29% reported that. Users also reported increased empathy and interpersonal skills. About 73% believed that peyote allowed them to confront and resolve their problems, their past actions, and their negative behaviors. 68% believed that it put them into a more positive headspace or gave them positive emotional changes. And then 27% said that they initially felt negative emotions that later resolved into positive thoughts. There were some physical effects experienced by the users, like we said before. There was nausea and vomiting experienced, about 46%, and lethargy, about 17%. We looked at the method of ingestion for these users. About 60% said that they consumed a physical peyote button, and about 30% said that they put it into tea, basically. There were a few other sort of ingestion cases, but those were the majority, which may explain some of the nausea or vomiting. There were other sort of adverse experiences reported, such as temperature changes, shaking, pupil dilation, voice changes, and diaphoresis, but those were very limited as compared to the overall scope of the reports. And then most of the therapeutic accounts, the individuals who felt like it really benefited them in a spiritual sort of way, said that prior to going into the peyote experience, they came in with premeditated questions and issues. And most of those people were led by a spiritual leader during their experience. Think like the Native American Church for people in the United States who were doing so. So some of the limitations of our study, we had a small sample size of the original 400 plus reports that we had. We only ended up using 41, which isn't very large. These were self-reported experiences by the users. So it wasn't anybody looking at what had actually happened to them. It's just what their experience was like, which can, of course, be altered by the psychoactive substance in terms of what their memory of the experience is like. There was minimal background information to try to exclude potential confounders. Like we said before, we eliminated any other psychoactive substance use from the reports we examined. But it's possible that in these reports, people just didn't mention that they were using marijuana or LSD or any sort of other potential confounding substance. And then really it's the lack of ability to objectively assess what is the patient's insight into their experience, as well as what are the true symptoms that they're experiencing during their peyote usage. So overall, we found that most people who use peyote, at least in the reports that we read, had positive experiences. They were able to experience some sort of resolution to emotional problems. They noted increased self-acceptance and improved mental health. This kind of supports our efforts to evaluate psychedelic agents as therapies for mental illness. Our previous presenter had, one of our previous presenters talked about, LSD and microdosing, and depending on the dosing may be potential therapeutic applications for psychiatric illnesses. And we feel that our peyote results here also supports that. Peyote is an understudied agent with therapeutic potential, and based on our research, guidance under either a psychiatrist or some sort of therapist, maybe a spiritual leader, may be more helpful than an unguided solo use. But we definitely need to have a greater understanding of the non-mescaline alkaloids in peyote and similar plants. As well as that, we need to understand that there is some potential for adverse effects like the temperature changing, the anxiety, voice changing, and diaphoresis that patients may experience if they were using it under a psychiatrist, as well as the nausea and vomiting. And then this is a list of the references that we looked at when we were conducting our research.
Thank you. Thank you so much. That was excellent. I do have a quick question for y'all. That was fascinating. On the subject of, the various alkaloids and terpenes in peyote generating that nausea and vomiting, we often talk about the psychological catharsis, but what about this physiological catharsis or the emesis itself? Did you see anything in the trip reports about the nausea and vomiting being an obstacle that had to be overcome in order to do the psychological work, or whether that was essential to the beneficial experience or harms as they may have been?
I think that mostly it was just an obstacle. It was unfortunate. I don't think I saw any of them attributing any positive benefit to overcoming it, to being like the intensity that we talked about in some of the other presentations. I don't think any of them mentioned that the intensity of the actual extra symptoms helping them long term. It was more about like just what they were seeing, what they were being guided to in their own introspection.
Okay, fascinating. Thank you very much. I think we're going to have to move on to our next presentation. That was wonderful.
Thank you.
Okay. So our next student presenter is student Dr. Christopher Conquest, presenting potential applications of psilocybin in medicine. Christopher A. Conquest is a first-year medical student here at RowanSOM and vice president of the Sports Medicine Club. He is a South Jersey native from Haddonfield, New Jersey, and an alumnus of St. Joseph's Preparatory School in Northern Philadelphia. He is a recent graduate of Loyola University in Maryland in 2021, where he graduated summa cum laude with a bachelor's degree in biochemistry. He's a member of the National Biology Honor Society, National Leadership Honor Society, and National Jesuit Honor Society. Today he will be presenting on psilocybin. Student Dr. Christopher Conquest, you have the floor. Thank you for being with us today.
Perfect. Thank you for introducing me, Jesse. It's a pleasure to be here. Today, I'll be kind of just speaking on the potential applications of psilocybin in medicine. A lot of it has been touched on today, but I do think that a couple of my trials that I studied later in the PowerPoint will be a little bit different from what other people have said today. So just to get started. We can turn the slide up. Okay, a little bit of a lag. All right, so right here, I just talked about my outline. So I start out with the big picture questions, and I go over a little bit of easier stuff just to set the mood, and then some examples of mushrooms, the mode of action, potential applications, and then some homework at the end if you guys are interested in learning more about psilocybin in medicine. Just waiting for the slide to change. Okay, so here are the big picture questions. So how do mushrooms compare to other psychedelics? as we kind of seen throughout the presentations today, a lot of them share the same receptor, and this is the 5-HT2A receptor. If you see in the picture on the top right, what Jason presented on earlier today, they both interact with the EGR1 receptor, which is used for decreases in depression, associative learning, aggression, and anxiety. And this is a lot of the other classic psychedelics, as other professionals also touched on today. And then another question that I kind of just put in there to set the mood was, what is the difference between the mushrooms on my pizza and psychedelic mushrooms? And this has to do with it's psilocybin, which is the main pharmacologically active substance in magic mushrooms. It's psilocin, not psilocybin, despite the common conception that psilocybin produces the psychoemetic effects, and psilocybin is considered the prodrug to psilocin, and you can see that they are tryptophan derivatives in the top left over there. They are methylated into DMT and then can be oxidated into psilocin and then dephosphorylated into psilocybin. And then it can be dephosphorylated back into psilocin. That's usually what how the body metabolizes it and causes most of your hallucinogenic effects. Next slide. Okay. So I will just be going briefly over the schedule as presented earlier today. It's a Schedule 1 drug, so pretty much what that means is that it's scheduled as highly abuse potential and no medicinal value and lack of accepted safety. I'll be going over history in the next slide, and then just its basic effects, which throughout the studies there seems to be a common acceptance of a onset around 30 to 60 minutes and a duration for about 6 hours, the peak in 2 to 3, and it can last from anywhere from 4 to 12 hours. And there's also effects like synesthesia, auditory and visual hallucinations, euphoria, increased heart rate, blood pressure, flashbacks, and then like unusual thoughts and speech, personal insight and reflection, excited mood. A little bit more on synesthesia. It's pretty much like when you hear music, but you see shapes, or you hear a word or a name and instantly see a color. I think in Greek roots, it translates to perceive together. So it's pretty much when you mix your senses up, so you kind of get all distorted, but people appreciate the feeling. The big thing that other people have talked about today is the individual reactions, which you can have based on the set and setting, which set refers to the psychological state and the beliefs of the person taking the drug. So it's what you go into and kind of the mindset you go into the experience. So if a football player kind of goes into a football game thinking he's going to lose, he's most likely going to lose. If you go into a sporting event and you think you're going to win, you have high confidence, you're most likely going to win. And that's kind of that's different from the setting, which is the external circumstances they're in and the people around them and their environmental settings. So what that has to do is, in a lot of these clinical trials, when people take their doses of psilocybin, they'll either be with a friend or like they'll have a therapist be with them. So if there's any kind of things that go wrong, they'll be able to talk them through them. Where if you take psilocybin in a very sensory heavy circumstance, then you could have negative effects. It's all depending. And then something that Jason talked about earlier, but I'll just bring up again, is the aspect of hallucinogen perception disorder. And it's mistakenly referred to as flashbacks. And it's pretty much unknown the prevalence, but it's a condition unique to psychedelics involving the perceptual changes lasting weeks to months following the drug psilocybin. And then it's relatively very safe, which I will go over more later. I will try and speed up this history because I know we have a limited time. Just a quick synopsis. The earliest known written record of magic mushrooms was in the Florentine Codex, compiled between 1529 and 1579, despite thousands of years of psychedelic use in religion and recreation before that. The classic psychedelic compound like psilocybin, mescaline, and DMT have been used in religious ceremonies for indigenous societies in South and Central America for centuries. We have kind of three psychedelic renaissances. Jason talked about one before in 1938 when Albert Hofmann synthesized LSD. But in my presentation, the second renaissance is more important because that's when he received a sample of dry psilocybin mexicana to determine the bioreactivity. And he in fact used paper chromatography to separate the various components of whole extracts of mushrooms and then ingested each fraction. And the active fraction was chemically characterized as crystallized, and they soon up calling that psilocybin. I'll kind of skip through the 1960s and 1970s because that's when psychedelics became like central to the hippie, which led to drug enforcement and prohibit psychotropic substances, which in 1970 we see that it was declared a Schedule 1. So now we have our third renaissance. And in our third renaissance, that's when UCLA researchers began clinical trials in psilocybin for the treatment of pain, anxiety, and depression, and in patients with advanced stage cancer, which I'll be all going over later. And in 2006, we start seeing like the upward trend of psychedelics again with the formation of the Psychedelic Research Unit. And then since then, there's been about 80 peer review articles. And then 2018, which I kind of put into my homework for you guys, is that Compass Pathways in London received the US and Food and Drug approval for breakthrough therapy. And the same thing in 2019 with USONA Institute. They also received the breakthrough therapy for major depressive disorder. And then in 2020, Johns Hopkins University built the Center for Psychedelic Conscious Research, which is the first of its kind. And to date, they've developed over 27,000 articles which have been published on psychedelic drugs, with over 1,000 particularly on psilocybin. Toxicity and dose, I'll make this quick. In the bottom right corner, there's a quick little chart looking at the amount of dried mushrooms and the its associated milligrams and its expected effect. So you see that with a low dose, there's a 1 milligram would have 10 milligrams of psilocybin, and that would just be a euphoric and enhanced senses. And if you go down to a high dose, that has about 3.5 grams of dried mushrooms, which equals around 35 milligrams of psilocybin, which will give heavy perceptual distortions and ego dissolution. Like I said before, the amount in comparison for toxicity is very, very high. And we already know that LSD has a very, very high toxicity, and you can just see the multiplication of psilocybin compared to that, making it even more safer of a drug. It's found in several types of psychoactive mushrooms, make it perhaps like one of the best known naturally occurring psychedelic drugs. It is most commonly found in the wild or homegrown mushrooms and sold either fresh or dried. Most popular species of psilocybin mushrooms is the Psilocybe cubensis, which is taken orally by either eating dried caps and stems or steeped in hot water like made through a tea. All right. Going on, this is just a couple pictures comparing the Psilocybe cubensis to other ones. We talked about Psilocybe mexicana before, and there's just different variations. And they all contain different amounts of psilocybin, which would give different effects. Now going into the mode of action. The psychoactive components of psilocybin containing mushrooms are two similar chemical substances, psilocybin and psilocin. When ingested by humans, the psilocybin and the mushroom is converted to psilocin. Psilocybin hallucinogen effects are generally believed to be due to this serotonin agonist action, and it stimulates the sympathetic nervous system. We can see its closely related structure to serotonin. And then in the top right, we also have a picture of psilocin binding to the 5-HT2A receptor. And the biological basis of this experience is pretty much the breaking down of existing brain networks that typically breaks down our sense of self and ego. And there seems to be science behind a new configuration and unification of systems regions that are usually apart from one another. Okay, and then the potential applications, we have cancer, depression, anxiety, smoking cessation, and other considerations. In Griffith's experiment in 2016, we see that psilocybin produces substantial and sustained decreases in depression and anxiety in patients with life-threatening cancer. And when administered under psychologically supportive double-blind conditions, a single dose of psilocybin produced substantial, enduring decreases in depressed mood and anxiety, along with increases of life and decreases in death, anxiety in patients with a life-threatening cancer diagnosis. And it was a double-blind crossover trial, and you can see the dosages that people were given, either a very low dose or a very high dose, and they were checked in at 5 weeks and a 6-month follow-up, in which 80% of participants continuing to show significant results. And it seemed to be as if the high dose amount of psilocybin was more effective. And there's another study with Ross in 2016, but we will just keep going. Johns Hopkins has been a huge part of developing psilocybin, improving its effectiveness in depression. And as I said before, in 2020, the Center of Psychedelic in Baltimore and Consciousness at Johns Hopkins University was developed. And the design of the study was about adults 21 to 75-year-old with major depressive disorder. And there was 27 participants. And the main outcomes and measures was the primary outcome of depression severity was access using the GRID Hamilton Depression Rating Scale, and which they checked in at 1 and 4 weeks after the intervention, and the immediate treatment group ended up doing very well. And the present trial showed that psilocybin administered in the context of supportive psychotherapy, approximately 11 hours of psychotherapy, produced large, rapid, and sustained antidepressant effects. The effects sizes reported in this study were approximately 2.5 times greater than the effect found in psychotherapy and 4 times greater than the effect sizes found in psychopharmacological depression treatment studies. So that means that the effects of psilocybin were about 4 times greater than your regular SSRI or any kind of antidepressant like an SNRI. And there was 2 sessions along with supportive psychotherapy. The first was a 20 milligram per 70 kilogram, and the second was a 30 milligram per 70 kilogram. The next is smoking cessation. There's a lot of studies that back this, but you guys can read the amount, like the details of the study. But the big thing about this experiment was that there was an increased self-confidence, shift in orientation towards the future, and reorganizing of life priorities. And the participants said that the psilocybin sessions gave them vivid insights into their self-identity and reasons for smoking. And they ended up placing great emphasis on the content of the psilocybin experiences, overshadowing any short-term withdrawal experiences they had. Strong rapport with the study team and preparatory counseling and a sense of momentum once engaged in the study were otherwise positive changes experienced in the study participants, including increased aesthetic appreciation, pro-social behavior, and altruism. Feelings are all interconnected as curiosity continued the acute effects once the psilocybin wore off as well. Other applications we see in substance addictions, if I could move this, alcohol and smoking, other anxiety disorders besides advanced stage cancer and terminal disease, cluster suicide headaches, chronic pain and inflammation, maladaptive narcissism, and narcissistic personality disorder, borderline personality disorder, epilepsy, and partner violence. And there's many more, but they're just a tiny amount of studies. And this is where you guys have optional homework. There's books, a lot of books, and there's a lot of websites and research articles and editorials and mental health care companies, like I said before, through Conquest, that would be great if you want to learn more about psilocybin. Through my research, I found that Shroomry is a very interesting website because they have more information, including effects of psilocybin and like experience reports. So if you were to wonder like personal experiences with certain things, then that would be the website to check out. And it also has very up-to-date things. Like, for example, this morning they posted a article about the demand growing for UK ministers to reclassify psilocybin for medical research. And then below, I just have a couple podcasts and videos. And that is all I have, because I'm pretty sure that's just a thank you slide. And these are my references.
Thank you so much, Christopher. That was wonderful. Any questions from the audience? There's some nice discussion in the chat side. Team, do we have any questions I should bring forward? Oh, yes. So there was a little bit of questioning about a hotline that can be contacted if someone's having a tough trip. And the Fireside Project is linked on the side. Firesideproject.org is a hotline someone can call and hopefully get some help with a difficult trip. Okay, so next up, we have another student doctor, student Ethan Zerpa. Ethan Zerpa is a native of the Pacific Northwest who grew up in Portland, Oregon, the city of Bridges, and attended the University of Colorado Boulder, where he obtained his graduate and undergraduate degrees in integrative physiology. Prior to medical school, Ethan spent 7 years working as a paramedic in various roles, including ambulance, helicopter/fixed wing, tactical medicine, event medicine, motorsport medicine, working alongside NASCAR and the IMSA racing circuits. Ethan's research interests include resuscitation, traumatic brain injury, and neurocritical care, amongst several others. Ethan is a Navy Health Professions Scholarship Program recipient and will serve as a Navy physician after graduating from medical school. Such a range of experience there. Student Dr. Zerpa, we are all excited for your presentation. You have the floor. Thank you so much for being with us.
Can you guys hear me okay?
Yes, we can hear you, and your PowerPoint is full screen. So looks good.
Thank you for confirming that for me. All right, everybody, thank you so much for having me. My name is Ethan Zerpa. I am going to be talking about ketamine in emergency medicine, and we're specifically going to be discussing its role in analgesia, anesthesia, and agitation. So why is a first-year medical student talking to you about ketamine and what qualifies him to do so? So prior to me actually starting medical school, I spent 8 years as a paramedic. I trained in Colorado, where I also did my undergraduate and graduate education in integrated physiology. And I had the opportunity to work as a paramedic, both on an ambulance and then most recently as a flight paramedic in Wyoming. I'm still employed by a couple of these companies, but I don't have any other conflicts of interest to disclose. And so with that, let's go ahead and jump right in. So what we're going to be talking about today is we're going to start off by discussing the historical origins of ketamine, where it came from and why we're using it. We're going to describe ketamine and talk about how it works and how it has the effects that we want it to have. And then with that, we're going to lead into why we use it for analgesia, how it works for anesthesia, and its uses in agitation as well. We're going to compare the dose response curve of ketamine and talk about how we have different effects based off of how much ketamine we're giving. And then we're going to wrap up our talk today with a review of the case of Elijah McClain. So ketamine was first synthesized in the 60s at Wayne State University, and the idea was that they wanted to come up with a better anesthetic than PCP, the derivative of, or ketamine is a derivative of PCP. It started off getting used as a veterinary anesthetic in the 60s and was finally utilized in humans and approved for use in humans by the FDA in the 1970s. The first individuals that were actually getting treated with ketamine were the American soldiers in Vietnam during the war. We're not really going to talk about the antidepressant properties that have been discovered in some of the future directions for ketamine. We're going to really focus on about those three things that I.
Can you guys hear me now? Okay, yeah, I just took the AirPods off. So we're going to start talking about the history of ketamine very briefly. It was originally synthesized in the 1960s by researchers at Wayne State University. The idea was they were trying to come up with a better anesthetic than PCP, which is what ketamine is a derivative of. It was utilized as a veterinary anesthetic first, and then approved for human use in the 1970s. And the first individuals that were actually receiving treatment with ketamine were the American soldiers during the Vietnam War. Now, I mentioned the three things that I'm going to talk about: analgesia, anesthesia, and agitation. We're not really going to talk about the antidepressant properties, but there's a lot of future directions and a lot of promising data out there about its use in emergent suicidality. So what is ketamine? Ketamine is a non-competitive NMDA receptor antagonist. It's a dissociative anesthetic. It's an amnestic, and it's analgesic and an analgesic agent. Essentially, you are inducing a state of detachment from the outside world. And you can sometimes have patients who have this sort of cataleptic trance where they have their eyes open and they're not really perceiving any pain. And that's what makes it a really, really good drug for the uses that I've discussed already. So how does ketamine work? So like I said, ketamine is an NMDA receptor antagonist. NMDA, as we know, is a glutamate receptor that's involved in long-term potentiation and long-term depression. It's found primarily in the hippocampus, the cerebral cortex, the spinal cord, and it causes an increase in calcium influx and potassium efflux. And this is where ketamine is targeting. When we have glutamate that's released in the spinal cord from the dorsal horn as a response to pain stimulus, that's where we get ketamine involved with acute and chronic pain, and that's where, like I said, its target is. Ketamine results in a blockade of the excitatory synaptic activity, and this creates a sort of loss of responsiveness that allows it to aid in severe, in several clinical scenarios, like I said, chronic and acute pain, as well as some other potential applications in antidepressants. So why do we use ketamine? So ketamine, like I said, a really good way to remember these uses in emergency medicine is AAA, analgesia, anesthesia, and agitation. Ketamine is lipid soluble, so it's going to distribute pretty quickly across the blood-brain barrier. It's metabolized by the liver and excreted by the kidneys. For the most part, you're going to see weight-based dosing, and we'll get a little bit into that here in a sec. Our onset with ketamine, because it is so lipid soluble, is going to be pretty quick. It's going to be about a 1 minute onset, and you're going to have a 5 to 10 minute duration of effect. So that's good for when we want to have an effect quickly and then be able to sort of do whatever it is we're going to do and manage the patient appropriately. For the most part, ketamine has a pretty wide and safe therapeutic index. It doesn't decrease your respiratory drive, which is one of the differences that sort of makes it stand out compared to other anesthetics. You also maintain your airway reflexes intact, which again is important. And cardiac function is actually stimulated rather than depressed, as with other anesthetics. And so it makes ketamine a pretty good option when you have a hypotensive patient. Additionally, it works pretty well via a couple of routes of administration. You could administer it IV, intravenously. You can administer it intranasally as well as intramuscularly. So let's jump into the dosing. So I want you to put yourself in the position of either of these two figures here, and I've conveniently included some sort of estimated body weights for biologically female and biologically male patients. I want to reiterate that the dosing isn't different. You don't have a different dose that you give a female or a male patient. However, just to kind of give you an idea of what the dosing might look like in a female and a male patient. So in green, you're going to have your female dose, so to speak. Like I said, this is just based off of those weights. And then in yellow, but really the dosage there is going to be 0.1 to 0.3 milligrams IV for the top, and then 0.5 to 1 milligrams per kilogram intranasally. So when we're using ketamine for analgesia, this is going to be our subdissociative dose. Subdissociative because we're not inducing that dissociative state. So when are we going to use this? We're obviously going to use this for pain, but we don't want to use ketamine as our primary pain control, pain management drug. we want to try to use other non-sedating drugs first. So these are going to be drugs like morphine or fentanyl, other opioids, if you will. When we want to use ketamine is when that opioid is either not indicated for the patient because maybe they have a sensitivity to the opioid, or maybe you have a person who is a recovering opioid addict and you don't necessarily want to, you want to help them with the pain, but you also don't want to bring them back into a potential problem for them. Or individuals who have already received opioid treatment for their injury or for their pain, and it just hasn't done the trick. So imagine somebody who has a very severe dislocation, a very severe fracture, and you've already given them morphine, and the morphine just isn't cutting it. This is when you would potentially introduce ketamine and give them a dose of ketamine. For the most part, like I said, this is going to be our sub-dissociative dose. So try to keep in mind what these doses are, because we're going to talk about how the dosages increase and how the effects sort of change as we go through the PowerPoint. You can imagine that the intranasal dose is going to be a little bit higher because we're going to have decreased bioavailability, so you're going to have to give a bigger dose. Another thing that you can do is rather than do this weight-based dosing, you can kind of take this sort of middle ground dose, 15 milligrams, which kind of splits the difference, if you will, and allows you to have a relatively safe dose that is going to have some of these sub-dissociative ketamine analgesic properties, and you can do that as well. So now ketamine for anesthesia. Now we're getting into the realm of dissociative dosing. We're giving a lot more ketamine, as you can see there, 1.5 to 2 milligrams per kilogram intravenously. That's a big jump from our 0.1 to 0.3 milligrams per kilogram intravenously. Ketamine is an ideal induction agent for intubation, especially because of its relatively safe profile, its minimal effects on the respiratory drive, its a quick onset, its quick duration, and of course the analgesic properties as well. It's fairly hemodynamically stable, like I said. It's compared to some other induction agents, it's going to be a little bit safer when we talk about agents, for example, like etomidate, which have some other effects. For the most part, you're going to have an increased heart rate, increased blood pressure, and so that makes ketamine an ideal agent to use in a hypotensive patient who needs aggressive and prompt airway management. When you're using dissociative dose ketamine, as we are in this case when we're intubating a person, you're going to want to make sure that you're continuously monitoring them. So you want continuous telemetry monitoring. So put them on the cardiac monitor. You're going to be monitoring their end-tidal CO2 as well to make sure that they're ventilating appropriately. And you want to make sure that they're oxygenating appropriately. So you're also going to be monitoring their pulse oximetry. And of course, if you're getting ready to intubate a person, you're probably already doing all these things anyway. These individuals who are receiving dissociative dose ketamine, in this case for anesthesia, they're going to not have any perception of their external stimuli. They're not going to have any memories of this. And so obviously we wouldn't want them to if we're taking away their airway. So now, ketamine for agitation. Again, this is going to be our dissociative dosing. I'm going to have this little disclaimer here for the first dose there, 1 to 2 milligrams intravenously. We also use ketamine for procedural sedation. So somebody who has a severe dislocation and we need to put it back into place, set it. Not somebody that you want to be awake for that, obviously a painful procedure. And so that's somebody who can receive dissociative dose ketamine to sort of take them out of that situation mentally so that they don't feel the pain and they don't have any memory of the pain. So that's kind of what that first dose is. It just didn't really fit my analgesia, anesthesia, and agitation model. But for this slide, we're really going to talk about the agitation primarily. You can see there that below 4 to 5 milligrams per kilogram intramuscularly is going to be the dosage that we use for ketamine in an agitated patient. Now let's talk about how we define the agitated patient. This is going to be an individual who is suffering from what has sort of largely become described as excited delirium. These are individuals who are posing a threat not just to the providers in the room and other people around them, but certainly to themselves. Individuals who are experiencing excited delirium states can have cardiac dysrhythmias. They can be suffering from hyperthermia, other life-threatening conditions as well. They have paranoia. They may be experiencing hyperaggression, hallucinations, tachycardia. They might have this perception of increased strength. And a lot of times we see physical stimulation of these patients with restraints. And that's something that we actually want to try to minimize. We don't want to restrain these patients. These patients are having a true emergency. And so that's why we want to be pretty aggressive with the way that we administer ketamine, because ketamine is really indicated in these patients because it's going to have a fast effect. It's going to allow them to kind of calm down so that their emergency can be addressed. And the first step there is going to be by using the intramuscular ketamine. So you can see here, 4 to 5 milligrams per kilogram. If you insert your own weight there, you can see just how much ketamine you would be receiving. In this case, 240 milligrams to 500 milligrams. That's a very big jump from the sort of weak, 15 milligrams that you might be getting if you were receiving analgesic subdissociative ketamine. Again, this is excited delirium is really its own talk, and I'm not sure if there's going to be another talk during this presentation, during this conference about that, but it really is its own talk. So now let's kind of wrap up and summarize what we just discussed with the ketamine doses. So on the left, you're going to see a table that talks about kind of what our targets are for dosing and what the effects are going to be. So when we have analgesic or subdissociative ketamine, that's our 0.1 to 0.3 milligrams per kilogram range. And at the bottom, 1 to 2 milligrams per kilogram, that's going to be our fully dissociative state. Everything that happens kind of in the middle, that 0.2 to 0.8 milligrams per kilogram, this is kind of where we start to see a lot of the psychoperceptual effects that can be seen with ketamine that can be problematic. Obviously, the lower the dose, the better. But as you get a little bit closer to that fully dissociated state, you start to have a little less, it's a little bit less predictable as far as what those psychoperceptual effects are going to be. This is where some of the untoward effects of ketamine, the emergence reactions that we may have heard about before, can come, especially in that partially dissociated state. This is a graphic by Dr. Ruben Strayer. He's an ER doctor in New York, and I think he's done a lot of work to try to dispel any myths about ketamine and get people a little bit more comfortable with using ketamine in emergency medicine. And so what his graphic here shows, both graphically and numerically, is it kind of shows you what that range of ketamine and what those effects are going to be. We really want to stay away from those middle areas. We want to keep people in either the subdissociative or analgesic states of ketamine or that fully dissociative state of ketamine. Again, that partially dissociated state is one that we're going to want to try to avoid. So speaking of some of those untoward effects, let's talk about some of the other things that you might see when you administer a patient ketamine. Not really going to see a lot of respiratory oppression. It might be, it's pretty rare and transient. A lot of times it has to do with how quickly you administer the ketamine. You may see laryngospasm, but again, not usually very often. Hypersalivation is something that you can sometimes see, but it's something that you can pretty easily manage with suction, having suction available. Vomiting is going to be something that you see more often than not, but it's something that you can kind of address pretty easily by co-administering ondansetron or Zofran. And then that emergence reaction, which again is going to happen, especially if you don't give someone enough ketamine and they find themselves in that partially dissociated state, or when you give somebody a dissociative dose of ketamine and as it's getting metabolized and that person is sort of coming out of the K-hole, so to speak, and once they're re-emerging, that's where you tend to see those untoward emergence reactions, those really intrusive psychoperceptual effects. But you can minimize that by giving an individual a co-administering midazolam. So now that we've talked about ketamine a little bit, I want to introduce the case of Elijah McClain. Elijah McClain was a 23-year-old individual who was contacted by police in Aurora, Colorado. 10:43 p.m. is when he gets contacted. Over the course of the interaction, Elijah is detained. He eventually is physically restrained by the police, and the firefighter paramedics are called to the scene. At 10:53, the firefighter paramedics arrive. Elijah's behavior was described to the firefighter paramedics by the police as being violent, as fighting, struggling with incredible strength, with crazy strength, with superior strength. These are quotes from the actual after-action report. It's worth noting to you that Elijah at this point is handcuffed and is face down, laying on the ground. Now, Elijah weighed about 140 pounds or 64 kilograms. These individuals that contacted this patient, again, I wasn't there. This is something that happened in the state where I worked primarily. I mean, it kind of touched everybody very closely, but I was not directly involved with this case. In Denver, the city of Denver, the protocols for excited delirium call for 5 milligrams per kilogram to be administered intramuscularly of ketamine. In this case, Elijah weighed 64 kilograms, but the decision was made, or the estimation, I should say, was made by the people on scene that Elijah weighed 100 kilograms. And so they dosed him with 100 kilograms at 5 milligrams per kilogram. So he got 500 milligrams. What he should have gotten, I did the math there for you, was 320 milligrams. So there's about 3 hours worth of harrowing footage that's pretty difficult to watch, but I sort of summarized it here. I took some screenshots of the scene for you and kind of narrowed it down to about 5 minutes. So at the 0 point of this 5 minutes, 500 milligrams gets drawn up of ketamine. 15 seconds later, they administer the ketamine. About a minute and a half, you hear one of the police officers or firefighters say, "Yep, he's snoring, he's out." About 30 seconds later, Elijah gets moved to the gurney. About 15 seconds after that, they realize, oh, maybe we should put an N-tidal CO2 on him. Let's look at his oxygen, or I'm sorry, his carbon dioxide levels. About 20 seconds after that, he starts to agonally breathing. So this is sort of what's called guppy breathing, if you will, not perfusing, not adequate breathing. They realize about 7 or 8 seconds later, hey, we need to get him inside the ambulance and suction him. Within a couple of minutes, CPR is in progress, and they are taking Elijah to the hospital. All in all, there was this call lasted about 20 minutes. It started at 10:43 p.m. and by 11:04, CPR is being done on Elijah. Unfortunately, Elijah was pronounced dead 3 days later, and then 3 days after that, he was pronounced brain dead 3 days later, and he was unfortunately passed away 3 days after that. Now, the response to the Elijah McClain case in Colorado was pretty severe, and the Colorado State Legislature stepped in and actually considered taking ketamine off the table entirely for its use pre-hospitally. This obviously created a big problem, big rift between the lawmakers and the individuals on the ground providing the care. It also sort of set this precedent of, wait a minute, so why are lawmakers all of a sudden able to make decisions and make medical decisions without actually being licensed to practice law? There's a reason that, or licensed to practice medicine. There's a reason that medicine is practiced by medical providers and not lawmakers. We won't get into that argument. But part of the problem here, I think, is that there has been this problem with excited delirium, especially. It's been highlighted in a couple of position papers by the American Medical Association, and actually a paper that was put out by the Lancet last week, where police officers contact an individual and they sort of say, "Oh, you know, this person is out of control. We need the paramedics to come and we need them to sedate them." And so when the paramedics show up, they say, "Oh, you're going to need to sedate this person." And so as the paramedic, you sort of hear that and you already start to automatically kind of go down that route. And again, the same reason that lawmakers shouldn't be practicing medicine and making decisions, you know, based off of not being medical providers, police officers should not be making that assessment and making that decision for the providers. And that's something that the providers should be making on their own. So what happened as a result of this? There were a few iterations of legislature that were introduced. They kind of went back and forth. The big thing that happened as a result of this is that there was a bigger mandate for improved and better training in ketamine for providers, for pre-hospital providers in Colorado that were going to be giving ketamine. These were the two big things that came out of this. I can tell you anecdotally from my experience when we first got ketamine in the state of Colorado, the rollout was not good. It was not an adequate training. I think it was pretty superficial. It was one of those things where it's like, hey, you know, watch this module and you'll be fine. And here is, you know, I think we used to carry 1,400 milligrams of ketamine on every ambulance where I worked. Certainly a lot of drug for sure. The point is that one of the problems that happened, and I saw this especially at the agency where I worked, was that people were very excited to use this new drug that we had never had before. And so you saw the use of ketamine increase dramatically, not just for pain, but also for agitation. And it was a problem because people were not trained properly on how to use it. And here they were using it all of the time. And obviously, you know, this is, you know, I'm describing my experience at my agency, but this obviously happened across the state and led to providers who were not well trained, were not adequately prepared to administer a drug that can obviously have deleterious effects if not used appropriately. I can tell you from my 8 years as a paramedic, I probably have given ketamine in an ambulance probably 5 to 6 times. And in 8 years as a paramedic and treating thousands of patients, I can think of one time where I maybe encountered somebody that I would assess as having had excited delirium. And at the time, we didn't have ketamine, so I wasn't able to use ketamine for excited delirium in that situation. I was able to take care of that individual by administering intramuscular midazolam, because that's all I had at the time. In summary, or one of the other things that came out of this was the American Society of Anesthesiologists and the American College of Emergency Physicians came out with a joint position statement, essentially saying, you know, we see what's going on in Colorado. We don't think that you should take ketamine entirely away from individuals. I think that's not the right move. Ketamine is a good drug. It's widely used. We use it in the emergency department, and it's used pre-hospitally. You can effectively manage someone's pain. We can effectively sedate someone, and we can control the agitated patient. But you need to be able to make an appropriate medical assessment. You need to dose it appropriately, and you need to monitor that individual patient that's receiving the ketamine and take them to the hospital. In summary, ketamine is a safe drug when it's used appropriately, when the patients are dosed according to their weight accurately, and when providers know exactly what to do and how to manage the potential effects of ketamine. Like I said, one of the unfortunate results of this in Colorado was that a lot of agencies stopped using ketamine altogether. And like I said, it's an effective drug. It's a good drug, but to be able to be used effectively, it needs to be for a drug to be effective, it needs to be used effectively. And unfortunately, that was something that kind of fell apart in a lot of agencies in Colorado. And so with that, if you have any questions, I don't know if we have time, but I'll be happy to take some questions here. You can certainly shoot me an email as well. And these are my references.
Student Dr. Zerpa, I must congratulate you on a fantastic presentation. Really, practical, meaningful, on a social perspective. So many aspects of this was excellent. One of the questions we've gotten from the audience, let me just pull it up quickly, is exploring the use of ketamine for acutely agitated patients with history of traumatic brain injury. But I really want to kind of just expand that to, first of all, like a geriatric patient who's in agitation. I know we try to avoid the atypical or any of the antipsychotics. I know we try to avoid the benzodiazepines. Do you think ketamine has potential in treating the agitated geriatric patient?
I do, and I'm trying to fix my background here, and I don't know what I'm doing, so I'm just going to stop. I think that, what's that?
It's fine.
Yeah, sorry. Yeah, I do think that there's a lot of potential for ketamine in the geriatric population. Obviously, these are going to be individuals that are potentially being managed with, I think, as the question said, other antipsychotics. So for the most part, like I said, ketamine is relatively safe to dose. You don't really want to microdose individuals who are, how to say this? You want to avoid getting into that middle range of analgesic and dissociative ketamine. You want to sort of stay away from that. So I think regardless of the age of the patient, as long as you're dosing them appropriately for the intended use, I think you're going to be okay. I think you were saying some other things about some of the other antipsychotics that can be used.
Yeah, it's just that when we have an acutely agitated geriatric patient, the tools that practitioners usually reach for are the antipsychotics or the benzodiazepine or the anticholinergic, all of which are simultaneously contraindicated in the geriatric population. So it's kind of a rock and a hard place. And I'm wondering if ketamine, and it sounds like it may be able to serve as a bit of a cushion in between those, but still running the same risks of increasing disorientation if not dosed appropriately.
Sure. I think part of the problem, especially with ketamine, is that it doesn't get used for the intended uses as often as it should be. So when we consider the agitated person, let's sort of ignore the age for a second. You sort of have these three categories in which we can put agitated patients. You can have an agitated person who is agitated but not really causing any sort of disturbance. That's not somebody that needs to be dosed with ketamine. Then maybe you have an agitated, combative person, but who you are able to talk to and who's able to respond and who's able to engage. Those are individuals who may be suffering from delirium as a result of a psychiatric problem or psychiatric disorder, I should say. These are individuals who maybe they're going to be more appropriately managed with some of our, so for example, these are individuals who you could manage, for example, with Haldol or haloperidol and lorazepam. That's somebody that you might be able to use that with. Alternatively, you can use olanzapine for those patients, or I think droperidol is also being used now as well. It's coming back. But they're not individuals in which you need to use ketamine. Really, the ketamine for the sake of sedation or agitation, I should say, should really be reserved for an individual who is acutely, for a lack of a better term, in a hyper aggressive, violent mode that's potentially putting at risk themselves as well as the other individuals that are part of the care team. So outside of the person who is experiencing intractable pain that hasn't been touched by any other opioids or other management, and outside an individual who's exhibiting violent aggression that is intractable, that you're not able to coach, that is, potentially putting themselves at risk or you at risk, there really is no need to consider the ketamine in that patient. And so in that, I guess maybe I'm taking back what I'm saying. I think it would be safe to use in an elderly individual as long as it's being utilized for the right purposes.
Thank you for clarifying that. So kind of just to synthesize that the ketamine is best appropriate for an agitated patient, almost in the role of a kind of chemical restraint, where this person really just needs to be, take a little bit of a rest. And I just want to follow up with one more question about the analgesic. Do you see ketamine becoming an analgesic between NSAIDs or Tylenol and opioids, or do you think opioids are going to stay as the kind of first line escalation above the typical pain control? Or what do you think is the conversation like in that space?
I think you're already starting to see a lot of chronic pain patients who are receiving ketamine because of its relatively safe profile and its ability to sort of treat their pain without having to cause that same addictive property that some of our other opioids have. I do think that it's going to be seen a little bit more as people become comfortable with it. Again, as long as, at least in the emergency room, I think you're going to see it a lot more with individuals, as long as it gets dosed appropriately, as long as patients are not being given more ketamine than is really necessary. I think you're really able to have a good effect. I don't know that you'll ever see ketamine take the place of some of the more traditional opioids, but I do think that it has a place in acute and chronic pain management. I think you see pain clinics and stuff like that are using ketamine, not necessarily as a one dose shot of ketamine, but even ketamine infusions as well.
All right, well, thank you so much. That was a wonderful presentation. We do have one more question for you in the chat if you want to stick around and answer that, but we do have to move on. Our next speaker is the magnificent Magdalene Lederer. She is a second-year medical student here at RowanSOM and is president of the Students for Integrative Medicine Club. Although from New Jersey, she left the state to pursue a bachelor's degree in biomedical medicine, global studies from Liberty University in Virginia. She is passionate about women's health and volunteering with the Spanish-speaking community. She's also passionate about all forms of social justice and societal reform, really an inspiring and passionate person to work with. And she has done a ton of the heavy lifting and detail-oriented organizational work without which this conference would have been impossible. So I have a personal huge thanks to her. And I'm sure we're all looking forward to your presentation, Magdalene. You have the floor.
All right. Thank you so much, Jesse, for that very kind introduction. Just going to quickly share my slides. All right. All right, everyone can see this? All right,
Excellent.
got a thumbs up. All right, so like Jesse said, my name is Magdalene Lederer. I'm a second year here at RowanSOM, and today I'm going to be bringing you my presentation on eating disorders and therapeutic uses of psychedelics. Let's find the slide. Sorry. Go forward. 1 second. Try again. Hey, Jason, can you actually share these slides for me? It's not letting me move forward.
Yeah. Can you do that?
All right. And the box isn't coming up for me to move forward, so I'm going to have to rely on you guys to move the slides for me. Sorry, thank you. All right, so we can begin. All right, so just some background on eating disorder treatment. Eating disorders have multifactorial causes that can make them very difficult to treat. There have been many different proposed mechanisms as to the brain pathophysiology that occurs. However, we don't have a really clear consensus. MRIs have demonstrated disruptions in the neural circuits, supporting emotional processing in the amygdala and self-regulation in the dorsolateral prefrontal cortex. Current pharmacology has really targeted the neurotransmitter and hormonal disruptions that tend to occur because of disordered eating. Next slide. Worldwide, there's actually only one medication approved for an eating disorder, and it's for bulimia nervosa fluoxetine. In the US, we also have lisdexamfetamine, which has been approved for binge eating disorder. However, there are no approved medications for anorexia nervosa, avoidant restrictive food intake disorder, or pica rumination disorder. Next slide. There are other medication options. You know, things are used off-label all the time. So olanzapine and other atypical antipsychotics have been used for anorexia nervosa, as well as topiramate has been used for bulimia nervosa and binge eating disorder. However, these tend to have only minimal to moderate efficacy. Next slide. So this is where psychedelics can come in. With these limited options pharmacologically that we have for patients with these disorders, there aren't many options, and patients often fall off these protocols. They don't like the major side effects. They don't like anything else related to them. So anorexia nervosa remains the most lethal mental illness with an extremely high mortality rate that continues to be documented, even as it becomes more and more understood and accepted as a mental illness. It still has very high rate of mortality. A survey done in 2021 by Harding showed that people with eating disorders really do want this research. They want more options. They want to try if these things can get them off a drug that they take every day for the rest of their lives and even lead to regression, not just symptom management. Next slide. So now I'm going to go through the current research that we have available that's actually been done either in animal models or in humans with psychedelic compounds. And then I will go into some proposed research that's coming from what's been done in other mental health disorders and how it could possibly be applied to eating disorders as well. Next slide. So there was a study done back in 2013 with dronabinol, which is an endocannabinoid very similar to THC, but still slightly different. So they took 25 women with a strong history of anorexia nervosa, gave them dronabinol, 2.5 milligrams twice daily for 4 weeks, did a washout period, and then did a placebo for 4 weeks. 24 women completed the trial. but there is significant change in body weight, a gain of 0.73 kilograms, which is very important and statistically significant for treating these patients who, sometimes you just need to gain weight before you can get to anything else. However, there were no significant changes in the eating disorder inventory 2 that they gave to these patients. Next slide. So THC, multiple kinds of THC have been studied with eating disorders. For example, delta-8 THC was used in a rat animal model. So they looked at animals with binge eating disorder, and they were able to show that it did increase the weight in these rats, and it increased their cognition as well. And both of these were statistically significant results. There was also a pilot study done with delta-9 THC for anorexia nervosa patients. This study was really fascinating because it showed decreased ascetism, which is the very strict discipline about themselves that most people with anorexia nervosa tend to have, an increased body care of just taking care of themselves, and a decreased depression rank on the Beck Depression Inventory Test. So all of these look more towards the lifestyle effects, not just the physiology that tends to be disrupted in eating disorders. They did have moderate weight gain, but that did not demonstrate any statistical significance. Next slide. So in this study, researchers looked at a bunch of different people. They asked them if they had an eating disorder and if they were going to be doing a psychedelic experience on their own, not as a part of the study. So they completed both of these surveys, the Quick Inventory of Depressive Symptomology and the Warwick-Edinburgh Mental Wellbeing Score, 1 week before and 2 weeks after the psychedelic experience. And what they had was an improvement in the depression scores and improvement in well-being scores, demonstrating that this is not just about treating the disease and managing the symptoms, but really moving towards regression of these kinds of disorders. Next slide. Lastly, there were 2 studies done on ayahuasca. So these studies both did post-experience interviews, and they looked at the main themes that people who completed ayahuasca reported after their experience. So in Raleigh 2018, they interviewed 13 different people, and they reported rapid decrease in ED thoughts, healing of root causes of eating disorders, processing painful memories, increasing their self-love and self-acceptance, and even catalyzing spiritual elements, like Dr. Strassman was talking about earlier. And all of those really can lead to lifelong remission of these diseases. LaFrance in 2017 also looked at 16 participants, and they had the reduction and cessation of ED and mental health symptoms, shifts in body perception, and they also went back to what we've heard a lot today is the importance of the setting and aftercare. You can't just go and have an experience and not be taken care of after. It's really important to have that kind of integration post-psychedelic experience. Next slide, please. All right, so now we're going to look at a couple studies that the authors are proposing these substances could be used for eating disorder treatment in the future. Next slide. All right, so this paper looked at, in Brewerton 2021, looked at people with eating disorders and PTSD. MDMA has been used successfully to treat PTSD, and unfortunately a lot of people with eating disorders have comorbid PTSD. So the author's idea was that they might already have this disorder and it's been working well for them. Why not integrate it into people who have this combo? Pharmacologically, MDMA, we had explained, it hits a ton of different neurotransmitters and hormones all at the same time. So what it does is it is able to very quickly get at these deep-rooted emotions and really turn them on their head. As you see here, there's associations with MDMA in general is reduced fear, increased sociability, which is incredibly important with eating disorders, increased interpersonal trust, which is also important, and increased compassion for yourself and others. Next slide. All right, so this study looked at ketamine and the possible use of ketamine with eating disorders. Ketamine, as we know, has been used for treatment-resistant depression with great success. We'll be hearing a poster on that tomorrow, actually. It works as an SSRI, but also works with dopamine. It works in the reward and motivation center, and so ketamine can induce that neuroplasticity that we've been hearing about a lot today, and very specifically work in the reward-related associations. Reward-related associations tend to be disordered in eating disorder patients, so that's why the authors seem to think that this would be an incredibly important use of this drug. They suggest that patients in trials in the future be aware that ketamine is a very intense drug, and so they might have more intense therapeutics, and it might get a little worse before it gets better. Case studies have also demonstrated decreased suicidality, decreased compulsive eating, and a reduction in the anorexic voice. And while all of those are important, the decreased suicidality is really the biggest point that we want to explore in the future with psychedelics for eating disorders, because unfortunately, suicide is a main way that patients with these disorders end up losing their lives, and we want to continue to fight against that. Next slide. All right, so just some closing thoughts. Eating disorders are associated with high mortality and low regression. In the UK, 1.5 million people suffer with an eating disorder. The current options for patients with eating disorders are very limited, marginally ineffective, had high drop-off rates, and tend to focus just on making someone gain weight or getting someone to stop throwing up. And that's obviously not what we want. Early psychedelic research, as we've seen today, is pointing to success, not just with some moderate weight gain and some symptomology, but also with internal healing and remission of the disease. And that, for me, especially as an osteopathic medical student, is the goal, is healing and remission of disease. Because I don't want to have a woman come into my clinic one day with an eating disorder, give her a pill, and tell her this might work, and that's all I can offer her. So we would really like to see more research into this area so that we have more options for our patients. Next slide. So these are all my references, and then any questions for me, I will take.
Magdalene, you've done it again. That was fantastic. We do have one question that was submitted in advance, if you'd like to hear it.
Sure.
Is there pushback from the pharmaceutical industry in regards to using psychedelics in healthcare for something that could assist with eating disorders, which currently are predominantly limited to therapy? Do we still face the same pushback?
I would say it might not be overt pushback, but there is a bit of a financial gain to keeping someone through therapy twice a week for their entire lives, or on a medication every day for the rest of their lives, versus you do a couple intense treatments maybe once every 5 years, and you see a therapist once a month to see how you're doing. There definitely is a financial aspect of that. I think the greater barrier with eating disorders is just the Schedule 1 set for all these psychedelics. It really seems to affect getting any studies done. And these studies I had some of them were very recent. And so we hope to continue this momentum that we've been talking about today of cannabis getting some publications in 2022 and all these other things. So we're hopeful for the future, but unfortunately I do think there is an undercurrent in mental health in general of just slapping a pill on something and keeping someone symptoms okay are gone, but they're still suffering.
Yes. I mean, I totally agree. It's our first line, you got to treat the infection. You can't just suppress the fever, right? So we need to get to the root of issues if we're really going to be serving our patients as well as possible. Thank you so much, Magdalene. Our next speaker will actually be introduced by Jason Leonardo. Jason, if you would.
Hey everyone, so thank you again, Magdalene. It's truly incredible the range in which researchers are finding efficacy with the use of psychedelics. Something like eating disorders, which again, like Jesse had just touched on, and of course you, these things have been seen with such limited tools and treatments available for them. So something like this could really be revolutionary for people with an eating disorder. So thank you again. So we just have 2 presentations left for the day. Next up, we have Dr. Nathan Riley, and that'll be followed by student Dr. Jesse Benzell. Both of these presenters have a lot to offer in terms of spirituality and well-being. Dr. Riley is specifically going to be focusing on the palliative care aspect of it. So just a little bit about Dr. Nathan Riley. He's a MD who is board certified in hospice and palliative care. He has a holistic OBGYN practice and provides remote palliative care services to the underserved populations of Northern California. Dr. Nathan Riley completed medical school at Temple University, right over here near us by Philly, and his residency at Kaiser in Los Angeles. And he also completed his fellowship at UC San Diego. He lives in Louisville, Kentucky with his wife and baby girls. He is the host of the Holistic OBGYN podcast. So Dr. Nathan Riley, I see you're on, so take it away for us. Oh, you're muted, Dr. Riley.
Can you hear me now?
Perfect.
Awesome. I know you guys have been here for a long time. I was in the call early today, but we're doing potty training and I was covered in poop and I had to go and clean up. It's just how it goes when you're a dad, everybody. So welcome to medical school. And medical conferences are oftentimes, I think, a little bit challenging because you're getting just an onslaught of data. And fortunately for me, I'm not the smartest person here, and I've got a whole bunch of you guys to present all the data. I'm going to be talking a little bit more on the soft and squishy side because I do birth and I do death. And those are 2 things that have a lot of components that we can't really measure and we really can't express through data. And so that gives me a great privilege as a doctor, but it also is a sort of the bane of my existence, is trying to justify why I do certain things. So are you guys able to see slides, or do I have to share something? Let me see here.
Yeah, so the 3rd button kind of in the middle is a box with an arrow upward is the share button.
All right, let's just do this. You're going to see my slides and you'll see my, oh, actually, you know what I can do is, yeah, you'll see my slides and my notes, and that's okay because we're all friends here. Entire screen. Let's see that. Let's just try this. Sorry, guys. You'd think I'd be better at this. I'm a freaking podcaster, you know? All right, can you guys see anything now? Oh, here we go. Here we go. Oh, boy. All right, you're just going to see my whole screen. Can you see it now?
Not yet.
Well, I've got 5 minutes left in my presentation. Hang on. It says I'm sharing the whole screen, but nothing's popping up. We can't display your shared content. Make sure you've allowed permission to share content, then try again. Well, if you guys have slides, do you mind just throwing them up there and I'll give you the wink or something and you can advance it? Sorry.
Yeah, for sure. We'll put those up for you.
Okay, great. Because then you don't
let us know whenever you want them switched.
You can pop them up right now, and I'll just give you a signal of some sort. Probably just say something like slide. All right. So thank you for that introduction, Jason. My name is Nathan Riley. I'm a board certified OBGYN and hospice and palliative care physician. You did all my credential stuff, which is kind of boring, really. Like, who cares where you went to med school? One thing I will say is, since you guys are all osteopaths, you have a leg up on all of us allopaths. You guys learn a whole skill set that we have nothing to do with. So please embrace that and continue doing it, because I love sending people to my DO friends because they do all these manipulations and stuff that I have no concept of. So please keep doing your manipulative therapies. Just like the next generation, we got to get you guys back to doing osteopathic work, because allopaths, we have this tiny little shrivel of education to share. I'm also going to be asking a lot of questions, guys. So please, please don't be shy. When I was in my OBGYN training as a surgeon, you're a failure if you say, I don't know, or let me go find out. If you don't have the answer there, or you don't make up something that sounds good to everybody, or you don't pull the fire alarm, you look like a total dope, because everybody expects you to have the answer. If you have all the answers, this isn't fun anymore. You might as well just retire. So I want you to all just embrace this conversation as a conversation, and not so much just me presenting a bunch of numbers and data, which, again, I'm so grateful other people have done that, because that lets me get into the nooks and crannies here. So the first question I have for everybody is, by show of hands, or maybe just put like a here in the comments, who here has actually had an experience with a classical psychedelic or cannabis or even MDMA? Just like real quickly pop it in there. If you don't want to disclose your experience, then that's fine. I've used everything under the sun and will continue to, because it is an extremely important part of my spiritual practice. So we've got at least a couple brave people. If you've had an experience with a psychedelic, you understand that there's a lot of, you've gone home and you're like, mom, or maybe not mom, but you know, your best friend from college, you're like, listen to what I did. And they're like, cool, bro, do you want to play Call of Duty or something, right? Because there's something ineffable about this, right? If you've read Michael Pollan's book, he's a gardener. He came from like the food world and then started writing about psychedelics. And he, with all of his language, was still kind of unable to really describe what's happening within the psychedelic experience. And that's important. So let's read this little passage together. This is from an article that Steve Ross and Malone et al. Is really the official authorship. This is a direct quote from the paper. This is a participant in a psilocybin assisted psychotherapy trial. I would say I have less anxiety about my body and my sickness coming back, my cancer coming back. I saw this body for what it's worth. I picked it. It's mine. I think that acceptance has been liberating. I am convinced beyond any doubt that there is a spiritual realm. The spirit guide showed me a world that I believe to be very, very real. It is what it is. It's not worth worrying about things you can't change. So hell yeah, right? Like, so how do we then take that experience and try to use a novel therapeutic in order to help them cross over? And that's a rhetorical question. You don't have to answer that. So I want to instill in everybody, you guys are learning about all these medicines, IV fluids. By the way, the easiest way to screw somebody up is to give them too much IV fluids or the wrong IV fluids. That's all you need to know from medical school. Everything else is like, yeah, you're going to have somebody watching your back until you figure out the dose. I will say 500 milligrams of ketamine is an F ton of ketamine. So probably you're going to always have to question how much ketamine you're giving. I'm not going to talk about ketamine here, but we used ketamine in fellowship all the time at UC San Diego, which happens to be one of the largest cancer centers in the world, where people would come up with like graft versus host disease. We've tried every opioid under the sun, and they still don't have any of their pain taken care of. You flip them onto ketamine, and something magically happens, and there's that dissociative effect and everything else. But I digress. When you're,
Excuse me, Dr. Riley.
yes, sir.
Real quick, let me interrupt you. So you should be able to switch your slides now. Would you mind trying that?
Let me see how.
Hopefully, what we did works
right.
out.
Where the heck is it? I don't even see it on here. Hang on.
Hi, Dr. Riley. Do you see a black bar on the left side of your screen?
It's just blackness. It's just utter blackness on the left side. There's nothing to click there.
So there should be a vertical left bar if you kind of hover over the left side of your screen. And in the center of that bar, there's an O1 with an arrow above and below it. You can use those arrows to change your slides.
I have none of that.
Okay.
Sorry.
If that doesn't work for you, then I can also change your slides, and you can just let me know when you want to advance.
I don't see any slides at all, actually. My slides are gone. You guys are still seeing the first slide?
Yes. Can anyone else see the slides?
Oh boy, I'm a total loser. So see, a lot of other people can't either. So what are we all doing wrong?
Okay, let me try unsharing and sharing again.
Okay.
Can people see slides now?
I can see it now.
Okay, so I'm going to give you presenter privileges.
Cool. So you guys probably thought I read that previous one just from memory, right? Because I'm just so sure. I'm now the presenter, but now the slides are gone.
I thought you were just flowing, Dr. Riley.
Well, I mean, I am good at flowing. I've never been a super academic. I mean, you learn everything you need to know, but I think flowing is what we need today at the end of the day. I don't see my slides at all now. I'm so sorry.
Okay, so if you'd like, I will just share them and you can let me know when to advance them.
Okay, let's do that. Let's do that.
Let me pull them up one more time. Thank you guys for bearing with us.
Grab a snack. By this point, people are probably wondering, did this guy actually get board certified in anything? He is talking like he's from outer space, and I promise you I have.
Can you get
Okay.
board certified in cool room design? Is that a license, or is
Yeah,
that off
yeah.
label?
I do that. That's my side gig, is helping people decorate their offices. Trust me, it's a working process. You should see what you can't see in the room. I've got like 1,000 books with copious notes attached. All right, so we can advance, Ayesha, to the green slide and then to the next one. Yeah. So this, so what I was getting into is what we learn in medical school is a big part of what it means to be human, the measurable things, right? Is there an infection? Is this person losing too much blood? Am I cutting the right artery? Am I, you know, in the right space, right? In the pelvis, we do a lot of surgery in these various spaces, right? And you want to make sure you're not getting too close to a nerve bundle and this and that. The measurable things are important. And that's where pharmacology, pharmacokinetics, and pharmacodynamics comes into play. But what about the immeasurable things? There's a lot that is immeasurable. And so my next question for you guys, what is evidence-based medicine? Just leave like a one-liner on the right side. I know it seems like an easy question. And again, there's no wrong answer. I'm going to answer for you because I don't see anybody popping up. But what I would say, the way I would define evidence-based medicine is that when we decided we can reduce our human experience to just the measurable things, we can filter out all of these confounding variables, and we can isolate just a specific variable within a very, very controlled demographic in order to see what does something do and what is the predictable outcome in a linear relationship from dose. So just looking at medications. Well, that's really, really helpful in some ways. But the limitations of evidence-based medicine are that data isn't everything. For example, if I cut open your brain, I don't find consciousness. If I cut open your heart, I don't find love. If I asked you how much you love your partner, what is it, 6, 10? Like, what's the number? How much do you love your mom? So there is some limitation. It's a toolkit we have, evidence-based medicine. When we talk about psychedelics, we have to really be thoughtful about the limitations of how we can quantify a person's experience. And I would even argue that we really don't even necessarily always need data to justify the use. Yes, I said it. I know that that's going to get a lot of people all riled up. But the reason I say that is that once we start trying to regulate some of these therapeutics, we end up in a position where we're extracting one single chemical from a very complex plant, which is not even a plant. It's part of a separate kingdom fungi. And we're now going to try to put that into a capsule on the shelf that we can use in a linear relationship, as we do with every other medicine. And I would venture, if you have responded that you've had an experience with cannabis or a psychedelic, you've gone to outer space with 5-MeO-DMT, you've used MDMA, I'm not exactly sure that we can really say that there's a linear relationship there. It doesn't matter how much data there is. There's some people that have 2 grams of mushrooms and 10 grams of mushrooms, and they may have paradoxical experiences. So this is the challenge with regulation. And I'm not saying we shouldn't be regulating. I'm the curious one, and I want you guys to just be thoughtful about these things. So my next question, you can advance the slide there, Ayesha. So what is birth? This is my daughter, by the way. We had a baby in the hospital, and then we had a home birth the second time around. And the home birth experience, guys, is out of this world. It changes your entire perspective on what birth is, and therefore what being human is. So what is birth? And that's a rhetorical question, but think about it. What is happening in birth? Next slide, Ayesha. What is death? This, by the way, this is one of the incredible graphics of Alex Gray, who, by the way, started as a medical illustrator, as far as I know. I met him once naked at Foam Dome at Burning Man, and we fist pounded. That's my claim to fame. He has done some of the most incredible illustrations of the astral, of the spirit, and we're going to get into mind, body, spirit in a second. But when you think about death, ask yourself, what is actually happening? And I don't mean looking at it through the lens of Christian theology necessarily, or any other major religious sort of paradigm, But what is death? What happens when you die? What is a person experiencing when they die? And can we measure that? Maybe, but probably not anytime soon, nor do we really necessarily need to. Next slide, Ayesha. So I would argue, and I've sat with over 1,000 births and deaths, I would argue that if you're paying attention there, you're going to see something very similar happen. You're going to feel and sense something very, very similar between these two events. I would argue that birth and death are two sides to the same coin. What do they have in common? They're two things we don't talk about around Thanksgiving dinner. They're both kind of gross. They're both kind of morbid, right? There's all these fluids and blood and stool in both situations. And in both, I would argue that there's a transformation of spirit for both the mother and the baby in birth, for the dying person and the family who's paying attention at the time of watching a person pass away. And lastly, a baby sees a light at the end of the tunnel and goes towards the light, and a dying person does as well. That's a little cliche, but really think about it. What is happening here? Next slide, Ayesha. So I would argue that instead of looking at birth and death, we should actually be focusing on rebirth. And I would conjecture, what if death is the beginning and birth is the end? Now, the beginning of what and the end of what is not the question. But what if we're looking at, next slide, Ayesha, a loop? So another image from Alex Gray here. If you were to continue these rainbow paths from out of the pelvis and into the brain, there's this sort of elliptical movement of whatever we want to call it, prana, chi, energy, whatever it is. There's this cyclical loop. So which direction is that loop going? We don't know. And that's cool. It's cool to not know. I want you guys to really, really embrace that. It's cool to not have the answer. It's fine. Next slide, Ayesha. So what's so scary about dying? Now we're getting into the actual like crux of what I do. You're sitting with a person who's dying. Why is it so scary? It's not so much that we don't know if we're going to heaven or hell. Maybe for some people that's the biggest question. For me, the biggest question is, what is going to happen? Like, what is my actual experience? What is my consciousness experiencing when I go through this? And I would even say that a birthing woman's first confrontation with mortality itself is birth. And if there are any women in the crowd who have had babies, you might be able to feel into that a little bit. Next slide, Ayesha. So let's talk a tiny little bit about near-death experiences. The psychedelic experience is often conveyed in such a way that near-death experiencers are able to relate to, where you find yourself in this pool of light. You're one with all. You are, you're experiencing the unification. You're experiencing the cosmos, etc. And oftentimes, if you've read about near-death experiences, and I'll present a few references here in a couple of slides, what you'll find is that people who have these near-death experiences will say that even though the doctors told them their heart and brain had stopped, that they're able to witness what's going on the operating room table, or what was happening in Ethan's trauma bay, right? And there's something really special about that. And Ayesha, you can advance the slide. When we talk about holistic care, and remember, I do a holistic OB/GYN practice. I'm not just talking mind body. I'm not just talking about eating plants and vegetables and going out and getting grass-fed beef. That's not what wholeness is. Wholeness includes the mind, the body, and the spirit. The spirit would be described in other words as the astral, the mind being the etheric. That's the emotional body. But the spirit is separate from the mind. And we know that through near-death experiences. So we don't know anything, but that's what seems to be emerging. So you can advance the slide, Ayesha. Okay, so this is a great book that a lot of people don't talk about. It's called Return from Tomorrow. George Ritchie is a physician, and he was in the military. While he was in the military, he got super sick, nearly died from pneumonia. Well, he probably clinically did die, but his consciousness took an incredible journey, his spirit, and he came back, and it completely changed his entire framework of life and living. So I recommend this short read. It's like 150 pages. Next slide, Ayesha. Here's some more artwork from Alex Gray. This mural on the left side is actually the mural that he was painting when I met him at Burning Man. And you can see, again, it's this elliptical connection to other people. And this is what near-death experiencers, this is the type of artwork that they're describing through that ineffable experience that you had when you were taking mushrooms out in the woods and you came back and tried to tell your buddy. There's something about that connection that's happening. And perhaps when you have 1 foot in and 1 foot out, perhaps that's actually where you start to find equilibration. There's more of this artwork everywhere online. I saw that somebody, Jason posted Alex Gray's website. He's an incredible artist, and he really helps you relate to it because it's so anatomical and it's almost like that eerie uncanniness about it, where everything is connected in a way that we're not really privy to until we're starting to transition or until we're starting to have a baby, which many women have actually shared this experience with me. So the topic of my presentation today is psychedelics and palliative care. You can advance the slide, Ayesha. Sorry about that. Yeah, that's actually the right slide right there. So what is palliative care? Most people don't learn about this in medical school. We all think palliative care is the person who comes in and somehow craftily gets the person to agree to a do not resuscitate order, or man, this person's not, they're a goner, they're circling the drain, all that language we use. And they want me to come in and convince the family that this person's going to die regardless of whatever interventions we have. So what palliative care does, just in case you don't get a couple good lectures on this, it's symptom management. We're pain, nausea, anxiety, depression, constipation, delirium experts. It's what we do. Now, we're not the pain addiction medicine people, but we're going to be able to craft a cocktail of all of these medications, help eliminate polypharmacy in order to make sure that their life is as livable as possible. We also visit goals of care. Giving chemo or not giving chemo is not the answer. The answer comes from getting to know a person, what their values are, what are their experiences, what gives them fear and trepidation about dying. And only then can we start to craft a plan in order to make their life as livable as possible as they start to approach that transition. And that's when hospice comes into play. That's when you've had a diagnosis that could lead reasonably to the end of their life within 6 months, give or take. And then palliative care is a multidisciplinary approach. The medical stuff that we're all learning in school is one part of it, but the psychosocial elements of disease, that gets into the etheric, and then the spiritual needs, that's in the astral. This is where the money's at, because we don't have many therapeutics for this. And I would actually conjecture, my next question to everybody would be, which of these elements is most needed by a dying person or by a birthing person? So one example of how you might get these priorities twisted is I was in fellowship and I went down to the ICU and a nurse was frantically trying to page me. And I ran down there and she was like, listen, my patient in bed, whatever, 16, she won't take pain medicine. I tried giving it to her. Her parents now don't let me in the room. And I was like, well, let me talk to them a little bit. And it turns out that this is a person of devout Buddhist, Orthodox Buddhist tradition, and she was raised in a schematic in which suffering was an important part of fulfilling her life's purpose. And if I were to detach her from that pain of what we would call suffering, many of us would call suffering, then she wouldn't get to experience the full possibilities of what working through that suffering may offer her on the next iteration when she's reincarnated. The same goes for a birthing person. Many, many women now are trying to have babies at home without having medications pushed on them over and over and over again because they want to be sitting in the experience of giving birth. For those of us who haven't given birth, that might sound crazy, but it's not my concern what's crazy and what's not, what the right approach is. Sometimes what a person needs is actually to have their spiritual needs met before we even start talking about medical, or their psychosocial needs met for that matter. Ayesha, you can move to the next slide. So pain is obviously the first thing that comes to mind when we talk about end of life. And so I am going to focus a little bit on that. But pain comes in a variety of forms. So the physical stuff is what we've all been talking about. It's the nociceptive, neuropathic, bony, inflammatory pain. 4 different types of pain, all treated somewhat differently with a lot of overlap. I'm not going to get into that today. This is not a palliative care lecture. This is a Nathan Riley lecture. So The emotional pain as well, right? That's where we're talking again about the etheric. It's the pain of, I didn't get to say goodbye to my son. He's fighting, you know, overseas or something like that, and he can't make it. What am I going to do? Or I didn't make enough money, or I feel a lack of dignity because somebody has to wipe my butt every time that I drink any water because it comes right out of me, right? There's the emotional pain that comes in palliative care. And then there's the big one for me, which is the existential pain. And that's why you guys putting together these types of conferences is so critical. How do we treat the existential pain? And I'll clarify what that means. Existential pain is the, what am I doing here? What is my purpose? And what's going to happen to me afterwards if I haven't completed that task? And it comes in a whole variety, right? It's another part of what I do is really getting to know a person and trying to read between the lines as to what is really eating Gilbert Grape. It may not just be that they've got, you know, intractable rectal pain. Actually, that might be their third priority. What they might really be distressing about is what is going to happen to me? They were raised in a Baptist household and they're convinced they're going to hell. So if only we could turn back the hands of time, if only we can help them see the reality, which those of you who've been under the influence of some of these therapeutics can relate that, there's something more to the 3D experience we have. And in Aldous Huxley's book, Doors of Perception, he describes the cerebral reducing valve. You take these medications and there's a part of the brain that opens up the floodgates and you're now perceiving everything around you that would have been overwhelming in the general experience of living. And I don't know if somebody talked about the pineal gland and DMT. I don't think we'll ever really come to a conclusion about that. But you would think that, wow, if a person is having this extrasensory experience as they're crossing over, perhaps there's some psychedelic component of death and dying in and of itself. You can go to the next slide, Ayesha. I would be remiss to not mention our good friend Paul here. He's a friend of mine. We've communicated. He and I were working on some studies together. I ended up probably not having the interest in doing a study myself, but he and I have communicated about his stack. I've been giving out his stack to a variety of people for a variety of reasons, not just at end of life, but also for people who have chronic endometriosis. They've got horrible cyclical pelvic pain, fibromyalgia, neuropathic pain that remains after chemo, neuropathic pain that remains after a spinal cord injury. And this stack works, period. They just did a giant sort of, I would call it a phase 1, but it was massive. It was like 20,000 people enrolled in Vancouver. And I'll share the dosages in a second, Jesse. And they enrolled basically all comers who wanted to try low-dose microdosing with psilocybin stacked with lion's mane and niacin. And if you don't know about the stack, psilocybin mushrooms are used. I've noticed people talking about extraction methods. Do you think that nature ever delivers us a chemical packaged perfectly into a biological organism that is going to be as effective as nature constructed the vessel itself? I'm telling you the answer is no, it definitely won't be. It may be good as we're trying to regulate these things in the clinical setting, but Paul recommends using the whole mushroom, which are easy to find, easy to grow. If you know where to go online, it's not illegal. Nothing is illegal about this. You powder them up, you encapsulate 0.1 grams of psilocybin with 25 milligrams of niacin and 500 milligrams of lion's mane. It's too much for one capsule, so you generally have to have 2. The niacin is a vasodilator, and at even low dose, you're going to get an expansion of your blood flow to every tiny, teeny little capillary throughout your entire nervous system, all the way out through the skin. If you triple that dose or quadruple that dose, you'll get a flushing reaction. And that's because you're getting massive blood flow to every extent of the body. And the reason that psilocybin and lion's mane are stacked together is because they work synergistically. So even at a super low dose, which is not going to produce a psychotropic effect, you're actually going to get some benefit that may be super subtle, but if your patient is paying attention to it, it is magical. And it's not psychedelic, it is magical. Jesse, you said 200 milligrams of psilocybin mushrooms. It's 0.1 grams, so 100 milligrams, 500 milligrams lion's mane, and flushing dose, not necessarily. Just make sure it's not nicotinic acid, which is the non-flushing form of niacin, or is it nicotinic acid? Am I saying that right? It's 25 milligrams of niacin. So this has incredible, the indications for this stack are wide-ranging. I would even venture, Magdalena, that it would be useful for people with eating disorders as well. This is a resetting of the nervous system by helping with neurogenesis and helping you get out of that loop. If you imagine an elephant stomping through a jungle, it's going to keep on that path that it's been stomping, right? All that you do by taking some of these therapeutics is you open the possibility that the elephant might actually go off that path and get them out of that stuck loop, right? So what slide are we on this? There we go. Okay. So I would suggest that everybody start looking into the microdosing, which is going to be far more likely to be approved in the near future than doing high doses, even in clinical settings. And I would argue that this is actually a more beneficial treatment to the generalizable population who's battling depression, anxiety, PTSD, you name it. And if you haven't tried it, it is worth experiencing yourself, because you're not going to be communing with the trees, but you're going to relate things like my patients have related back, which are like, I've never had this many good days in a row. 6 weeks is all that really matters. And if you extend it to 12 weeks, then that's great. I would just take a break in between 12 weeks and doing another course. Next slide there, please, Ayesha. So this is an oft sought after book. I was lucky enough to nab a copy on eBay recently. It was like a year ago. When I was in fellowship, I learned about this. This is the great Stan Grof, and a book that is largely not talked about, The Human Encounter with Death. He wrote it with Joan Halifax, and there's a foreword by our good friend Elizabeth Kubler-Ross. And in this book, they highlight all of the experiments they were doing in the 60s before the war on drugs. I'm using air quotes, of course, which kind of pushed psychedelics out of the main lens of our society. But still, the data was so rich in treating existential pain with LSD in particular, was very relevant even to the contemporary literature, like the initial quote that I showed you all the way back at the very beginning. If you guys can find a copy of this book, it is worth every penny. I think I last saw it for like $150. It's not in print anymore. Next slide, please, Ayesha. I also would be remiss if I didn't mention something about other methods of managing some of these nervous system issues, whether it be neuropathic pain or the fibromyalgias or these chronic fatigue syndromes, etc. I know everybody's into Wim Hof. He's a super cool, groovy Iceman guy. If you haven't tried his breath work, you can go to YouTube and find the breath work that everybody's so excited about. There's another type of breath work called effigy. My wife and I did this breath work while we were in labor, and it was as if the portal opened, a baby came out asleep on her chest, and then the portal closed. We had to wake the baby up in order to collect APGAR scores. So the reason I even bring this up is Stan Grof originally started his movement in holotropic breath work because you could achieve the same profundity and experience through breathing that you could even with a moderate dose of LSD. And perhaps you could argue that there were differences or whatever, but at the time, Stan Grof didn't have any option. He wasn't able to give LSD anymore to patients, so he needed to come up with another technique. Wim Hof's is a hypercapnic breathing where you have a breath hold. Effigy is a conscious hyperventilating into the chest for about an hour. And I've used this with patients who have chronic pain. They've got arthritic pain, they've got rheumatoid arthritic pain, they've got chemo-induced neuropathies, diabetic-induced neuropathies, all these sorts of things. And if you have them put their hands in cold water while doing one of these breaths, their opioid use, I've done this myself. I've got like an N of 15. It's probably not worthy of the British Medical Journal, but it's something, where their opioid use drops by like 50 to 60% over the next week. And then they want me to do it with them again. They're like, I don't know what that was that you know, what voodoo you're working on me, but I loved that breath work. Can we do it again? So these are technologies we don't need clinical trials for. We don't need any regulatory bodies to tell us what we can and can't do. You're the doctor. You're training to do something that is going to provide healing to a patient. So it's up to you to figure out, where is my time best spent? And these are cheap, if not free, technologies to help your patients out. Ayesha, next slide. I'm just finishing up here, guys. I've got a couple rhetorical questions that have no great answers. To which specialty does caring for humans fall? Just think about these things. There's no answers, but think about it. This is a human problem. Humans caring for humans. It is not a doctor thing. It is not a nurse thing. It is human beings caring for other human beings. And we need to completely open up our hearts and minds to the possibility that some of these novel therapeutics carry for changing the world, right? Through the lens of humans caring for humans. Next slide, Ayesha. Do we care about the mechanism of action? Who cares if it works, right? Like I don't have I'm a pretty strong, fit guy. I don't have any data to support why lifting 95 pounds on a barbell overhead so many times makes me feel good, but it does. And I look good in the mirror at the end of the day. So I don't need the data to support that. Likewise, I don't need the data to tell me whether or not psilocybin helps a person break through the existential pain of dying, something that they may never have been confronted with since perhaps childbirth. So the mechanism of action is less important to me than the outcome. And we need to actually get around that. We need to really be careful with evidence-based medicine. Just because we don't know the mechanism doesn't mean that the outcomes don't matter. And through publication bias, through major medical journals, Marcia Engel did an expose and got a bunch of heat for it. She was the former New England Journal of Medicine editor. And apart from admitting that Big Pharma was paying them to publish their studies, regardless of how good they were, well they were done, she also, alluded to the fact that like, hey, people don't want to know the outcomes if it doesn't fit in with the mechanisms we already understand. We don't have a mechanism for existential pain. So just bear those things in mind. Next slide, Ayesha. Is dying a medical failure? I forgot to put that slide in there. I was contemplating taking this one out, but this is a whole lecture in and of itself. We don't ever seem to be able to accept that our friend or family or ourself is dying until we've, quote, tried everything. But is that true? Or is dying a privilege and a beginning to some new chapter? If culturally we can wrap our heads around that and get our egos out of the equation, perhaps this conversations around the novel therapeutics like psilocybin, LSD, etc., would be a little bit less confronting to the establishment. Next slide, Ayesha. My last one without my shameless plugging of my websites. And then is a medical approach requisite to a good death? I used quotes here because we don't know what a good death is. Like I said about my Buddhist patient, for her, a good death was feeling through the experience of dying. That was an important part of her dharma. This is what made her life matter. Likewise, for a woman giving birth, I need to feel this. I want to feel my baby coming out. I've been bonding with this baby for 9 months. Why would I want to detach at the very last moment? So for one woman, a good death might be an epidural and a C-section. For another person, it might be a natural birth in a bathtub in their living room. The same goes for death and dying. Some people would want to be on a ventilator, giving it hell until the very, very last moment. And other people would want to be left alone and for their last touches to be through the lens of love and compassion as opposed to violence and futility. And I use those words very liberally because I know that that may be confronting to a lot of people. I don't want to upset anybody. Last slide, Ayesha, please. So this is me with a hat on, and that's my Instagram thing there. And I've got these two websites. I do have a podcast where I talk a lot about these things. It's not just, let's talk about cervical health. It's actually way beyond that. Like, what does it actually mean to be human? And then my practice website is Beloved Holistics. It's a private association. I see patients. I have a collaborator program for med students and doctors of all sorts and health coaches. And so find me there if you guys want to reach out and be friends. I'm always looking for more friends. So thank you so much for having me, everybody. Thanks for organizing this. And if you guys are attending this conference, you guys are the heroes. Like, you're the ones that need to take this information out and to make it matter in the world. So thanks for having me.
Thank you so much, Dr. Riley. That was really a really insightful presentation. I think that what you really said shows us how effective these compounds and even things as far as just getting more in touch with your body through breath work exercises and more can really be useful throughout all stages of life, whether that be young, old, middle-aged people, even those that are approaching death sooner. So we do have a couple of questions for you. One that was submitted in advance is what's the biggest misconception or piece of misinformation that you see perpetuated in today's culture between psychedelics and spiritual experience?
I think that the biggest, I don't want to say that it's erroneous necessarily, but I think that people are too cavalier in describing it as a linear relationship. And I got into this a little bit before, but some people are like, well, just try a tiny little dose or whatever else. And that's fine. That's totally fine. But we're not seeing the same linear relationship. In all the people that I've talked to who've utilized psychedelics, the dose has almost nothing to do with it. Granted, if you take 10 grams of mushrooms, you're going off to outer space, period. Don't get me wrong. But, you know, to think of it as a dose in the same way that we think of, and we're talking about a biological organism here, not extracted psilocybin or synthesized from some company in the UK. We're talking about the whole plant. There's going to be other plans for you if you go in with the idea that you're going to control this experience. So I think that's the biggest, I think, error in, it's not an error in logic, because I understand why it's logical, but I think it's an error because they haven't experienced it themselves.
So that makes sense. You're saying how taking, if someone says, oh, here, take 4 grams of mushrooms, it's not necessarily going to correlate with a more spiritual experience compared
Right.
to if somebody goes into it with a different mindset, different idea of it at 1 gram of mushrooms, for example.
Yeah, that's exactly right. And the same goes for cannabis as well. You know, for one person taking a 5 milligram dose of THC, let's say, they could have one of the most incredible lucid dreams when they go to bed at night, which may change everything for them, versus somebody who's toking up all day long, has no concept of what they're talking about because their CBD receptors have been saturated their whole lives, you know? So the spiritual component of this is separate. And I would always tell people, if you're going to go into this experience, put your expectations aside and you have to surrender to the experience. And as everybody says, go through the door, go up the stairs. The mushrooms are going to show you what you need to see. And I'll also add that you're not adding anything in that's, like, we always think about medicines as adding some external thing. The mushrooms are not psilocybin, LSD, and whatnot. These psychedelic medicines are not adding something to you that is allowing your brain to do something it can't do without them. They're training wheels. So if you're trying to have a spiritual experience, you don't go in saying, I want to meet God. Like, it doesn't work like that. It's too smart. The universe is way too smart for that. It's going to hit you whenever you least expect it. And if you go in thinking, I'm going to do a 2 gram dose because I'm not totally sure if I want to meet God, buckle up.
Yeah, I mean, I guess the universe has weird ways of showing itself and has a plan for everything in that sense.
Yeah.
All right, Dr. Riley. Next up, we have a question. You mentioned how suffering is often associated with the process of life and death and like those natural processes throughout various beliefs and cultures. They asked, would you say that in this sense, the pain can be a spiritual experience and viewed in the same dimension that the spiritual experience with use of psychedelics can be viewed?
That's a good question. So I guess what you're sort of getting at is, for the challenging experience on psychedelics, could that be seen as a kind of a part of the process? Of course, yes. I think that when people say, like, I don't want to do it because I'm going to have a bad trip, I think reframing that culturally is important, because there is no bad trip. There's a challenging experience, and you may take 3 grams or 3.5 grams of mushrooms one time and have a beautiful, you know, you're running around naked in the woods and you're just in love with everything. And then you might take a 3.5 gram of, you know, dose later, and something needs to be confronted this time around. So you're now going to be, you know, you're going to go through the ringer. So I always remind people that the set and setting is important so that you don't have a psychotic breakdown and you don't become traumatized by the experience. I don't even recommend everybody do psychedelics. And that's not even based on comorbidities. It's just that you need to be willing to surrender to the experience, whether you would see it objectively as good or bad. And that surrender is the therapy. That's what people miss out on. It has nothing to do with what you told Roland Griffiths over at Johns Hopkins. the experience you had is actually what's important. And the fact that you were able to lean into the experience, that's actually the therapy. You know, you've allowed your ego to step out of the way in order for you to roll into this experience in a sort of whatever comes, you know, whatever may come is my future. And when the people who resist that, whether it's going to be good or bad, when they resist what experience may befall them, that's actually where the challenge happens, because now they've come out of this thing thinking they were hoodwinked or something. So whether we're doing this in a clinical setting with, I noticed somebody, Jesse, you mentioned how you're going to do the breath work. You described the perfect experience for somebody who's doing MDMA or psilocybin-assisted psychotherapy, where you want to make sure a person feels safe. And if you as a guide, if you're sitting there with them, you're not telling them what's going to happen. You're just providing a little bit of space. And if they can surrender and melt into that experience, that's where the magic happens. I hope that answered your question. That's a big
No,
question.
I mean, it definitely does. I think that what you just said relates a lot to what Dr. Rick Strassman was saying earlier as well. Like a lot of the expectations that people go into experiences like this with aren't necessarily set in stone with what's actually going to be occurring.
Yeah.
So it's just a lot of going into it with an open mind and being prepared to allow whatever's going to happen to happen.
Right.
To follow up on that, we have a couple questions about the statement stack. So I'm not sure if you know, but how does like the ratios of each of the components of this stack, like where did they originate, and like what was the formulation like for that?
I don't know the history of it. Paul had shared that with me years ago, and then he started talking about it in his lectures. And I think that, you know, Paul's a pretty smart guy, and he's like the mushroom expert. I think that he was very thoughtful about how can we really help to synthesize the neurogenic potential of lion's mane, for example, by utilizing the sort of cofactors provided by psilocybin. I think that's how he came up with it. And then the next step was, how can we get this medicine to the tiniest nerve endings? And the only way to do that is to open up capillaries that are only big enough, you know, their luminal diameter is only big enough to allow a single blood cell to pass. So I don't know. I honestly don't know. I wish I did. But you know, it started off with higher doses, and then it turns out that he was seeing the same benefits at lower doses. And that's what I actually started using a higher dose of psilocybin, and then I pared it down based on his recommendation. I was also using 500 milligrams of niacin, which is a full flush. If anybody's ever taken a lot of niacin, whoa, it lights you up, you know? So I realized, well, that's not a great experience for people to have. Like, they may not even be privy to some of the other subtle things that are happening if their skin is on fire for the next 6 hours, you know? So it's a little trial and error. And even on that low dose of niacin, the 25 milligrams, even on that low dose, some people do have an occasional flush during the 6-week course. And by the way, I didn't mention this, but it's 4 days on, 3 days off. You allow your receptors to reset. Your system kind of gets a little recess, and then you go back and do 4 days on, 3 days off. That's the 6-week course. In case anybody's curious about the
Yeah, that was actually the next question, Dr. Riley. The question mentioned how there's all different schedules and regimens for like microdoses and things like this. So they were just wondering what the schedule for the statement stack is specifically. But
yeah, I mean, just
really
like anything. Yeah, if you smoke cigarettes, and you know, I don't recommend anybody smoke cigarettes, but if you're smoking cigarettes, you're going to be up to like 2.5 packs a day after 10, 20 years of smoking it, because your body just doesn't respond. It's the same tachyphylaxis you see with any other chemical substance, that you need to give yourself a little break. And if you're going to get the maximum benefit from that agent, you know, you want to take a couple of days off. And Paul initially told me it was 5 days on, 2 days off, and then he adjusted that, and he recommended 4 days on, 3 days off.
Wow.
So that's what I recommend to everybody if you're going to try it.
Oh, that's great. Thank you so much again, Dr. Riley. I think your presentation really had a lot to offer in terms of spirituality and potentials of both these therapeutics and just really daily life and death, even with psychedelics and spirituality. So thank you again.
My pleasure, everybody. Thank you.
So next up, we have student Dr. Jesse Benzell, who will be wrapping up our day for us. His presentation should actually complement Dr. Riley's very well, because he also hones in a little bit on spirituality. So a little bit about Jesse. Jesse Benzell is a medical student at Rowan School of Osteopathic Medicine in New Jersey. He's in the class of 2023, where he's currently the co-president of ACONP on campus. He holds a bachelor's degree in neuroscience from Tulane University in the class of 2016. And his experience includes research on cognitive neuroscience at Tulane University and the University of Southern California. He loves to teach and has presented an approach to spiritual assessment and care as part of an internal medicine residency curriculum. He enjoys discussion on the intersection of consciousness, belief, science, and medicine through modern and historical lenses. So without further ado, we have Jesse, and you can take it away.
Can you all hear me okay?
Yeah, Jesse, just a heads up. We have like a weird gray box floating around on your slides. It's very small right now, but if it continues, we'll just let you know and we'll see if we can present for you, if that's okay.
Okay, let me just try to adjust that a little bit. I think I can minimize one of them. And do we have one kind of at the top as well?
Nope, gone now. Oh,
okay.
Now we have 3.
Okay, let me stop sharing for one moment and close some of my other applications. I think my computer's just reaching its capacity. One moment here.
All right, no problem.
So we are rolling into our 8th hour of day 1 of our conference. So for any of you who have been with us the whole time, I am both impressed and grateful. And I'm so glad you're on this journey with us. And I'm going to take us home. We're going to get out of this. Okay. So again, my name is Jesse. Oh, let me share. Let's see how this goes. Okay. How's it look now?
Looks good so far.
All right. So my presentation is titled Psychedelics, Spirituality, Depression, and Well-Being in Healthcare. We've talked about a lot today, and I think that this actually is going to do a good job of kind of bringing some of those concepts together and hopefully give us something that we can take home and use day to day. So I have no financial disclosures. I want to give a big special thanks to Magdalene Lederer, Jason Leonardo, Ayesha Gurnani, Victoria Murray, and of course, Dr. King for making this entire conference possible. So we'll be talking about a few things. We're going to talk about spirituality. We're going to talk about the biological basis of the spiritual experience. We're going to explore a psychological model of depression, kind of based off of a Freudian paradigm. We'll expand that out into more modern concepts of spirituality in the context of psychedelics, and wrap it up on the essentials of delivering spiritual care to patients in the clinic. So there's this osteopathic tenet that for my allopathic counterparts may not have heard, but Andrew Taylor Still, the founder of our School of Medicine, has this quote: "The body is a unit. A person is a unit of body, mind, and spirit," which is fantastic. This is what we've been talking about all day, the body, mind, and spirit. It comes together, it makes one thing, but we're still talking about 3 things. So are we one thing or are we 3 things? It's kind of similar to the philosophical religious situation of the Holy Trinity in Christianity, where you have the Father, Son, and Holy Ghost coming together to form God. It's 3 things, but it's one thing. So this is just something to contemplate, and I think we'll get to revisit this at the end. So what is spirituality? I cannot tell you exactly what spirituality is. Everyone has their own version of a spiritual experience, has their own version of religion. There's organized religion, there's personal religion. But here's some ideas about how spirituality, we might perceive it. Is it a representation of reality? Is it being kind to our neighbors? Is it part of our identity? Is it a biological function? Does my brain generate spiritual experiences for some sort of physiological purpose? Is it just mindfulness? Is it just being aware of myself and my surroundings? Is it supernatural? Are we talking about magic? Are we talking about something metaphysical that can never be described within the scientific model? So spirituality is a huge concept, and it's really up to you. It's up to each individual to define their relationship with the spiritual. But I think we can agree that spirituality has cognitive factors, experiential factors, behavioral factors, and emotional factors. So Michael Pollan has this quote, "The opposite of spiritual is egotistical." Okay, so for the purpose of this presentation, I just want us to kind of, for a moment, operationalize spirituality using this definition, accepting that we all have different faiths and whatnot. Let's just play along for a minute, that the opposite of spiritual is egotistical. So does that mean that the spiritual is in fact based on an ecological perspective, an egotistical perspective? So in this egotistical perspective, we are not the center of the universe being served or harmed by things around us. We are not at the top of the pyramid, but rather in the midst of it. We're all mixed up. We're in this giant fluxing washing machine of life, and it's not really clear who's the winner or the loser. If things are right or wrong, things are just kind of happening and we're a part of it, right? And this is a legitimate way of viewing the world. I'm not saying it's the absolutely correct way of viewing the world, but it is an approach. And I think that in this ecological perspective, something that's very important is the concept of multiplicity of subjects. So I start recognizing that my point of view is not the only one that exists. My friends and family all have their own point of views, and maybe all other beings and matter have their own perspective from their position in the world. There's an interconnectedness. Everything is related. Things cannot exist without each other, or in reference, or in contrast, or in comparison. And I think that at the root of all of this is empathy. The second that I begin to recognize that someone else has a perspective that exists, forget on if I believe it's valid or valuable, the second that I believe someone else has a perspective, I am experiencing empathy, okay? So just kind of pull that string together. The opposite of spiritual is egotistical. Therefore, spirituality is an ecological perspective. An ecological perspective is based on a multiplicity of perspectives, and understanding it and experiencing a multiplicity of perspectives is the fundamental core of empathy. Okay, so now we've gotten to this point that spirituality and empathy might be close to the same thing. So how does spirituality affect mental health? Here's some statistics from a nice paper. Mental health. In the USA, more than 80% of individuals with mental disorders turn to spirituality to cope. In addiction and behavior, although it remains controversial as to whether spiritual components of Alcoholics Anonymous and other 12-step approaches are essential, these programs are associated with more than half of all reported recoveries, right? So the Alcoholics Anonymous and 12-step approaches have a spiritual component, and people debate whether that spiritual component is essential, but it's still the best programs that we have available to people suffering from addiction. Suicide. In one study of nearly 90,000 American women, weekly religious service attendance predicted a 5 times reduction in suicide, even after controlling for depression, major life stressors, and social activity. In one study, more than 40% of pre-treatment suicidality could be accounted for by spiritual struggles, particularly those relating to God. And on the subject of delusions, spirituality can co-opt the presentation of psychotic and obsessive symptoms, which complicates treatment. If someone is performing a religious ritual that I don't understand, it might just look like an obsessive compulsive disorder. So humbling ourselves and allowing ourselves to understand other people's perspective, very important for respecting their experience. How about on physical health? This is a study on religiosity and spirituality and the physiological markers of health. And here we find that religiosity and spirituality actually has an effect size of negative 0.42 for myocardial infarction risk markers. And this fail-safe N, for those of you who are not particularly statistically savvy like myself, my understanding of this number, the fail-safe N, is the number of subjects that would have to be included in research that shows zero effect in order for this effect size to be nullified. Okay, so we would have to have another 45,000 patients who did not have a reduction in cardiac risk markers to suggest that this finding is not true. So religiosity, spirituality, I'm not telling anyone to go and practice a faith, but it seems to be good for your heart if you have some sort of religious or spiritual practice, or at least belief. And please don't take this as me pushing religion on anyone, but this is the data. Okay, and let's tie this back into empathy. This is one of my favorite papers ever, very highly cited, Physicians' Empathy and Clinical Outcomes for Diabetic Patients. Does it matter if I, as a doctor, am demonstrating and using empathy? So they had about 900 diabetic patients, about 30 family physicians, and they're going to measure hemoglobin A1C, which is a measure of blood sugar control, and they're going to measure LDL-C, which is a measure of poor lipid control, kind of one of these risk factors for atherosclerosis and obesity. These are big picture of the metabolic syndrome, responsible for a lot of morbidity and mortality. So then what they did was they split the physicians, and they had the physicians fill out a scale called the Jefferson Scale of Empathy. And based on this Jefferson Scale of Empathy, the physicians were lumped as high, moderate, or low empathy scorers. And it was proven statistically significantly that physicians in the high empathy group had much better control of these physiologic markers than the patients of the low empathy physicians. We're talking about 56% being well controlled versus 40% being well controlled for hemoglobin A1C, and 59% versus 44% for LDL. So that's a 15% swing on hemoglobin control from good control to not good control. So this is a big difference. There was no control of who received what medications, who was instructed on what kind of diet and lifestyle. This was literally just based on how much empathy do these physicians have. And this is the scale that we measured empathy on in this study. And I'm going to read these out loud because I think they're so important. My patients feel better when I understand their feelings. And physicians were asked to rate these statements as true or meaningful, or that they believe in this statement on a scale of 1 to whatever. My patients feel better when I understand their feelings. I consider understanding my patient's body language as important as verbal communication in caregiver-patient relationships. I have a good sense of humor that I think contributes to a better clinical outcome. I try to imagine myself in patients' shoes when providing care to them. My patients value my understanding of their feelings, which is therapeutic in its own right. I try to understand what is going on in my patients' minds by paying attention to their nonverbal cues and body language. Empathy is a therapeutic skill without which my success in treatment is limited. An important component of the relationship with my patients is my understanding of their emotional status as well as that of their families. I try to think like my patients in order to better render care. I believe that empathy is an important therapeutic factor in medical or surgical treatment. There's a lot here, but I think you're getting the picture. Physicians who believe that this is true have better outcomes for their patients. So even if you think of yourself as the physician or the practitioner who, I just get results, I don't deal with that fluffy stuff. If you care about results, you have to care about this fluffy stuff. This is a mechanism of delivering those results to your patients. And I hope that y'all were able to read this while I was talking. Okay. So the biological basis of spiritual experience. People have been experiencing mystical experience, prophecy, altered states of consciousness from the dawn of humankind. And this paper explores whether or not there are focal regions in the brain that correlate to spirituality and religiosity. And they found that brain lesions were associated with self-reported spirituality mapped to a brain circuit centered on the periaqueductal gray. Intersection of lesion locations within this same circuit aligned with self-reported religiosity in an independent data set and previous reports of lesions associated with hyperreligiosity. Lesion locations causing delusions in alien limb syndrome are also intersected with this circuit. So I think this is where it becomes a little kind of funny, is that we have people talking about their spiritual experiences and people talking about delusions and alien limb syndrome, which is very distressing, in the same situation, coming from the same part of the brain. And you can see that lesions here, here, and here can impair your ability to have spiritual experiences, probably also reduce hallucinations and delusions, and vice versa with these green regions, increasing spirituality. Okay, so how can we connect spirituality as this broad cognitive concept to actual patient care and what we've been talking about all day with psychedelics, creating certain kinds of experiences? How does this all come together? So Sigmund Freud, let's not get into debating you know, where the man and the myth begins and whether we love him or hate him. Regardless, he wrote an excellent piece of literature titled Mourning and Melancholia. And here we have some little portraits of him by Salvador Dali, which I think are fantastic. But this, everyone is basically aware of Freud's model of the id, superego, and ego. But not everyone is as familiar with his kind of concept of what I will call an emotional economy. Okay, so what is this emotional economy about? The emotional economy is that I invest my psychic energy or libido in, you know, things, both physical and abstract, and those things nourish and sustain me, okay? And when those things don't nourish and sustain me, I am sad and I have distress, okay? Works the same as finances. If you invest in a stock and that stock does not pay you dividends and the stock's value decreases, you lose money and you feel bad, okay? Same concept here. So he compares mourning and melancholia, which in more modern terms, we would use terms like grief and depression. And in mourning, we have a physiological passage where we have investment of libido into a new love object. I just met my new girlfriend and she makes me feel amazing. I'm appreciating the love object. You know, we go out for nice dinners, we have a good time. And then there's loss of the love object. Maybe we break up or a tragedy occurs. And then I have to change. I have to be able to withdraw my libido from this love object that is no longer able to give me emotional dividends. And this occurs through the process of reality testing, where I reach out psychologically to this object and get nothing back. And I realize slowly over time that this object is no longer available to me to provide nourishment, and I withdraw my libido from it, and then I gradually invest that libido elsewhere, okay, and start new relationship. Okay, this is the healthy cycle of grieving, and this can happen in death. This can happen in so many forms. And now let's contrast with what Freud proposes as the model of depression, where a few things happen at the same time. So first of all, we have this thing, the narcissistically valued love object, which is, I don't love this person or this animal or this job or whatever it is because of some goodness in my heart, but I love it because it does something for me. It makes me look cool. It makes me feel better about myself. There's like a very explicit awareness of the dividends. In this healthy cycle, the dividends are appreciated and enjoyed, but it's not like this give and take where I give you 5 and you give me 6 and now I'm happy. This is like, I'm giving you 5 and you're giving me 5, and that's a fair deal. I'm not really, it's less selfless, it's more selfish. And along with this comes an awareness of frustration, that if I'm only interacting with other people as to serve myself, well, that's not a really pure love. That's not like a really good way to interact with people. And maybe I'm not capable of producing a more authentic or beautiful love. From that same sense, there's a development of ambivalence towards the love object. Maybe that object is only using me in the same way. Maybe I could find a love object that gives me more satisfaction. So it's not even a full investment of libido into the love object. It's kind of half-hearted. And then with this half-hearted investment, we also have an inability to withdraw the libido, right? So we've got one foot in the door and it's wedged. We can't quite pull it out either. We're not in the room, we're not out of the room. And this results in the libido being frozen. It's not available for investment, okay? Because there's this concept that if my love is kind of crummy, I shouldn't bother anybody by sharing it with them because it's only going to let them down. So there's an absolute frustration with the limitations of the ego. Okay. So spiritually and psychologically, depression may be confrontation with the limitations and inevitable frustrations of the ego and the love that it's capable of generating. So for contrast here, we have the ego-centered love and the authentic love. And one of my favorite things to do when I meet someone is I ask them, you know, what do you think love is? What do you experience when you're in love? How do you know you're in love? And I've gotten so many different answers, but one of my favorites, and one that I actually think might be true, is that there's lots of kinds of love. Love is like a fire, okay? You can have a fire that's in a fireplace and you come home to it at the end of a long day and you warm up and it protects you from the elements and it's very cozy and a bit tame. Or you can have love that's like a burning apartment building, a towering inferno, and there's people jumping out of the windows, but oh my God, is it hot? Okay, so we can have all these different kinds of love. I think what we're talking about when we start talking about this authentic love, or the opposite of this ego-centered love, is to almost think of the fire that is the sun. Okay, the sun burns really hot, but it's also really far away. It's totally indifferent to our personal lives and what happens on the day-to-day. It's a big love that's not coming from me because I don't really matter on the scale of the sun. The sun will burn long before and long after I'm dead. But it's still some sort of power that I can tap into and sustains my life and the world around me. So again, we're talking about the ego-based love versus the ecological-based love. The eco-love is this kind of solar love, if you will. And to just kind of connect this for a bit of fun, if anyone here is a fan of physics, I kind of think about this in the same way that people talk about the particle wave duality of light, where light can be described as a particle, where it's a discrete object that interacts with things but bounces off of them, or you can have it as a wave, and the wave kind of flows and has a gradient and interacts more fluidly. And they're both true. They're both accurate ways of describing the universe. And I think what's happening in depression is that we're getting stuck in this egocentric perspective. We're getting stuck in this particle-based perspective. And if we can help that patient see an ecological or a wave-based or a solar love and realize that they're able to tap into that, maybe we can heal them, or help them heal themselves, rather. The patient is always the center of wisdom and healing. The physician facilitates that and tries to remove obstacles. So the dynamism and flexibility in perspective is part of what allows spiritual feelings to facilitate healing. So this shift in perspective, right, the ecological perspective, we're able to transform the concept of death and loss to discovery and availability. Isolation and loneliness can be shifted towards solitude and immersion. Dissatisfaction and desire can be shifted towards acceptance and appreciation. Power and responsibility can be shifted towards something like surrender and comfort. And these aren't supposed to be exactly antonyms, but you can imagine how different people in the same situation could experience either of these emotional sets. Okay, so here's our model, okay, of depression. We have someone who they hate themselves because their ego is only capable of generating selfish love, that they really shouldn't bother investing in anybody else because it's only going to do harm. So they develop an avoidant behavior and posture. They're isolating, they're curled up, they've got the upper crust syndrome. Maybe some of you learned about that in O&M class, and chronic pain and inflammation. But what if we can break that cycle, okay? We dissolve that cycle and we add a new element. What if we use psychedelics to add a new element above this ego, all right? And we allow this patient, even briefly, to experience an ecologically centered identity, okay? In this ecological centered identity, judgment dissolves, right? From the ecological perspective, it's not like the fox is the villain and the rabbit is the hero. It's they're just both trying to survive. And in that same way, the patient can forgive themselves. So suddenly they respect themselves as part of a larger system. When they start respecting themselves, maybe they're able to make successful love investments. Their libido is no longer frozen and becomes available to connect. They change the way they move and sit and hold themselves. This reduces pain and inflammation and results in rewarding environmental engagement. And suddenly we've transformed things into a cycle of health, which was really the goal all along. So this is a fascinating paper. We talk about mystical experiences, and we can debate all day what a mystical experience is. Is it the prophetic vision as described by Dr. Strassman? Is it the dissolution of ego described by others? I'm pretty sure, I think most of us would agree if someone comes to you and says, I met God, you would say that was a spiritual experience, that was a mystical experience. So just based on that, we can see that individuals who, this was a survey of individuals who report having met God. Some of them were on psychedelics at the time, some of them were not. Okay, so we call this the endogenous the endogenous mystical experience and the exogenous mystical experience. And you will see that they rate their experiences very similarly, okay? The psychedelic mystical experience is legitimate. It is meaningful, it is powerful. And if our goal is to help a patient experience that, I think psychedelics are a good choice, of course, with proper screening, contraindication, safety, set and setting, everything we can do to make it as safe and responsible and ethical as possible. If we think that their depression is this kind of psychological depression, as opposed to a more biological depression, like there's an explicit brain lesion that prevents them from experiencing joy, if it's more of this perspective-based depression, I think psychedelics are gonna do them a lot of good. But psychedelics aren't available to me today when I'm going through my rotations in the hospital. How can I provide spiritual care to my patients today? And the answer is through those empathy tools that we discussed before, and also through this, what's called the HOPE questionnaire. So people have addressed this many times. Obviously, you can always put in a consult to the chaplain service at your hospital, and you should. but I'll just read this one. So this HOPE questionnaire, you help the patient identify with their endogenous spiritual capabilities by identifying sources of hope, helping them foster any of their potential relationships with organized or personal religion, and then start a discussion about how their medical situation interacts with those values and beliefs, right? Are there certain medical procedures that you do or do not want done? Are there certain, due to your belief system, and vice versa, do you have certain spiritual or religious goals that you are medically unable to achieve that we should be focusing on? For example, you want to be in a certain kind of posture while you pray. Oh, well, then we should really focus on your back pain so that you can achieve that posture, because that's what you care about. Okay, so it's the same goals of care we've always been talking about. And I love this one. Honestly, if you could ask one patient, if you do one thing, ask your patients this: what are your sources of hope, strength, comfort, and peace? What do you hold on to during difficult times? When you ask patients this, it is amazing the light that comes on in their eyes, because they will start talking about their families. They will start talking about what they think is the most important thing in their life. And it's incredibly comforting to them. It's incredibly rewarding as a practitioner. One of the biggest obstacles we face is burnout, which is how can I deliver meaningful care to people in this meat grinder of a medical system where people come in, they get chewed up and spit out. This gives you a moment to really connect with people on a very, very personal, almost a soul-to-soul connection. And it's really beautiful, and I recommend you do it for their benefit and your own. 94% of hospitalized patients believe spiritual health is as important as physical health. Patients care about this. Do not talk to me about goals of care if you're not talking to the patient about what they think life's about, what the purpose of their life is about, okay? And what they really care about. Okay. And this is evidence-based to do this. So here's the conclusions. Let's pull it all together. It's been a long day. Spirituality has biological correlates and may be considered functionally similar to empathy. Okay? Empathy may be correlated to patient benefit. Spirituality may play a protective role in several aspects of health and is a meaningful component of patient lives that deserves attention and respect. Meaningful spiritual experiences can occur endogenously, like spontaneously through behavioral practices like deep breathing or active breath work. And meaningful spiritual experiences can occur exogenously, such as through the use of psychedelic substances. Spiritual interventions may be indicated in the treatment of psychological depression. Straightforward tools like the HOPE questionnaire can help physicians meaningfully engage with their patients. The psychological benefit of psychedelics may occur through activation of spiritual experiences, which allow for healing of self-perception with behavioral and social cascade of positive effects. My citations, which we will distribute. A lot of the citations we're going to distribute through an email to all of our guests. Thank you so much. I'd love for each and all of you to contact me, Benzell93@Rowan.edu, spelled in the email with one L, but in real life I spelled it with two. And I'll stop sharing my screen.
Wow, thank you so much, Jesse. I feel like just as I said for Dr. Riley's as well, it really just shows how important that spirituality component of this whole idea around psychedelics actually is. I mean, just as one of your slides said, the spiritual health and actual mental and like body health is just as important as one another, and we see 94% of people say that.
It's what people care about.
Exactly.
Almost by definition, if you care about it, that almost makes it a spiritual thing. So it's almost a circular logic on that, but that makes it all the more meaningful.
No, definitely. I 100% agree with you. We do have a number of questions lined up for you, Jesse.
Bring them on. Let's go.
The first one is, can you please share about your interest in the field and how you got involved with various activities that help enrich interests, especially during med school?
Sure. So, it kind of all happened for me at the end of middle school. I went to summer camp for the first time. I had a really powerful experience. I felt like I really changed as a person, and in an almost joking way, I was like the bunk psychiatrist. People would come to me with problems, and I would use my pseudo wisdom from TV and movies to offer completely reckless advice. Since then, I've matured a great deal, I hope. Um, and one of my best friends that I met there, I actually learned had attempted suicide just a month before I met them. And this is a person who I thought was so wonderful and changed my life so much for the better, and still does. And so that was kind of the first time I started caring about mental health. I was like, wow, I almost did not meet this person. And for totally selfish reasons, like, I need this person in my life. They're so amazing. We got to do more about mental health. And then through high school, I saw a lot of my friends struggle with eating disorders, depression, bipolar. And at the same time in high school, I was assigned a project. Everyone got assigned a decade. I got assigned the 60s. And I started learning about the hippie movement. And I learned that science and medicine really believed that psychedelics were going to do for psychology what the microscope did for biology. And that kind of sparked my interest, and I saw some interesting YouTube videos of there's one of a housewife taking LSD, and she describes how beautiful the experience is. That kind of sparked my interest even further. So in college, I studied neuroscience, got more involved with mental health, and decided to come to medical school explicitly with the dream and goal of helping this field develop in an ethical, responsible way. That's, not just respectful to our culture, in Western society, but like respects the roots and kind of doesn't take advantage of anybody. So that's kind of why I came to medical school, was to help this field. And I've had people the whole time tell me, don't talk about psychedelics, you're going to get kicked out. You'll never get accepted to medical school. And in all honesty, the applications I put out that I put psychedelics on the essay, I did not get interviews. So it has been a tightrope to walk. But it's been the most important thing I've done, I think. So.
No, I mean, for sure, like you're saying, how you put it on your applications, and unfortunately you didn't get interviews there. It all comes down to the stigma that even researchers now are still fighting 3 years later, 4 years later. And I feel like it's along the lines of the same backlash and destigmatization that researchers had fought with medical marijuana when those studies were first coming out.
I really do believe, though, the science will bear this out as good medicine.
Absolutely.
And there's this one quote, I can't recall who said it, but it might have been Robin Carhart Harris, that essentially drawing a line between penicillin was one of the greatest discoveries in internal medicine, and it comes from a mushroom. And I wonder if psilocybin is almost the penicillin for the mind. Obviously, it's not that straightforward, but I like the idea that you can actually treat the idea of like a kind of root or an infection, and remove that obstacle that's in the way of health.
No, that's definitely an incredible quote. And I mean, your personal experience with friends and others close by that have had mental health issues, and you've seen this on a personal level, and I guess you can say it was kind of ingrained in you from a young age that you needed to go this path to not only help them, but help people in the future.
Absolutely. And the greatest irony of psychedelic medicine, I think, is that these things have been used across the globe for thousands of years in different cultures and cults and whatnot. The idea of them being totally taboo and the idea of them being totally, contraband is very recent and like a very jarring contrast to how humans have used psychedelics throughout our development. And that's probably a whole nother conversation, is the role of psychedelics in the development of human civilization. But
That's a conference for a different day.
that's next week, everyone. We'll get there.
All right, Jesse. So for the next question, you mentioned how spirituality and religion can even be beneficial to your heart. And then you mentioned how spirituality can be just as important as physical health. Do you feel that the psychedelic experience could, in theory, in the future, prove to also be beneficial for not just mental, but also physical health?
So we were talking about like that kind of the trinity, the mind, body, and spirit. Absolutely. Any gain in any of those systems will facilitate the others. So definitely, yes. And I think it's very interesting, like nobody knows why those spirituality and religiosity markers correlate to some of those improvements in health markers. One thing that was interesting was that it actually had a positive trend with BMI, which in America, maybe not a good thing, but in a lot of cultures, maybe a good thing, probably because people come together and eat as a big part of a lot of different religious practices. So yeah, it's definitely very interesting. And I think there's potential for overlap. Sure. Because, well, let me answer it this way. I think injuries can arise on a spectrum of subtle to physical levels, right? The most physical being, I was hit by a bus, I need a doctor to sew me back together or I'm going to die. Okay, I cannot meditate through that. Okay, I will die. On the opposite side of that, if I'm having a spiritual crisis and I'm having existential pain, I don't think there's a surgery that can fix that. Certainly not ethically. So you have to recognize where is the disease emerging and try to treat it at that level. And that's why I try to make the distinction between a biological depression and a psychological depression, which I think deserves a lot more research and investigation.
No, I mean, definitely. I couldn't have said it better myself. Just like you said, how that existential pain can actually come about into actual physical pain. It's almost like a somatic system disorder where there is no real, like, plausible reason why they are in pain, but their subconscious is creating that real pain within them.
Yeah, I mean, just because you can't see it on an X-ray, just because you can't put it in a test tube, doesn't mean it doesn't exist. It might just be a limitation of technology, and it might just be one of those problems where, you know, we don't really know where consciousness interacts with the physical plane. That's it's called the hard question. No one has an answer for it. But I think psychedelics, I think a big part of their functional effect is at that intersection.
No, definitely. Like I said, couldn't agree more with you. All right, Jesse, we're gonna get one more quick question in, and then we'll
wrap up.
Yep, we'll wrap up. All right, so the next question is, how can uncomfortable psychedelic experiences or bad trips be utilized to bring awareness to the dissonance between ego-based and ego-based love?
So I think that when people are coming from ego-based love, they can cause a lot of harm in their environment. And during a psychedelic trip, feelings of guilt and shame can be very prominent. And I think that, you know, if there is morality, and I think there is, if there is a difference between right and wrong and doing good or bad in the world, then I think that we have to be able to reflect and hold ourselves accountable. And it's very easy to just chug along and not think about the people we're stepping on. And when you take a psychedelic, sometimes suddenly you turn around and you see a way ahead of you, way above you, way below you, and you see behind you a lot of people you stepped on. And we're all guilty of it to different extents. So I think coming to terms with that is important. And I think the difference between a traumatizing, painful, and injurious experience is if that person gets stuck on the retrospective and stuck in the perspective of shame. If they can somehow facilitate, okay, I've made those mistakes in the past, what can I do now? What can I do tomorrow to right those wrongs or to prevent those bad things from happening again? Then it can serve as fuel and motivation and really a galvanization of the individual's commitment to be the best that they can be.
All right. Thank you, Jesse. That's great, actually. All right. So thank you again, Jesse. That was very insightful and a great compliment to Dr. Riley's presentation.
My pleasure.
I wanted to thank everybody who stuck with us all day and came out for any and all presentations today. We hope it was just as informative for you as it was for us. All of the speakers we've heard from today did an excellent job and all had something incredible to offer. Just as a reminder, please fill out the sign-in form, which we've posted in the chat. Tomorrow morning, we'll be starting at 10:30 a.m. We'll have 3 professional speakers followed by a poster session. We hope to see you all then.
And I just want to put in the reminder that the first portion will be active breath work for about 20 minutes. It's a very beautiful experience. So comfortable, dark space, eye shades, maybe earbuds if you can. A place to lay down would be optimal. But we love to have you even if you can't have the perfect environment. So we'll see you tomorrow morning. Thank you so much.
Thank you, guys.
Good night.